हाँ वीडियो यार. Maratha Warriors at 20 points. Next is Gujarat Bloom Stars at 40 points. Their cheerleaders. And River Wheels again at 20 points. So we are going to go to round 2, and this round 2 is going to be conducted by Dr. Neeraj. या माइक फॉरस करूंगे. यहाँ से मिनिमाइज होता है क्या? हाँ.
The folder could have please.
Round 2.
ये NPL का फोल्डर, उसमें का राउंड 2.
Round 2 sir.
हाँ राउंड 2.
Full screen.
Show me now ये प्रेजेंटेशन. पॉइंटर नहीं, प्रेजेंटर पाहिजे आपल्याला.
लेफ्ट राइट.
ठीक है. Pointer नहीं है.
हाँ ये.
So I will be conducting round 2, which is a power play, and the rules of the round 2 include image will be displayed, and it is a spot diagnosis. You need to identify the condition or the disease associated with it. The correct answer will fetch you 20 points, and incorrect answer will deduct your 10 points. There is no passing, but the next team can guess the answer since the one option is eliminated by the primary team, and you need to answer within 15 seconds. So Shiradonkar sir will keep the timing. 15 seconds is the timing. It is a spot diagnosis, so you have to fetch the clinical diagnosis. Correct answer 20 points, incorrect answer minus 10 points. And we will start with our first question. Team A, Maratha Warriors.
Emphysematous pyelonephritis.
Yes, that is absolutely right answer. We can see the air inside the right kidney in this contrast CT picture. Next question. Next question is for Gujarat Gloms. Shiradonkar sir, time. Last 5 seconds.
Membranous nephropathy.
Yes, please.
Membranous nephropathy.
That is an incorrect answer. Any guesses from Team Vidarbha Veers first? Yeah. Yes, Maratha Warriors.
Dense deposit disease.
It's a dense deposit disease. Osmophilic basement membrane on the electron microscopy.
Neeraj, at the end of question you get points.
Yeah.
This question had minus 10 points
Points.
and no point to
Any other team.
Minus 10 to Gujarat Bloom Stars.
So next question is for. Okay. Full screen. Okay, this is an osmophilic transformation of the basement membrane. Next question. Sorry. So this is an immunofluorescence image for Vidarbha Veers. I can give clue that this is an IgG immunoglobulin.
Anti-GBM?
Yes, that's absolutely right answer, and gives 20 points to Vidarbha Veers. Coming on to the next question for Maratha Warriors.
Yeah. This is the wall bladder. PU wall associated with this Christmas tree appearance of the bladder. Obstructive uropathy due to bladder outlet obstruction and Christmas tree appearance of the bladder.
Okay. Partially correct, but this is more of a neurogenic bladder and
Pine tree.
classical appearance of a pine tree appearance. I request sir to decide whether to fetch. Right answer fetches 20 points. Wrong answer is -10. Yes. ठीक है, obstructive. So we'll give +20 to Maratha Warriors. Next question is for Gujarat Gloms. 20 seconds, 15 seconds. City IVU.
I don't have process.
Yeah. Guess Maratha Veers. Oh, sorry, Vidarbha Veers. This is a CT IVU.
Medullary calcification.
Yeah, you are on right track. This is a medullary sponge kidney and the classical appearance. And the next question is for Vidarbha Veers.
Xanthogranulomatous.
That's an right answer. This is a xanthogranulomatous pyelonephritis. So gives 20 plus points to Vidarbha Veers. And one question for audience. Do we have any chocolate? No. Okay, so
Only
you will
applause.
be rewarded afterwards.
Only applause.
That's an easy one. Anyone? That's
Hero graft.
right. It is hero graft, hemodialysis, reliable outflow. So moving on to third round, I request Sachin sir to continue it. Can we have scores, please?
So Maratha Warriors at the end of second round, 60 points.
So Maratha Warriors had 60 points.
Gujarat Globstars, so they started really well as like a initial openers, but now they are at point 20.
20 points,
And Vidarbha Veer again at point 60.
60 points, so tough fight. So don't worry, there are a lot of scoring opportunities. Even the team which is at 20 can go up to 200. So lot of scoring opportunities, the rounds are designed in that way. So we go to next round, third round. So this will be probably the most interesting round for you all. And to be fair to all teams, this time we will start with team Gujarat Glomstars, so that there is no feeling that somebody got easy or this is a random starting, you can say. So identify the condition, a description will be given. So you don't need to apply your clinical, and now you don't need to remember amino acids or other things. This is a clinical and knowledge based. Maybe you can apply your WhatsApp knowledge also. A description will be given. Identify the condition, disease or drug this description best fits. And this may include a trade name of the drugs also. Okay? Not only the molecule. It can be a molecule, it can be a trade name, it can be a disease condition, disease, anything. Correct answer is 20 points, no negative marking, and it is a passing round. Okay, so the question can pass to next team, answer in 30 seconds, and passing team, if the question gets passed, will get 10 points and not 20 points. Okay? So, first question to Gujarat Glomstar team is bones, stones, moans and abdominal groans.
Primary hyperparathyroidism.
Yes, that is the correct answer, 20 points. Be attentive, Vidarbha. From congested traffic areas to dry zones with frequent peas, his journey lasted 6 hours. 30 seconds time, huh? Shekhar?
Furosemide.
Yes, that is the correct answer. It's a Lasix. Next question to Maharashtra. Slightly difficult, but still it is crackable. Next is love Jadu's fuel, resurgence in tube, and make bone stronger. Remember Jadu from Koi Mil Gaya?
Vitamin D.
Vitamin D, yes, that is the right answer. So now real test starts. Gujarat Globe Stars, be ready. From Leaning Tower of Pisa to Eiffel, he travelled via city of Taj. 30 seconds, Shekhar. From Leaning Tower of Pisa to Eiffel, he travelled via city of Taj. Once the answer is displayed, I am sure audience will also love it. Time over? So when question gets passed, there is no, you have to answer immediately. You don't have 30 seconds. So anyone passed? Anyone Maratha warriors? You want to guess? I think Khetan sir guessed it. It is Viagra. So now you put everything in perspective. From Leaning Tower of Pisa to Eiffel via city of Taj. So, yeah, now I think the next question is to Vidar Pierce, isn't it? While running circuitously behind the hen, his pot got exhausted and he had nothing to offer in exchange. Focus on each word. Running circuitously behind hen, his pot got emptied and he had nothing to offer in exchange. Time?
Loop up.
That is not the correct answer. You put everything in perspective. It is, as I said, it is either disease condition, stop. Pass to Maratha warriors. You need to answer immediately if you are ready. Get past Gujarat Globe Stars. So before I display the answer, running circuitously behind the hen, you guessed it correct, it was Lupa Henley. His pot got exhausted, that his potassium got depleted, and he had nothing to offer in exchange. What is that term? It is called as barter. So whenever you offer something in exchange, it is barter. So this is barter syndrome. So that's why it is called Googlies. I think last two rounds nobody has received any points, isn't it? Okay. So the last question, again focus on words. So initial round, easy round was given for you to understand the format. Sorry. So it got displayed. I think I have, do I have one more? No, I think burgeoned it. I don't have extra question. So anyway, nobody scored point in this, so it is my apology, but still this was the question. Annoyed by bubbly ride, threatening red berries and past tense. So that was meant by bubbly ride is cyst, threatening red berries was berries aneurysm, and past tense is a family history. He decided not to reproduce to stop this nonsense. So that was ADPKD. I am sorry if I have taken your opportunity from you. So these were created by me. Please help करो इसको. मुझे आता नहीं iPad ये थोड़ा Mac handle करना. Next round. So can we have scores if we are updated?
So at the end of round 3, 80 points for Maratha Warriors.
माइक दे सकते सर को? सर को दो माइक. तुम
80
चला
points for
सकते?
Maratha Warriors.
Cheer leaders.
40 Gujarat and Vidarbha Veer set also 80 points.
So 80 points to Maratha Warriors, Gujarat Globe Stars at yes, Maratha Warriors cheerleaders. 80 points. Next, can you play Gujarat Globe Stars? We have time to play these cheerleaders. Gujarat cheerleader at 40 points. Then Vidar Veers. You play their video a little longer because their names get displayed later. Yes. Vidar Veers. So you can stop this. Now next round is boundary ke bahar. You can presume that this is a completely WhatsApp round. Emoji will be shown. Identify the drug. Okay. It can be a generic name or popular trade name, and it's a buzzer round. Answer within 10 seconds. Correct answer gives you plus 20. Incorrect answer is minus 10, and there is no passing. Can we have test? See, when you press the buzzer, all the names will get displayed, but at the end, the team which press the buzzer first will get displayed here. So let's have a testing. No, it gets displayed. Is it the final answer now, team? So it was the number 3 team. So it is getting displayed here. There is audience to decide. So initially everyone's like all 3 will come. Then the system gets reset to 0, and the team which pressed buzzer first gets displayed. Are you right? Okay. So be ready. This is a buzzer round. Plus 20. Incorrect answer is minus 10. So don't bluff. So number 2, Gujarat Glom Star, answer.
Penicillin.
Yes, that is the correct answer. Plus 20 to Gujarat Glom Stars. So next is getting displayed. So pain is chilling, that is a penicillin. Next question.
TG cycling.
TG cycling. TG cycling, okay, you are right. So goes to Gujarat Glom Stars, number 2. So be ready with your buzzers. Gujarat Glom Stars is catching up. Next. Team number 1. Team number 1. Micah Panjin is the correct answer. So that's what I said. All numbers will get displayed, but finally the team which press buzzer first will get displayed. So it is a computerized system. This is the most controversial round. That's why we are having this system. So Micah Panjin, plus 20. Next. Slightly tough one. I think only one team pressed the buzzer.
Bacteria.
Bacterium. Huh?
Bacteria.
No, it was incorrect. What did we answer?
Bacteria. Incorrect.
Incorrect. Minus. So back and trim is a back trim. Be ready. Again.
Doxycycline.
Doxycycline. So doxy and cycline is the doxycycline. Again plus 20. So probably maybe their average age is lesser than other teams. So they are ready to crack these things. So next. Wait to answer. Team 2 again.
Tramadol.
Yeah, you are right. Tram A and all. Tramadol. So now this will be the last, and then I have a final one for audience. If you can crack what is at the end, you will be easily able to catch.
Gelusil.
2 number again. So you don't answer before it. 2 number is the
Gelusil.
Yeah. So that was the error which you made. You should have waited. Yeah. Once this get displayed, anyhow this round is over. Now I am going to ask for audience, dear scorer, please update the scores in the meantime. This is for audience. Yeah, you are right. It's a combi plan. So first, nephrologist friend came, tramadol, and this is a friend in another way. It generates patients for you. Combi plan. So this round gets over.
So at the end of round 4, after Googlies, so Maratha Warriors at 100, Gujarat is leading 130, and Vidarbha is at 100.
So keep track of your scores. Yes, yes. You are right. You are playing. Play it, no problem. Yes, set it correct. So keep track of scores, because next round is a scoring round, and you have to be very intelligent in choosing what you want. So we have time up to 9 a.m. and that is another easily 20 minutes or at least 18 minutes. We'll play this round till 8:55, 17 minutes. Is that done? 8:55, till 8:55 we'll play this round. Okay. So choose the option as per marks and category scoring. Scoring will be as per chosen mark. So what we are going to do is, there is this wall, okay. So these are 4 categories: Itihas, Chemical Locha, Name the Trial, and Photo Poster. So Itihas are questions from history. Chemical Locha is about chemical enzymes or things like that. Name the Trial is Name the Trial. Photo Poster, you will be shown image and you have to identify the personality basically. So if you, and obviously the gradation of scores and the difficulty associated is like that. And incorrect answer is half negative points. If you choose a 50 points question and if you answer incorrectly, you will get minus 25. If you answer correctly, there is plus 50. So there are...
Can you pass? No.
No, no. There is no passing here. There is no passing. So you have to take the calculated risk. एक मिनिट, इथे पॉइंटर कसा येईल, म्हणजे मला इथून क्लिक करावं लागणार, याच्यावर होणार नाही ते. म्हणजे समजा कोणी 10 मागितलं, मला तू क्लिक करू नका, आता 10 जर क्लिक करायचं असेल तर असं आता नको करू, इथे इथे होईल ना ते. ओके, राईट. सो दिस राउंड विल स्टार्ट इन रोटेशन. ओके, it is not a choose and pick round. It will start in rotation. It is a non-passing round. And so, because we are earlier started from Team Maratha, then we started from Gujarat. Now this round starts. क्या हो गया? अच्छा, तुम्ही तिकडून प्रेस करू शकता का? हाँ हाँ, I want in show. हाँ, yes, प्रेस मत करो भैया, नहीं तो क्वेश्चन चला जाएगा. Yes, so we start with Team Vidarbhir. Take a bet.
Name the trial 40.
Name the trials 40. So we are going to name the trials 40. Losartan in diabetic nephropathy. 30 seconds. So don't name any other, there can be many trials, but you are speaking about landmark trial. Please remember. Timer, please.
10 seconds remaining.
Marvel trial.
So that is an incorrect answer. It will fetch them minus 20. You want
Just
to answer?
answer.
Yeah, you
Renal,
just
renal.
Renal. That is a correct answer. That means question was also correct. Reduction in endpoints in NIDDM with angiotensin 2 antagonist losartan. That was a renal trial. So, okay. We go back to the wall, and so the question which has been done is already faded. It is to Maratha Warriors now. You choose.
Name the trial 50.
Name the trial 50. So if you thought, no, if you thought you have seen the question, You are making, okay, right. Now, one question had got displayed, that's why. Yeah. So, rituximab or cyclosporin in the treatment of membranous nephropathy. Name the trial.
Mentor trial.
Yeah, give plus 50 to them. So, membranous nephropathy trial of rituximab is a mentor. That is the professor speaking. Mentor.
Mentor speaking.
Yeah, that is a mentor speaking. So again, now to Gujarat Globe Stars. See, your lead is at risk. Take 50 somewhere.
Name the trial 30.
Name the trial 30. So I go to name the trial 30. Tolvaptan in ADPKD.
Tempo trial.
Tempo trial is the right answer. So 30 points plus 30. Scorer, your job is important now. Yes. So we again go back to Vidarbh Beers. Trial सबके फेवरेट है.
Chemical locha 50.
Chemical locha 50. They are taking a risk. Come on. So 50. Hyperacute rejection in pig xenotransplantation in humans is due to antibodies against. Any random answer, short forms are not acceptable. This is a 50 points question. Is it right, audience?
Yes.
Timer, please.
Yes. 10 seconds remaining.
Eggs.
It is a minus.
Stop.
Eggs.
So you can skip. It is not mandatory to answer. If you answer incorrectly, it will be a minus. I think your time is up. Yeah. So galactose, alpha 1,3 galactose is the GAG, it is called. So Maratha Warriors.
Trial 20.
Trial 20. Trial 20. Normalization of hemoglobin levels and cardiovascular outcomes in non-dialysis CKD.
Treat trial. Treat.
No, that's an incorrect answer. It's a create trial. So minus 10 to them. Okay. Gujarat Globe Stars.
10 trial.
10 trial. Okay. Defensive. So they are keeping track of their scores. So this is the last. Now there are no longer any trials available. Ramipril in prevention of adverse cardiovascular outcomes. Very famous, popular trial. Being young may be a disadvantage to you.
Rain trial.
No. So maybe this trial was popular at our times.
Yes.
Hope trial. This was always discussed. It is a heart outcomes prevention evaluation study. It was very landmark trial. So we now we have had 6 questions. I think, yeah, we are doing it in correct way. Vidarbh Beers.
Itihas 50.
Itihas 50. Oh, risky play, come on.
Spirit to win.
Name first live donor kidney transplant recipient in India and who was the donor, relationship. If you, let me clarify, if you answer half, I will give you plus 25. If you answer fully correct, 50. And if you answer and it is incorrect, minus 25. You choose your level. Name the first live donor kidney transplant recipient in India, relationship of the donor with the recipient.
He was a prince at Vellore. Like he underwent transplant at Vellore. He was a prince, and I think servant was the donor.
No. So Vellore is the correct answer, but that is not part of my answers. So name the first recipient and who was the donor. Specific question, specific answers.
Prince of, yeah, he was prince. And
I don't want to know his designation. I
Stop.
want name.
Time is over.
So incorrect answer 25 minus. Shanmugam was his name. Father was the donor. You are right. CMC was the place where it happened. 1971 is the year, and it was done under the leadership of Dr. Mohan Rao. So we go back to wall. I am sure scorer has entered minus 25. Yeah. So Maratha Warriors.
Chemical Locha 40.
Chemical Locha 40. Mechanism of Bilata Sept action. So it has like, even if you answer half correct, I will give you 20 points.
The BLYS, this co-stimulatory blockade.
Co-stimulatory blockade is the right answer. So it blocks interaction of CD80 with CD28 plus 40 points to Maratha Warriors. Next.
Fata poster 30.
Huh?
Fata poster 30.
Fata poster 30. I thought this would be chosen as a preferred round by others. So Fata poster 30. So identify the personality. Identify the hero. I am not asking what he did. He is a Nobel laureate. Okay? Important in nephrology. Timer.
Skip.
Yeah,
Skip.
so they are not answering, so no negative or positive marking.
Michael
So-
Armstrong.
No, this was Peter Agre, aquaporin he discussed, and he got Nobel Prize in Chemistry in 2003. So, who is the next team? Vidarbh Beers.
Fata poster 50.
Fata poster 50. Identify these two, name them correctly. It is a 50 points. So incorrect or partially correct answer no. Timer please. बताओ काउंटडाउन शेखर सर कितने बचे? 15 seconds to go. 10, 9, 8, 7, 3, 2, 1. Your time is up. Yeah. First transplant recipient. Ronald is the donor and Richard
So
Harris
you
is
asked
the-
about the instrument, sir.
What?
You asked about the instrument.
No, I identify the personality was the question. So Fata poster. What is that? Fata poster Nikla hero. No, if you, in this picture, if you are focusing on the instrument, then that is your error. When two people are there, question round is Fata poster, and if you are focusing on the instrument. But anyway, there is no negative marking. I am not deducting any points from you, but anyhow you haven't identified, not even you are named the instrument. So no points to you. Next to Maratha Warriors.
Chemical Locha 30.
Chemical Locha 30. Liddle syndrome is characterized by mutations in.
Activating mutation in ENAC channel.
Professor again. ENAC channel. Gujarat Glom Stars.
Chemical Locha 20.
Chemical Locha 20. PKD1 gene responsible for ADPKD is located on which chromosome number?
Chromosome 16.
Yeah, that's the right answer. Plus 20 to them. So by now we have 3, 3, 6, 3, 9 and 3, 12. So 4 rounds are done. I think we have time, we have 3 and 3, 6 and 7 questions. So we can have 2 rounds easily. Should we announce the score for them to understand where they stand? So, whatever is the time, hereafter we are going to have 2 rounds. Okay? So, get your score and be clear what you want to achieve. इवेंट वाला को नहीं है, इवेंट वाला अक्षित को देखो.
Yes. At the end of round 5, 4 questions, 4 rounds.
Yeah.
So 210 for Maratha Warriors.
Maratha Warriors 210.
Gujarat is like a 175.
175.
And Vidarbha at 55.
Vidarbha at
55.
55. So you can spoil others' party, choose 40 points and make them winner. So I'm kidding, that is the way people work. So be ready, Vidarbhis, choose what you want.
Itihas 40.
Trophies and ready? Ready, पाहिजे. Name the first chronic hemodialysis patient. Name. It's a 40 points question. Chronic, I am asking chronic hemodialysis. It's not acute, not first dialysis. Chronic hemodialysis patient.
He lived for around 40 years.
And is the name of the patient, so that you don't get confused with what I am asking. Timer, sir.
Yes, time. Time up.
Yeah, somebody was answering correctly, I heard. Yeah. So, again, that certifies that question was not incorrect. So, somebody knew Clyde Shields survived for 11 years on Scribner stent, is a first chronic hemodialysis patient. Yes, Maratha Warriors.
Chemical Locha 10.
Chemical Locha 10. They are smart people. They want to play it safe. Year of first successful kidney transplantation in world.
1953.
Is the incorrect answer, minus 5.
54.
It's a 54. Next, Gujarat Glom Stars.
Pata Poster 20.
Pata Poster 20. Those who attend Avatar conference, if you have attended, he is a faculty there. And we should have some Indian heroes, that's why. He's working abroad. Looks like Vijay Amrutraj, but he's not.
Skip.
No. Anybody wants to take? Okay. The Dheeraj Rajan, endovascular AV fistula creation. Then I think now we have last round, is it? Last round with Vidarbhirs. Go, what you want.
Itihas 30.
Itihas 30. So we go for Itihas 30. Yeah. My senior doctors will like this question. Indian Society of Nephrology was formed in the year
1971 maybe?
Slightly incorrect, but I think, yeah, he's saying 1970, we give it to them. And it is easy for me to give you because there is no harm done.
20 points, sir.
1970, I think this was 30 points question. So last 2 questions.
Chemical Locha 10.
Chemical Locha 10. Febuxoside reduces uric acid levels by blocking which enzyme?
Xanthine oxidase.
So that's a correct answer. They are leader and continue to remain leader. And this is the last question. After that, remaining we'll give to audience.
Pata Poster 40.
Pata Poster 40. So if you are attentive, there was some clue to this. Who is this? I can give you a clue also. It's a potassium disorder.
Humphrey Davis.
No. This is because it is a difficult question. I gave you a hint. It's Gitelman. Okay. So till the time our scorer updates the score. So now we have two options. So we will go with ITIAS 20, so that it gets completed. Luckily, the technology supported us. There was no problem in running this round. Year of first successful human hemodialysis, where I am not talking of the attempts. First successful human hemodialysis, where patient survived and kidney function recovered. It was AKI patient. So that was the correct answer. 1945. And the last, I think I wanted this question to be taken up by someone. Unfortunately, it didn't happen. Probably it is fitting that it is being taken by everyone. So that was the photo poster. That concludes our Nephrology Premier League. And I hope everyone liked this Nephrology first edition. And if there are office bearers sitting here, let this be a regular activity of ISN West Zone. So I will request Sri Ganesh to announce the scores, and then we have beautiful trophy, medals for all participants.
So though Vidarbha Veers took a lot of risk but unable to score in slog overs. So they are obviously at the bottom with 85.
Okay.
Gujarat Glome Stars played very sensibly and they maintained their middle border very strong, and they are at the runner-up. So they are 155. And Maratha Warriors, as usual, they hits like boundaries everywhere to one kede. So it is like a 215 for them, and they are the winner for this Nephrology Premier League.
So appreciate the attendance for this activity. Now we have a medal distribution. I will request chairman of our scientific committee who supported this initiative of Nephrology Premier League, Dr. Umapati Hegde sir, to present medals to the team Vidarbha Veers. I saw Girish Narayan sir somewhere. Yes. So please, he is our teacher. He is teacher to myself, Sri Ganesh Shekhar. He travels from Hyderabad. He will present medals to Gujarat Glome Stars team. Sir, Gujarat Glome.
Anger needs a special.
And to present the medals to the third team, I request Pargaonkar sir, Chafekar sir. So I am calling those whom I am seeing. So don't get mistaken for anything. Thank you, sir. And now we organizers will present the winner's trophy to Maratha Warriors team. You have every chance to kiss the trophy, celebrate it the way you want. Oh, please come ahead. So that concludes Nephrology Premier League. I have kept promise I made to myself, finished on time, started on time. Thank you. So next professor is Dr. Chitija. Table remove करा. So chairpersons के बजर्स वगैरह डिस्कनेक्ट करा. थोड़ा 2 मिनट लगेगा रेडी होने के लिए. Chitija, it will take 2 minutes. And we could have attention. You have all the information. आता बघा चेअरपर्सन अनाउन्स करते डिस्प्ले करायचं लक्ष ठेवा मी तेच आहे तुम्हाला रेकॉर्डिंग सेशनवर काय
So for the second session, how will I manage glomerular diseases in 2022? For this session, I request the chairpersons, Dr. Anil Ganju, who is a nephrologist and a transplant physician at Premier Kidney Hospital, as well as a visiting nephrologist at MPUH Nadiyar, and Dr. Devdutt Safekar, who is a director and a consultant nephrologist at Supreme Kidney Care and Medicava Hospital, Nasik.
Good morning, everybody. After that NPL session, which was very exciting, interesting, and well devised by Sachin, let us go on to the next session, which is a session on glomerular diseases. And you will agree with me that the topics which are selected even for this session are very, very contemporary, and I'm sure that we are going to learn something new. We are starting a bit late because we are supposed to stick to the time. So it's about 5 minutes past 9. And let us begin with the first session. I invite Dr. Girish Narayan for the first talk, which is on monoclonal gammopathy of renal significance. So Dr. Girish Narayan does not need any introduction to all of us. He has been visiting the West Zone for a very long time, and he's a senior consultant nephrologist at Uday Omni and Yashoda Hospital, Hyderabad. He has been my DM examiner, and all of us have learned from him for the last so many years. So I request Dr. Girish Narayan to deliver his talk.
Good morning, everybody. Thank you, Dr. Safekar. First of all, I'd like to thank the West Zone for giving me this opportunity to come and participate in this conference. As our chairman has said, I have been a regular visitor to the West Zone, and probably participating more in West Zone than in South Zone conferences. So thank you for this opportunity. I have chosen a topic which is relatively new, in the sense very little importance was given to the glomerular involvement, renal involvement, in a very important disease which has been going on for decades. And the diagnosis of multiple myeloma was used to be entertained for a very long time. And only classical renal lesions were looked into. Then we realized that the basic important molecule all of us know is the immunoglobulin, with the light chains, the heavy chains, the variable portion. And this is usually done by the test which is commonly employed in our routine day-to-day laboratories, the normal electrophoresis, where you see the globulins, various globulins, and the albumin towards the end of the graph. And in a classical patient of multiple myeloma, we can see a broad band towards the one end of a monoclonal peak of the abnormal immunoglobulins. So with this background, because we are familiar with multiple myeloma, but what is very important to understand today, there are so many disorders which have abnormal production of immunoglobulins, especially the monoclonal varieties, and a number of plasma cells, the B cells, and the lymphoblastic cells produces abnormal immunoglobulins and give rise to various manifestations. We were familiar with the clinical manifestation, but there was always a gray area where the patients had abnormal cells, but there were no clinical symptoms. And these are the situations where they were described under various heads, including the classical multiple myeloma, which I will not discuss, because all of us know the diagnostic criteria and the various lesions which occur in multiple myeloma. Then the so-called smoldering multiple myeloma, where you have abnormal proteins of significant content, but they do not have the target organ damage, clinically overt clinical damage. And then the other plasma cell disorders, long list. In the end, we'll come to the last one, the MGUS, unknown significance. This was something which is very commonly observed in common population, and as we'll be seeing in the incidence, more number of patients were seen, but there was very little to offer to them for treatment because all these abnormal proteins were being produced by non-malignant or you can say relatively benign cells, and no treatment except for close observation was required for these cases. But then we realized that by the age of 50 years, about 3% of the population will have these abnormal proteins in the blood, may not be of any significance to them clinically, but some of them, a small percentage of them, over a period of time, may develop the clinical symptoms and problems related to the various organs in the body. And by age of 70 years, almost 5% of the patients may have these globulins in their serum. So the term monoclonal gammopathy of uncertain significance was being used all these years with the clinical definition that they did not have abnormal proteins of more than 30 grams per liter. There was no end organ damage. There were no other, the classical multiple myeloma defining events. And it rarely leads to potentially severe organ dysfunction. So the criteria for classical multiple myeloma and other malignant lymphoproliferation as non-Hodgkin's lymphoma were not met, and there was no treatment recommended for these cases. Then came in 2012, we realized that there are certain patients that require intervention, they require identification because there is some damage to the organ, especially to the kidney, and the term the renal significance was added. And in over the next few years, different criteria were added. Criteria was added to identify the patients who are likely to progress faster, develop severe renal damage. And the International Kidney and Monoclonal Gammopathy Group coined this term of MGRS. And now we know that so many other plasma cell, B-cell lymphomas and other proliferative disorders have been added to this common term of MGRS because the final organ affected is kidney in these cases, and a variety of renal regions are seen. I am sure this is just the beginning. Over the next 10 years or so, there will definitely be more subclassification of these diseases because a large number of diseases are clubbed under this particular heading. And you look at the prevalence, it's not uncommon. About 6% of the patients, as per the American data, had MGUS, and some of them, about 1 to 1.5%, had developed renal dysfunction and end-stage kidney disease, especially in Netherlands. They realized that a good number of them had amyloidosis when they were started on dialysis, possibly with an underlying diagnosis of MGRS. So obviously, as a clinician, when do we suspect this? We suspect it when somebody has proteinuria, somebody has renal dysfunction, and when we do a biopsy for unexplained renal dysfunction, that is where we come across this. And let me remind you that the diagnosis of MGRS is usually made only after renal biopsy, that too after a good immunofluorescence study. Although light microscopy may give a clue, but the final diagnosis comes through immunofluorescence and definitely electron microscopy if the facility is available. So depending upon the type of deposits, the character of the deposit, the location of the deposit, the various disorders have been classified under this term of MGRS. Because there are so many other conditions which we have seen clinically, our pathologist sometimes surprises us by giving these diagnoses because there is nothing to suspect clinically in these patients. So as I said, probably over a period of time, when more characterization of these deposits are done by further studies, we may be hearing more of it. But as it stands today, these are the various morphological changes which are seen in the renal biopsy and which are all clubbed and grouped under the diagnosis of MGRS. including immunoductal nephropathy, including the cryoglobulinase, which we all know as the type 1 cryoglobulinemias. And what is important or probably of interest, I will say, is the crystalline podocytopathy, where the deposits can be present and the patient may present purely with proteinuria and nephrotic state. And rarely some patient may present with Fanconi-like syndrome because of the deposits in the proximal tibia. And more out of curiosity and for the quiz which we had today, probably for these things, there are so many other conditions which have been grouped under this with manifestations of multiple organomegalies, polyneuropathy, and biopsy, MPGN type of renal lesions. All these patients are all grouped under the term of Poems syndrome, which can be part of the MGRS syndrome. Basically, all these light chains are toxic to the kidney, they're toxic to the tubules, and once their levels increases and they are filtered, while going through, they get the misfolding of this amino acid sequence in the proteins, and which when they pass through the tubule, they bind to the thiamophosphate protein and cause precipitation, aggregation and precipitation, and these are the which initiates the immunological and the chemical reactions within the tubular lumen and damages the glomuli and the tubule and give rise to various lumen. What is more important and probably interesting is to realize that some of the light chains also act as a stimulus for activating the alternate complement pathway like C3 nephrotic factor, and like a typical case of TMA, they will be activating the complement, and without any immunoglobulin deposits, you can see the renal injury initiated by this proteins. So as a result, when I said when you have this alternate activation of the alternate complement pathway, you can have various renal lesions which are as a part of the manifestation of the MGRS syndrome. More for anecdotal reasons, some of these immunoglobulins also react and give rise to reaction with the plateau antigens and may have a morphological picture of a membranous nephropathy. And rarely patients have also been documented to have lesions like type 4 collagen of the and membranous lesions also. So it is something which is more of a challenge to the pathologist to diagnose it by proper immunostaining to identify this. So just to go through the various pathogenic mechanisms, we realize that it is the light chains which are present in there, which are toxic, which goes formation of high molecular weight aggregates in the tubular lumen or in the glomuli, which gives rise to cast formation. And the cast could be of the kappa or lambda chains, or some of the deposits could be the fibrillar form, which will give rise to amyloidosis, or the non-organized deposits, which can give rise to the classical light chain deposit disease. Broadly, they have been classified, the deposits have been classified into three different categories: the organized deposits, microtubular deposits, and then non-organized deposits. With the most common is the organized deposits, fibrillary deposits, which you see in amyloidosis. And then the other non-organized deposits, which come is the MIDD disease, which is not uncommon when we do a proper immunohistochemistry and electron microscope, and rarely Fanconi syndrome. And it can get deposited to the various segments right from the glomuli to the tubules, and various types of histological changes can be seen depending upon the site it is getting localized. And just a patient histologically, if somebody sees a mesangial expansion on biopsy, when they stain with PSM, if it shows PSM positive, we have diabetic and other diseases, and if it is negative, toward the other end we have the diseases like fibrillary glomerulonephritis or monoclonal immunotactoid nephropathy, depending upon that. And those who do not have any deposits, or in the microtubular structures like cryoglobulin A. Just abroad we have seen this, the nodular structure which is seen in light microscopy because of light chain deposit disease. Then the mesangial and the capillary depositions of the lambda chains and kappa chains sometimes with immunotactoid nephropathy. Then the fibrillary which clinically or histologically present with mild mesangial proliferation, some amount of basement membrane thickening could be seen. And the classical is the electron microscopy which give rise to the pattern which is typically considered as randomly arranged fibrils of this fibrillary glomerulonephritis. A word about this, the free light chain assay which is being done. It is very important that it is not easy to measure these free light chains in the serum because you require nephrolometric method or using monoclonal antibodies for the so-called free light assays to measure this, and the ratio between the kappa and lambda is considered to be of diagnostic value in some of the diseases. But a word of caution, but this is not routinely done, and if the same procedure is not followed up in the follow-up of the patient, if you follow two different procedures, the values also may change and you may not be able to interpret the abnormal findings in a proper way. So, as you know, because of the overflow of this excessive production of free light chains, they appear in the urine, and when you measure the urinary free light chains, you may be able to pick up some of these disorders which have been causing damage to the various structures of the nephron along the tubules. So once somebody is diagnosed with this, comes to the treatment has always been debatable, not well organized trials, and no standard recommendations have been made. As you know, only in 2017 the term MGRS was included in various diseases. So there are no good controlled trials for the management of these cases. So the main aim of the treatment is to treat the primary renal disease if possible, which can be done only by treating the primary clone, whether it is the plasma cell or the B clone, or preserve the renal functions as far as possible, because this disease is likely to recur after transplantation very rapidly. So the aim is to control the disease process and then only think of a transplantation in these cases. Although I will talk you later, the autologous stem cell transplantation can be done even if the patient has a renal disease. So the target for treatment depends upon the various drugs that have now been approved for use for the various disorders, including our commonly used drugs like bortezomib, rituximab, monoclonal antibodies, the alkylating agents, we have been using it for decades, and steroids, and some of the rarely autologous stem cell transplantation. When we talk about complete response, when there is not much of cells in the bone marrow shows absence of plasma cell, free light chain assay ratio comes down to less than 40, and then some of the patients, when there is no such response, we call them as non-responders, and these are the patients who are likely to give more problems in our day-to-day manner. So if the complete response criteria is met and these patients have absent cells in the bone marrow, then in these cases adaptation of this kappa and lambda ratio is the first issue which was considered to assess the response of the treatment. And then it is, as I mentioned, because the urinary estimation is inaccurate, we do not depend upon the urinary estimation of these light chains and this ratio for completing the response. The treatment, as I mentioned, is by various drugs, which I am not going to too much of detail. But the decision to undergo a stem cell transplantation should be highly individualized and is usually reserved for relatively young patients who do not have little or no comorbid conditions. As I mentioned, kidney disease is not a contraindication for considering a stem cell transplantation. And patients who are ineligible for the stem cell transplantation, in those cases, some of the diseases like MIDD, some of the diseases like proliferative glomerulonephritis, some of the diseases of amyloidosis, various combination of drugs have been tried with fairly good response. They have histologically demonstrated regression of some of the lesions after a course of cytotoxic and monoclonal antibodies and these drugs. So those cases who are not eligible for transplantation, 8 courses of bortezomib in combination with alkylating agent and steroids have been tried with some encouraging results. So these are some of the case reports which have shown the resolution of this. And to conclude, I will say that MGRS these days is now a well-recognized entity. You have to have a high index of suspicion. Biopsy is the only way to confirm the diagnosis. And the main aim of the treatment is to preserve the renal functions as far as possible and to at least keep it under control, because unless the primary disease is under control, there is likely to be recurrence after the transplantation. And then those patients who are suitable, autologous stem cell transplantation can be considered for these cases. I think that is the end of the. Thank you for your kind attention.
Thank you, sir, for your comprehensive discussion on this topic. We just have time for 2 questions, if anybody wants to ask.
Can she have a mic? I'm not a mic.
Membranous nephropathy on light microscopy, and this is showing kappa deposits only. All other tests are negative, sir. So what would you suggest? Should this patient be treated with all these agents, or should he just observe?
Yeah, theoretically, Doctor, yes. One of the histological lesions which are seen in the MGRS is membranous, as we have mentioned the underlying mechanism by acting autoantibodies against the plateau antigen. Theoretically, it can, but it is so rare. There are just isolated case reports. So if somebody definitely shows on immunofluorescence light chain deposits, I think it is worth investigating those cases for a possibility of an underlying plasma cell disorder.
I just have one question. The interpretation of FLC assay is different in patients who have renal insufficiency versus normal renal function with urinary abnormalities. So in that case, the decision regarding kidney biopsy, how do you think about it?
About the light chain assays?
FLC assay.
Yeah. No, basically, even once the patient starts developing deterioration of renal function, the excretion of this light chains changes, and the ratio value, what we normally start with 0.2 or 0.24, has to be increased to a cutoff value as 0.3. So in patients with deteriorating renal functions, the kappa lambda ratio has very little diagnostic importance in those situations. But in those cases, we have an abnormal production of a large, and you are finding a large amount of free light chains in the urine, which I said is very difficult to assess clinically by the laboratory methods. It is no longer a acceptable way of evaluating such cases with this.
Thank you, sir. Let us go on to the next presentation. Thank you, sir.
Thank you.
Let us go on to the next presentation.
Next presentation is by Dr. Saxena Alexander from Christian Medical College, Vellore, and she will be talking to us on IgA nephropathy. So without wasting much time, I would request her to start her talk. Thank you.
Thank you, sir. Good morning to all my colleagues and friends. Greetings from CMC Vellore. This is a race against time for me, so I'll do my best, and I thank the organizing committee for giving me this opportunity. The topic for today is IgA nephropathy, newer updates. We owe it to John Berger, who described this in 1968 in the renal tissue. This should not be confused with IgA dominant glomerulonephritis, which should be corroborated histologically and clinically. Coming to epidemiology, we know that the prevalence of IgA decreases from east to west. Retrospective studies in India have shown progressive IgA nephropathy with severe presentation in a younger cohort. And a 4-center retrospective cohort in India also showed a prevalence of 14% of IgA in renal biopsies in a younger population. The basis for the GRACE IgA nephropathy was to understand these differences in the Indian subcontinent at clinical and biomarker level, and the cohort is the first prospective single-center study and is registered with the WHO trial registry. The protocol was published, had specific inclusion and exclusion criteria. The follow-up of patients, 200 patients completed 3-year longitudinal follow-up in September 2020 and will be completing 5 years in September this September. The outcome measures that we studied were on the rate of fall of eGFR, the remission rates in proteinuria, as well as composite outcome, which was a more than 50% fall in eGFR, end-stage kidney disease, or need for renal replacement therapy. The patients were mainly from South, Central, East, and Northeast regions of India. There were no, the risk was based on 2 scores. One was a score which was validated in the Japanese population using clinical and 3 MEST criteria, and the other one was the International IgA Nephropathy Equation, which was published in 2019. There was no significant difference in demography. As expected, there was higher blood pressure in the higher risk group with higher proteinuria and increased renal dysfunction. Though synpharyngitic illness was less frequent in our cohort, it was more so in the lower risk group. This was a cohort distribution in terms of eGFR category and subcategorization based on proteinuria tertiles. If you can see, the hypertension denoted by the pink and the rose color, with or without other symptoms, predominated all GFR categories, whereas if you, especially in the lower GFR, whereas if you look at the higher GFR, there was a more spread of non-hypertensive symptoms also. The macroscopic hematuria, which is a commonly seen symptom in the western and eastern cohorts, which is the green color, was less frequent and more seen in the higher eGFR groups. The incidental symptoms, which are symptoms which is IgA nephropathy picked up during routine health checkup, which is colored in fluorescent green, was seen in all 3 CKD categories. The median lead time from detection of hypertension to kidney biopsy was 10 months, and from all the other symptoms to kidney biopsy was less than 6 months in our cohort. This does not include subclinical or asymptomatic disease. Hemoglobin, total protein, and serum albumin were significantly lower in the higher risk group, and just to recall, these variables are not included in the present risk equations, but as expected, eGFR was lower in the higher risk group. Coming to MES scores, there was significant inflammatory as well as sclerotic and fibrotic lesions in the higher risk group. As expected, global glomerular sclerosis was also significantly higher. IgA staining, higher grades were seen in lower risk group, probably because of more viable glomeruli. Crescents were much rarer in our cohort, but that does not mean that crescentric IgA nephropathy is not common. From our single center study, IgA nephropathy was the 3rd most common cause of immune complex crescentric GN. When we looked at the relationship of MES-C score with clinical variables, which was mean arterial pressure, eGFR, and proteinuria, there was significant association of endocapillary hypercellularity, segmental sclerosis, and fibrotic lesions. Segmental sclerosis was associated with higher proteinuria and lower eGFR, whereas the fibrotic lesions, the T1 and T2, were associated with higher MAP, higher proteinuria, and lower eGFR. Likewise, global glomerular sclerosis was associated with higher proteinuria and lower eGFR values. Some of the interesting observations that we found was that even in incidental asymptomatic IgA nephropathy, which was 8% of our cohort, with a map of with a good map and a well-preserved eGFR and a proteinuria 1 gram per day, there was significant sclerosis and fibrotic lesions. Patients who had visible hematuria and synpharyngitic illness, which were 15 out of 75% of them had hypertension and chronic lesions in renal biopsies. The so-called low-risk patients who had proteinuria less than 1 gram and preserved eGFR, on histology again, kidney damage was still seen. 12 patients with nephrotic range proteinuria and preserved eGFR again had evidence. So this suggests that there is a propensity of a sclerosing and a fibrotic lesion in South Asian IgA nephropathy. The results were published, and coming to pathogenesis and newer updates. As we all know, IgA nephropathy is due to the proliferation of the polymeric form of the IgA1, which is usually present in the intestinal mucosa. Usually the polymeric, the hinge region is glycoxylated, but what happens in IgA is there is a deficiency in glycoxylation in the hinge region of the IgA1 molecule. And this glycoxylation is a post-translational modification. So as the IgA molecule traverses through the Golgi apparatus, the glycoxylation happens. And once it comes out, the IgA molecules combine with each other to form the polymeric, by the joining change to form the polymeric forms. And as it exits the intestinal epithelial cell to the mucosa, the secretory chain is added. The present hypothesis is based on the 4 hit criteria. The hit 1 is the galactose deficient hinge region towards which autoantibodies are formed, which is the hit 2, which is then forms immune complexes and deposited in the kidney, which is hit 3, and hit 4 is a subsequent renal injury. So mucosal infection leads to both T-cell independent and T-cell dependent pathways. T-cell independent pathways is through recognition, is through toll-like receptors which cause B-cell priming. The T-cell dependent pathways is through activation of cytokines like APRIL and BAFF, which again cause B-cell priming, and these then become antibody secreting plasma cells that secrete poorly galactosylated polymeric IgA. They combine with autoantibodies, cause complement activation and renal injury. Now, what about risk stratification? KDIGO recommends that risk stratification be done using MES-C scores as well as clinical variables. There is the recommended equation by the KDIGO network is the International IgA Nephropathy Network equation, which was published in 2019, and there is a free risk calculator available online. So when we input enter the variables, this is an example where I have entered variables for eGFR, systolic, diastolic blood pressure, proteinuria, age, race, MES score, as well as the use of RAS inhibitors and immunosuppression, and we need to choose the time at which the risk needs to be predicted. Here I have entered 36 months. We get a risk of progression, which is a risk of 50% decline in estimated eGFR or progression to end-stage kidney disease at the time that we have chosen. Please note that in this equation, the race that we have to choose is others, because this equation has not yet been validated in the South Asian or the Indian subcontinent. When we looked at the performance of this equation in our cohort, the Barber et al. Risk prediction at 3 years, the patients were distributed along the x-axis in the increasing order of the Barber risk prediction. And the red color shows the ones who had achieved composite outcome at 3 years, and the green color shows ones who had good outcome. The median risk predicted was 18%. We found that 9% of patients actually had composite outcome when it was less than 18% risk prediction, and 54% had composite outcome when it was more than 18% risk prediction, and this shows that it underestimates the risk for our population. The performance for a more than 23 score is 70% sensitivity and 80% specificity. The 3-year outcomes, the other 3-year outcomes that we have studied was the various lab and clinical associations over time. We assess the patients at baseline 6 months, 1 year, 2 year and 3 years. The first diagram shows a mean arterial pressure. The red color is those patients who had bad outcome, and the green color is those patients who had good outcome. The mean arterial pressure was maintained, and there was no significant difference at each follow-up time point. But the bad outcome group had increased use of antihypertensives. When you look at 24-hour urine protein, you will see that in both groups the 24-hour urine protein decreases. But if you notice carefully, the 24-hour urine protein reaches less than 1.5 gram per day at 6 months in the good outcome group, and less than 1 gram per day at 1 year in the good outcome group. The other outcomes that were relevant in our cohort, this cohort, most of them received short course immunosuppression, and a minority received MP if they had persistent proteinuria. Remission rates of proteinuria was partial was 84 and complete was 39. Rapid progression was seen in 40% of patients, and composite outcome was seen in 37% of patients. When we look at partial remission and complete remission, partial remission was more seen in the group that had good outcome, shown by the light blue color, and it was even more evident with complete remission, which was better in the good outcome group, which was shown in the red color. The most important clinical, the lab criteria that was associated with composite outcome was the annual rate of decline in EGFR. A more than 5 ml decline per minute decline in EGFR had a specificity of 86%, sensitivity of 86%, and a specificity of 90%. By multivariable Cox model, we found that MES T2 score, 24-hour urine protein measured at 6 months, more than 1 gram, EGFR less than 60 ml at 6 months, and a rate of decline of more than 5 ml per minute, annual rate of decline, were significant risk factors for IgA nephropathy progression. Note that the strongest predictor here was the annual rate of decline in EGFR. Coming to biomarkers, where do we stand? There is no universal biomarker that has been validated in IgA nephropathy till now. What about our population? Though serum galactose IgA1 has been studied as a biomarker in various other cohorts, it was not a diagnostic biomarker in our cohort. Those serum IgA levels were significantly elevated. Both had a positive significant correlation. The ratio of serum galactose deficient IgA1 by serum IgA also was not a diagnostic marker. We looked at it at its performance longitudinally, and we found that in the group that received immunosuppression, galactose deficient IgA1 levels significantly decreased at 1 year and progressively increased, and so was the case with serum IgA. So serum, which is seen in the second diagram, and the third diagram shows that the serum galactose deficient IgA as well as serum IgA parallelly declined by 1 year and slowly increased thereafter. This ratio was also significantly associated with composite outcome at 3 years, with a higher ratio having a poor prognostic value. It was also shown in the cohort that had steroids, and there was a quartile effect with composite outcome. When we included this biomarker in the multivariable Cox model, apart from the other measures that I had mentioned in the previous slide, this ratio also came up as an important independent risk factor for IgA progression. What about other biomarkers? Secretory IgA levels in the serum were again studied by ELISA and did not show any association with composite outcome. Serum immune complex levels were studied by an in-house ELISA and did not show any association with composite outcome. Serum C3 levels, lower levels were associated with composite outcome in the univariate analysis, but not in the Cox proportional hazards model. Serum C4, higher serum C4 levels were associated with composite outcome, again only in the univariate model. Immunostaining for serum C3 again did not show any association with composite outcome in our cohort. This is a study from Trivandrum which looked at the performance of serum BAFF and APRIL levels, and though it was not statistically significant, they found that patients who reached end-stage kidney disease had lower APRIL and BAFF levels. We looked at the serum APRIL levels in our population. Serum APRIL levels was not a diagnostic marker, but it's significantly associated with lower levels associated with M1 lesions as well as E1 lesions, and lower median level was a significant risk factor for composite outcome at 3 years. Have there been any updates in treatment strategies? KDIGO recommends enrolling patients in clinical trial, especially if they have persistent proteinuria, and it should be especially in EGFR category of more than 30 after assessing the risks and benefits of giving steroids. We all know that KDIGO has grade 1B recommendation for the use of RAS inhibitors for the control of blood pressure, along with lifestyle modification, which improves which gives a synergistic action for improving the control of hypertension and proteinuria. The new drug that has changed the landscape of treatment in kidney disease is the glifosins, and the DAPA-CKD trial had included 270 participants with IgA nephropathy. About 256 of them had biopsy-proven IgA nephropathy, and there was significant benefit in composite kidney outcome with dapagliflozin compared to placebo when it was added to RAS inhibitors. The baseline characteristics of both the groups were similar, But some of the limitations that that has been highlighted is that 24% of the placebo group exhibited primary endpoint, which was much more than expected by the prediction models. There were significant 3 participants who died with cardiovascular death. There was no run-in period for this drug. There were no biopsy in 16 patients, and the immunosuppression was at the discretion of the physicians. Though there's an important role in CKD, a stronger evidence in IgA nephropathy is still required. Now, presently, the EMPA kidney trial is ongoing, the phase 3 trial. It is a Jardiance molecule. Jardiance is a trade name. It's the largest double-blind randomized placebo-controlled trial involving more than 6,600 adults with CKD. The trial is conducted by MRC as well as the University of Oxford. The primary endpoint for this is a composite of kidney disease and progression of cardiovascular death. In March of 2022, the Independent Data Monitoring Committee recommended that the EMPA kidney trial be stopped early due to clear positive efficacy, and we are still awaiting the formal results of this trial. What about, there's been a significant change in the KDIGO position on proteinuria outcomes from 2012 to 2021. Presently, KDIGO accepts a proteinuria reduction of less than 1 gram per day as a surrogate marker of improved kidney outcome and as a reasonable treatment target. Coming to the role of steroids, earlier smaller trials had shown a legacy effect of steroids on IgA nephropathy treatment. But later on, 2 trials, a STOP IgA nephropathy as well as the initial testing trial, the STOP IgA nephropathy did not show any difference in the rate of loss of kidney function, and there were more infections in immunosuppression group. The testing trial was prematurely aborted after recruitment of 262 patients because of serious infections, though it did show treatment benefit with methylprednisolone. The KDIGO position also changed on corticosteroids, and they wanted reconsideration of corticosteroids, especially if eGFR was more than 30 and if there was a high risk for progression. The low-dose testing trial, which is shown in the bottom row, recruited patients with a lower dose of methylprednisolone, and the results have shown a much beneficial effect in kidney endpoints with a lower prevalence of serious adverse events. The other drugs have not been recommended by KDIGO. Fish oil can be taken, but no significant benefits have been noted. No significant benefits have been noted of MMF in non-Chinese patients, as well as HCQ also warrants evaluation in non-Chinese population. Now, what about the newer treatment algorithms? The newer treatments target all these pathways that are shown in the diagram. The key ongoing phase 3 trials are based on these drugs. I'll go through some of the results. The sparsentan is a drug which the interim results in 280 patients have shown a reduction of proteinuria from baseline. It is a new class of drug. It's a dual endothelin angiotensin receptor antagonist, and the change in proteinuria at 36 weeks is being looked at. NEPHROLOGY, the phase 3 results, the part A results have been released in 200 patients. This was released in ISN WCN 2021, and at 9 months there was a significant reduction in proteinuria of NEPHROLOGY, which is entry-coated budesonide. With regards to iptacopan, which is a factor B inhibitor, again the phase 2 results have been out, and there's a statistical reduction in proteinuria with tolerable side effect profile. Endothelin receptor A antagonists have been studied extensively in diabetic kidney disease, but its use in IgA nephropathy is ongoing in the phase 2 and phase 3 trials. MASP2 inhibitor is a complement inhibitor which also has shown significant proteinuria reduction and good safety and tolerability in phase 2 studies. Sibeprenlimab, which is APRIL blocking monoclonal antibody. Many of the centers in India itself are participating in this study. It's a phase 3 study which is going on, but the phase 1 study has shown that the drug is safe, well tolerated, and suppressed biomarkers without loss of antigen-specific vaccination response. These are the other promising drugs. Before I stop, I'll just need to highlight the ethnic differences that are seen in our population when compared to Caucasians with respect to serum secretory IgA as well as galactose deficient IgA1 as well as with respect to the inflammatory markers. We need to keep all these things in mind when we think about managing patients in the South Asian IgA nephropathy patients. So a retake on the multi-hit pathogenesis would be to consider effect modifiers which are South Asian ethnicity.
Please try to wind up.
Inflammation and occult GI infections, altered gut microbiome, genetics, epigenetics, and limited access to healthcare. Thank you.
Thank you, Dr. Saxena, for a very excellent and exhaustive coverage of the topic. Very nice, but because of shortage of time, we won't be able to take any questions. Thank you very much. And we move on to the next topic. The next topic is glomerulonephritis following COVID, and this will be dealt with by Dr. Divyesh Engineer, who is working at IKD Ahmedabad. I invite him to begin his talk.
Please do it presentation.
Okay. Good morning, everyone. Regarding the COVID-19 and kidney, it is very common to have acute kidney injury, with about 25 to 35% of all hospitalized patients admitted with COVID-19 have acute kidney injury. And the incidence may be much higher in ICU patient with up to 50%. And the most common biopsy finding that has been reported in literature is acute kidney injury. But now late, there are increasing case reports and case series that is now showing that even after COVID, apart from the acute kidney injury, the increased number of glomerular disease is also seen. So just like hepatitis B, hepatitis C and HIV, now COVID is also one of the cause of viral associated glomerulopathy. Now, which are the different glomerular diseases that are seen after COVID? The most classical is collapsing GN, then other podocytopathies like FSGS, minimal chain disease, ankylosing TMA, and other rare include membranous nephropathy, lupus, and MPGN. The biggest questions comes when we discuss regarding the GN after COVID. The main question is whether it is a definitely causal association or it is just a coincidence, because it has affected so many persons in the pandemic. And regarding the pathogenesis, what causes this disease, whether it is immune and inflammatory system activation that is very commonly seen in COVID patient, or it is because of the direct viral injury. If it is because of the direct viral injury, whether the virus affects glomerular cells, and if affects, then whether this affection of glomerular cells can cause glomerulonephritis. So regarding coming to the pathogenesis, there we have two pathogenesis. One thing is a direct viral cytopathic effect. So where possibly virus may be affecting podocytes, mesenchymal cells, endothelial cells, and causing GN. And other thing is because of the inflammatory mediators like cytokines. These cytokines, the levels are very commonly elevated in most of the COVID patients that can cause endothelial injury, complement activation, and glomerular injury. So with this endothelial injury and complement activation, it can cause thrombotic microangiopathy. With this endothelial injury, complement activation, and glomerular injury, it can also cause different types of glomerular disease also. So this shows different type of mediators that are very commonly elevated in COVID pneumonia. So in the COVID pneumonia, we have different cell activation like macrophage, dendritic cells, T cells, fibroblasts, and endothelium, and this that leads to systemic elevation of systemic levels of different mediators like interferon gamma, TNF alpha, interleukin 1, 6, and 18. And among this, interferon gamma and interferon alpha, they are very commonly associated with collapsing GN if the patient is having high risk apolipoprotein 1 genotype. Association with other type of GN is less common. Now, if we see kidney as a direct target of the virus, all we know that for virus entry into the host cells, the COVID virus requires help of the main pathway is by the basically ACE2 receptor attachment of the S protein, and with for this attachment it also requires the help of specific proteinase, that is a TMPRSS2. So host cell must have these two things on the cell wall for virus entry. Now if you see the expression of this AC2 and TMPRSS2 in kidney, the AC2 is mainly expressed in the proximal tubule, while the serine proteinase, that is a TMPRSS2, is mainly expressed in the distal tubule. There is very little expression of these two in podocyte, mesenchyme or endothelial cells. So probably this may explain why we see a lot of tubular injury and not that much GN in disease. But still there is some expression of these things in podocyte, mesenchyme and endothelial cells. So that may explain virus entry into the cells. So possible hypothesis how the virus reaches kidneys: there is a COVID pneumonia, then there is a viremia, and this virus enters the afferent arteriole and it first causes affection of the endothelial cells, and with this endothelial disruption the virus may involve mesenchymal cells and it may involve podocyte also, and this may cause this may be a possible mechanism of entry of virus into these cells and subsequent GN. Now regarding the evidence of renal tropism virus, there was one nice correspondence published in NEGM 2020 where they have done autopsy in patient those who have died of COVID. They have done quantitative virus estimation by RT-PCR in different organs. What they found was the highest level was seen in lungs and upper respiratory, but the virus is also found in the kidney also. And 6 of the patients, when they do microdissection and they estimated quantitative viral load by RT-PCR in different compartment, and surprisingly in out of the 3 of the 6 patients, in 3 patients they found significant amount of the virus in glomeruli also. So this may explain, probably virus may be culprit by causing direct injury to the podocytic cells. And they also confirm this with the in situ hybridization and also by the indirect immunofluorescence. Then there is a presence of viral RNA or virus protein in the glomeruli. But these were the first initial studies, but subsequent studies have shown mixed results where people have tried to analyze the presence of virus by different techniques like immunohistochemistry, immunofluorescence, RT-PCR, in situ hybridization. In the majority of subsequent results, they are not able to detect virus in the kidney tissues. So regarding coming to the public case series of COVID-19 and renal involvement, this was a published case series of 17 patients. They are published from US, and surprisingly the majority of patients have only mild COVID. They have only upper respiratory infection, and main indication of doing biopsy was basically AKI and significant proteinuria. And surprisingly, the most commonly associated GN was a collapsing GN, and that was followed by thrombotic microangiopathy, and very rarely it was FSGS and MCD. In second study also by from New York, where they have studied biopsy in 6 patients, all black patient, male patient, those who were having AKI and proteinuria, and in all patients what they found was a collapsing GN was the main disease, and all patients have high risk apolipoprotein 1 genotypes. So probably this COVID, if there is a genetic predisposition, then it causes this collapsing GN in black patient. And then subsequently there was a big series from the Paris where they have studied 47 patients of COVID. Majority of patients having mild to moderate COVID, and main indication of doing biopsy was basically AKI or proteinuria, and time of renal symptoms from COVID illness was like median was 18 days. So it was much early after COVID disease, and what they found was majority of patients has FSGS with main type was collapsing followed by non-otherwise specified and very rarely tip lesion. Other diseases were less commonly seen. So this also confirmed that the majority of patients they have collapsing GN. Now there have been, after this in last 2 years, there are a lot of case series and case reports have published. To summarize this all report, it was a summary of 158 native biopsies and 7 allograft biopsies, and where the main indication for doing biopsy was either AKI or proteinuria. Almost 36% of the case report and CDC have shown collapsing GN as a disease, and less other diseases like FSGS, other podocytopathy, crescentic GN, they are less commonly seen. And then comes to the largest study of that was published by Dr. May. That was a study of about 240 native biopsy and about 44 allograft biopsy. And what they have found was majority of glomerular disease was collapsing GN, about 25% of all patients, and rest diseases were very less common like TMA, IgA nephropathy, crescentic GN. And what they have found was in the majority of cases, about 60% patients, they have a high risk apolipoprotein 1 genotype, and they are not able to detect virus infection by in situ hybridization or ISC in any of the cases. So probably in a major study till date, virus has been not detected. So probably the inflammatory mediators and immune system activation is probably causing the glomerular disease. Now, in analysis of biopsy in our institute, we are not able to identify any particular case. So what we tried to do was we tried to analyze what was the biopsy diagnosis before COVID, that was in year 2019, and after COVID in year 2020, 20 and 21. So what we found was the blue bar represent biopsy collapsing GN diagnosis in year 2019, and this number suggests the percentage of total native biopsy. So in 2019 we have about 5% of collapsing GN. In 2020, it was a very less because very less biopsy was performed. And in the year 2021, there was an increase, there was a non-severe increase of up to 7.4%. In the thrombotic microangiopathy in 2020, in the year of COVID first wave, we have seen somewhat a non-significant increase of thrombotic microangiopathy. There was no change of month anti-GBM disease. So overall, in our experience, there are no much changes in the diagnosis of collapsing GN or thrombotic microangiopathy at our institution before COVID and after COVID. Now coming to the selected glomerular disease that are very commonly described, the most classical is collapsing GN. So the main histopathologic features are acute tubular injury, glomerular tuft collapse. Then in the EM, what we see was the extensive foot process effacement, and we can see the tubular reticular inclusion bodies in the glomerular endothelial cells. Now clinical cases, they are very typical. That include basically a moderate to severe proteinuria and AKI. So this combination is very common. Patients have a significant AKI and they have also significant proteinuria. And what we see in histopathology was podocytopathy or collapsing GN or both. In many of the cases, respiratory symptom may be mild, means most of the patients may have even mild COVID, not require oxygen at all. And in the majority of cases, they have either black patient, and in the genetic analysis, they have high risk APOL1 genotypes. So this was the summarized characteristics of around 50 patients. What they found was the median age was 50 years, majority were black males, and majority have high risk apolipoprotein 1 genotypes, and majority have associated comorbidity also like hypertension and diabetes, and it is very common to have renal failure at presentation, and even up to 58% may require dialysis. Now coming to what happens to this patient, those who have a collapsing GN after COVID. So there was a longitudinal study with follow-up of about 155 days. What they found was about 86% patients survived, 68% were dialysis free, and even 36% patients they have a partial remission of proteinuria, and almost 50% improvement in the 50% patients those who initially required were off the dialysis. So there may be, we need to wait for this patient, and the tubular injury that was commonly associated may improve with time. Regarding the whether in Indian we see collapsing or not, so because as in the literature from the US, majority are black patients, so I try to find whether there is a literature of APOL1 risk allele in Indians. So there was one study that was published in 2016 where they have analyzed about 159 Indian patients, and what they have found was none of the patients in India they have iris APOL1 hypothesis. So probably this may explain why the Indian we see less collapsing GN. So what is the treatment? Renal function and proteinuria in collapsing GN after COVID may improve up to 3 months. Acute tubular injury is present in this collapsing GN, so it is in up to 50% patient may improve and even may become off renal replacement therapy, and main treatment is a supportive renal therapy. There was no control study of immunosuppression, but it can be considered once the patient is out of the COVID symptom and the COVID symptoms, and if the patient is having persistent nephrotic proteinuria. Regarding anti-GBM disease after COVID, there was an interesting case series that was published from London where they have analyzed the last 10-year anti-GBM disease, and what they found was after COVID pandemic of 2019 there was almost 100% increase in the anti-GBM cases. So previously they were see about only 3 to 4 cases per year. In April 20 they have reported 8 cases. In majority of the 8 cases, all these 8 cases have a prodromic syndrome and 5 has a respiratory prodrome also, and all out of the 8 cases 4 has a detectable antibody to SARS-CoV spike protein. So this may explain the virus may be causing anti-GM disease. What is the problem? What is the proposed pathogenesis? The COVID pneumonia, it causes disruption of the collagen membrane. It may expose the unexposed epitope of non-collagenous domain, and it may lead to activation of the T and B cell and formation of anti-GM disease antibody, and it can lead to this anti-GM disease. There was interesting. There was also a case report from southern India where they have seen 4 patients of anti-GM disease from September 2020 to 21, and all patients, these patients have respiratory pulmonary symptom that preceded the renal illness by 4 to 8 weeks, and all have antibody positive, and none patient have alveolar hemorrhage, and all were treated with the steroid, cyclophosphamide, and plasmapheresis, and they have benefit. Regarding the thrombotic microangiopathy after COVID, there was a role of complement activation in COVID because in the biopsy diagnosis there was a deposition of mannose binding lectin, C3, C4 and terminal complement protein in the lung parenchyma, also in the skin parenchyma, and there was also some autopsy studies that showed complement deposition even in the peritubular capillaries. So there is evidence that the virus causes classical and lectin pathway activation, and it subsequently lead to complement activation. So this complement activation ultimately it may causes the renal injury, and it can cause thrombotic microangiopathy. So what is the treatment of the thrombotic microangiopathy after COVID-19? It is a mainly supportive care. We have to evaluate for the other predisposing factor like any medication, complement deficiency, antibody infection, and there are very little case reported series where they have done plasmapheresis or eculizumab they have used, but there is no evidence-based support to use these things. Regarding the ANCA vasculitis after COVID-19, there are about 6 patients they have reported, where 3 have like a PNCA and 3 have CNCA, and they majority have they have a mild respiratory disease and fever, and they have treated with the glucocorticoids, cyclophosphamide and plasmapheresis, and about 50% have shown benefit. So this may be a possible hypothesis where COVID there is excessive neutrophilic infiltration, and it leads to formation of neutrophil extracellular trap, and this contain MP and PI3 antigen, and this lead to loss of cell tolerance and generation of ANCA, and this may explain generation of ANCA antibody and ANCA disease after COVID. To conclude my talk, the dysregulated activation of systemic inflammation is the most likely contributor to glomerular injury. There is very less likely role of direct viral injury. Whether the virus directly cause glomerular cell injury and GN is unlikely, and immunosuppression may be appropriate in selected patient with persistent glomerular disease after the use of COVID-19. Thank you.
Thank you for that comprehensive discussion on COVID and glomerulonephritis. We have time for a couple of questions if anybody from the audience would like to ask. I'll ask you one question. Now that 90% of the population would be, infected with COVID, and all those who develop glomerulonephritis now, say in the next 6 months or so, is the approach to treatment going to change just because they had past history of COVID infection? Just to draw a parallel between HIV-associated nephropathy and the COVID infection.
It is from the different study, it is very difficult to draw whether it was a virus is responsible or even immune response to virus is responsible, because the subsequent most of studies they have not detected virus. So probably I think the treatment doesn't change, because usually this patient presents once they have recovered from the respiratory illness. So from treatment point, I think treatment with immunosuppressants remain the same, means that we have treated even pre-COVID era.
And is there any correlation with the antibody levels and the associated GN? COVID antibody?
I am not aware of that.
When would you advise biopsy in these patients? What would be the trigger? How much proteinuria, or so when should such patients be biopsied?
Mostly if because the if patient is not having not that much severe illness or COVID illness, and if they have significant renal involvement or significant nephrotic proteinuria, then the biopsy should be considered in these patients. Because those reported literature with GN, the majority have a mild illness. They have just the upper respiratory involvement.
So proteinuria more than 1 gram, or if there is a nephrotic proteinuria?
Probably nephrotic proteinuria and with or without involvement is an indication of biopsy.
And any glomerulonephritis or any renal involvement after vaccination? Any reports are there?
Similar like GN, there are a lot of case report. There are majority like basically there are a lot of case report of vasculitis after vaccination. Even then there was a relapse of different disease. But still whether it is a coincidental or causal, it is still not known in that entity also means. But there are a lot of published report. Even almost all GN new occurrence, de novo or relapse has been reported in after vaccination. Thank you, sir.
Thank you very much. Let's go on to the last presentation of this session on glomerular diseases. I invite Dr. Atul Sachgure, who is well known to all of us. He is a professor at the Department of Nephrology at D.Y. Patil Medical College. Many accolades and many awards to his credit. And let's hear from him regarding C3 glomerulopathy.
So good morning everyone, and my sincere thanks to chairpersons and the organizing committee of the West Zone for giving me this opportunity to speak on how I am going to present, how I am going to treat the C3 glomerulopathy patients. Where is the slideshow? Okay. So the contents of my talk are going to be a short case presentation followed by a short overview of complement system and C3 glomerulopathy, the available treatment options, treatment of my case, and the summary. So she's a 23-year-old female patient, married, symptoms only since 2 months, no history of any other major illness, pedal edema, facial puffiness, urine, generalized weakness since 2 months, and no other associated complaints. Blood pressure was 146/90, had anasarca. Systemic examination was normal. Urine albumin 4+ with active urinary sediment. Quantification of proteinuria revealed USER of above 15,000. Urine culture no growth. Mild anemia. Raised urea and creatinine levels. Serology negative. ANA negative. ANCA negative. C3 was markedly low, 33.9. C4 was normal, and USG revealed normal sized kidneys. So with membranoproliferative glomerulonephritis in mind, did a kidney biopsy which revealed 18 glomeruli, and the picture of the glomerulus is like this. It shows accentuation of the lobulation, increased matrix, increased cellularity, including neutrophils which are well appreciated under the microscope. Thickened glomerular basement membrane with double contours at places. 2 glomeruli showed crescents, cellular crescents. This was the pass stain, and silver stain was negative for spikes. The immunofluorescence showed granular C3 staining, and it was only C3 staining. There was no other immunoreactant that was positive on immunofluorescence. So unfortunately, the electron microscopy bit was very small, had only a small segment of a capillary loop, and could not demonstrate deposits. So this is the actual renal biopsy report, which shows 18 glomeruli with severe inflammation as described earlier, and C3 3+C3 deposits only in the on immunofluorescence. So the diagnosis was C3 glomerulonephritis, which is one of the subtypes of C3 glomerulopathy and disorder of complement dysregulation. So let us take a look at the complement system. Complement system, an essential component of innate as well as adaptive immunity with more than 50 components involved in the cascade reaction, important for opsonization and chemotaxis and inflammation and lysis of pathogenic organisms as far as the immune response is concerned. Out of the 3 complement cascade pathways, the classical and lectin pathways have very well-known triggers. However, we are interested in the alternative complement pathway. The terminal portion of all the 3 pathways are common, leading to the formation of terminal membrane attack complex, leading to cell lysis and tissue damage. The alternative pathway is spontaneously active in the circulation because of the highly strained thioester bond present in complement factor 3, which breaks it down to C3A and C3B. C3A is a chemoattractant, while C3B combines with factor BB, forming a complex. This is a C3 convertase, which again converts C3, breaks down C3 and amplifies the reaction, while increasing density of C3b leads to C5 convertase, leading to the terminal activation pathway, membrane attack complex. Now, it is essentially very important to keep this pathway under strict regulation in the fluid phase in the blood and also on the surfaces of the cells. One of the most important factors responsible for it is the factor H. And C3 glomerulopathy is a disorder of dysregulation of this pathway. The term was adopted in 2013 and it included 100% cases of type 2 MPGN which are described as dense deposit disease and almost 40% of type 1 and type 3 MPGN which were described as C3 glomerulonephritis. The prevalence and incidence is low all over the world, but I am sure it's going to be a little bit more in India and developing countries. It is characterized by deposition of C3 and cleavage products in the glomeruli. The diagnosis is essentially histopathological, and immunofluorescence studies show either dominant C3 deposition or C3 alone deposition, and dominant C3 means at least 2 orders of magnitude more than other immunoreactants. The deposits appear like semilinear and granular appearance they have, and there are 2 histopathological subtypes, dense deposit disease DDD and C3GN, that is C3 glomerulonephritis, which my patient had. In DDD, the deposits are highly electron dense, they are intramembranous. This disease is commoner in younger age group. It is less likely to respond to treatment, so diagnosis is important, and 100% recurrence after transplant. C3GN, the deposits are little less electron dense. They are in mesangium, in the subendothelial region, sometimes subepithelial. This overall is commoner than DDD. Response to treatment is better than DDD, and 60 to 70% recurrence after transplant is noted. Now, presentation, practically the whole spectrum of the renal syndromes can be presenting features of C3 glomerulopathy depending on the severity and the aggressiveness of the disease. Light microscopy again reveals a spectrum of features from normocellular or mildly hypercellular glomeruli to aggressive picture like my patient, endocapillary proliferation, membranoproliferative pattern, crescents, and sometimes sclerosis. Now, for the dysregulation, these are the factors that are important. There are 2 types of factors. One is genetic factors and the others are acquired factors. Genetic factors must be looked at because these factors are important because patients having abnormalities in the genetic factors are less likely to respond to the immunosuppressive treatment. So I advise genetic testing for my patient, but the couple refused because they had a social issue. They said that if the report comes positive, maybe the in-laws would press for divorce. So again, that is important in our scenario. So these factors are basically genes encoding for the complement factors 3, B, factor H, I, and there are so many others. Acquired factors are very well known. Antibodies against C3 convertase, these are C3 nephritic factors. Antibodies against C5 convertase, these are C5 nephritic factors. So both these nephritic factors stabilize the respective enzymes and lead to progressive activation of the complement pathway. There are other antibodies also present like antibodies to factor H, factor B, and there are so many others. Now, how will I investigate this patient further? I would do a comprehensive evaluation. The things that we commonly do are C3 and C4, but measurement of split products is important because C5b9 complex is also important in the prognostication of the disease and screening for autoantibodies, of course. So the biomarkers of aggressive disease will help us in treating the patients appropriately. Low C3 levels, high levels of C5b9 and high stabilizing capacity of C3 nephritic factors are important biomarkers. Now, how will I treat my patient? If a patient has a mild disease, that is proteinuria of less than 1.5 with mild hematuria and normal kidney function, I won't treat with immunosuppressive therapy as the literature suggests that it is not required. But basically whether I would observe and treat this patient, yes, because C3 glomerulopathy is known for not going into spontaneous remission. Most of the times it will remain stable for months or years, but ultimately it will progress to end-stage kidney disease. So supportive measures include healthy diet, lifestyle modification. ACE inhibitors and ARBs are questionable for RAS inhibition because these drugs lead to rise in renin levels, and renin itself causes hydrolysis of C3 can augment the disease. So that's why it has been suggested that maybe renin inhibitor would be a better choice for treatment of RAS inhibition. And of course statins as renoprotective agents, and I will closely monitor these patients as far as their BP, proteinuria and renal function is concerned. For moderate disease, that is proteinuria more than 1.5 grams per day or abnormal kidney function, I would definitely consider immunosuppressive therapy because the evidence goes in favor of that. Other treatment options for patients not responding to this treatment would be plasma exchange, anti-complement therapy, and certain newer experimental agents. Now, the best evidence so far we have got for this immunosuppressive therapy is the GLOSSIN study. This is a Spanish study, and 60 patients with biopsy-proven C3 glomerulopathy were treated for a median follow-up of almost 4 years. The median treatment mean treatment duration was 18 months. Out of the 22 patients with steroids and mycophenolate, you can see that 86% went in remission and none of them progressed to end-stage kidney disease. On the other hand, patients who received corticosteroids alone or along with cyclophosphamide, the remission rate was 50%, so that was not bad, but 3 patients, that is 17%, progressed to end-stage kidney disease and almost 40% had doubling of serum creatinine. And with no immunosuppression, this is important, that 1/3 patients progressed to end-stage kidney disease and no remission was observed. So this data is also supported by a retrospective study. This is a French study with 97 patients of C3 glomerulopathy with variable clinical presentations. And patients on glucocorticoid and MFF showed good results. Out of 42, 36% went into remission and progression to ESKD was only 14%, as against patients with glucocorticoids and any other immunosuppressive agent other than mycophenolate had 60% progression to ESKD, and patients without immunosuppression again had 65% progression to end-stage kidney disease. So these results are in favor of that, but the arguments are, like for example in the GLOSSIN study, in the Spanish study, they say that the complement evaluation and the genetic studies were not done in all the patients. 3 patients had genetic abnormalities in that study and all of them progressed to end-stage kidney disease, so they did not respond to immunosuppression. In this study, they are saying that in patients with no immunosuppression group, the patients were already older and had low kidney function, so they were more sick than patients in the other 2 groups. Also, the other concern is patients who respond to glucocorticoids and MMF, 33% relapsed after stopping the immunosuppression. So how long the immunosuppression should be continued? So I will continue immunosuppression indefinitely because there is still no data, and because the treatment, there is not going to be any spontaneous remission. I will continue to maintain the patient on low-grade immunosuppression based on the available evidence. The severe disease, I will do inpatient management, give pulse methylprednisolone oral followed by oral prednisolone 1 mg per kg per day until remission, then taper the doses and add mycophenolate or cyclophosphamide. Mycophenolate, my personal choice because of its safety profile and better results as per the literature. And this to be continued, as I said, I would continue them indefinitely to maintain the remission. Plasma exchange maybe is important, maybe an important treatment as far as severe disease is concerned. It may help. Theoretically, definitely there are points going in favor of plasma exchange, but it helps especially if a mutated protein is identified. It is not shown to be helpful in patients with C3 nephritic factors, presumably because the production of these factors continues even after removal of these antibodies. And there is a classical case report of a 15-year-old girl who had recurrent DDD after renal transplantation with C3 nephritic factors, continued on thrice weekly plasma exchange, and after 100 plasma exchanges when it was stopped, she maintained remission till then, and then the graft failed after stopping the treatment. Anti-complement therapy, theoretically, yes, it is appears very promising. Eculizumab, now we know that it is being used in all other complement-related disorders. So there are some case reports and case series. This study of 6 patients of post-transplant recurrent C3 glomerulopathy, out of them 3 had DDD and 3 had C3GN. 1 patient in each group responded to the treatment, and they found that maybe elevated soluble C5b9 level maybe is a marker, and it will probably predict response to eculizumab. Now the novel therapeutic agents still undergoing trials. These are all targeted against the activation of complement pathway and against the various factors including the C3 and C5 convertases. And now what I would do is basically, since these are not available, if at all, if I get to know that one of my colleague is doing a trial on this, it's participating in a multinational trial, I will recommend my patient to participate in the trial and would ask the patient whether he or she would like to do the participation. Now let's take a look at the clinical course of my patient. I did the biopsy on 5th December 2020. Symptoms, patient came to me in the last week of November. BP was 131 by 86 again on the follow-up on the day of biopsy. Creatinine was slightly high with very high UACR. After the biopsy, started patient on 1 mg per kg approximately, prednisolone oral 60 mg. After 4 weeks, the albuminuria started decreasing, creatinine reduced, blood pressure was better. reduced the dose to 40 because we had cosmetic concerns. Remember, 28-year-old young lady, recently married. Mycophenolate was added as a steroid sparing agent, and olmesartan was started because at that time I was not really sure whether olmesartan will worsen and whether I should be starting aliskiren. After 8 weeks, albuminuria decreased, prednisolone was further tapered, and I went on increasing the dose of mycophenolate sodium just to cover the tapering of steroids. At the end of 14 weeks, C3 was normal, BP was okay, so amlodipine was not required at that time. Creatinine was normal, UACR was 44, and I switched her to deflazacort again because of cosmetic concerns, and there is no literature of deflazacort in maintenance of remission available for the C3 glomerulopathy. So she maintained such status, and at the end of 9 months after the biopsy, the couple came and said that they wanted to plan a pregnancy. So BP was normal, creat was normal, UACR was again normal. So I switched her back to prednisolone because I didn't know how safe deflazacort would be in pregnancy. Immediately stopped mycophenolate and olmesartan and switched the patient to azathioprine. Maintained very well. Pregnancy was diagnosed 15 months after the kidney biopsy. And at present, the patient has 31 weeks gestation, and anomaly scan is normal. Fetal growth is good. She is in remission. UACR is borderline 60.69, but it's okay. Prednisolone dose is just 2.5 milligrams and azathioprine is 50 milligrams. So I'm hoping for the best possible outcome and good news soon. So to summarize, C3 glomerulopathy is a rare disease with no spontaneous remission, so treatment attempts should be made. Antiproteinuric and renoprotective treatment should be given in all classes, especially for the mild disease where immunosuppression may not be required. Immunosuppression is, I guess, it is worth trying irrespective of presence or absence of genetic factors. That is because, just like in my case, genetic study was not done, but it worked, and there is nothing else that we have in our hands to improve the patient's condition. So immunosuppression should be tried. I would recommend steroids and mycophenolate, and the duration, again, as I said, cannot say when to stop, and we can continue and maintain it as long as possible. Plasma exchange and anti-complement therapy may benefit certain severe cases, like for example plasma exchange in those with mutated proteins and anti-complement therapy in those with circulating high levels of C5b9 complexes. So there are another thing that I want to discuss. In developing countries like us, we should, I think, look at certain other products that are naturally existent complement inhibitors. One of them is glycyrrhiza glabra, which is commonly known as yashtimadu or jeshtamad in the common language, commonly used in the alternative medicine. The side effect profile is very well known, and it has anti-complement activity that has been documented in certain studies. Another product is rosemary. It also has anti-complement activities. So our patients who are maybe may not be able to afford the costlier treatments, we should actually promote trials for these agents. Thank you.
Thank you, Dr. Atul, for finishing exactly on time. We have time for 1 or 2 questions. Yes.
Great presentation, Atul. Just one question. Earlier, when we were talking about treatments of MPGN, we thought that mycophenolate is not an effective molecule. Except for some small studies, it has really not worked. So any mechanistic reason why you think that C3GN is responding better to MMF?
Actually, the only reason is basically the studies that have shown that only 2 studies have shown good results. There are other 2 studies, but the numbers are small. And definitely, probably we are looking at those patients with genetic problems. Those are not responding to mycophenolate. So those patients who have autoantibodies are likely to respond well to mycophenolate. So I think that should be, it is worth giving a trial. So, as you said that when we were treating patients with MPGN, again there could have been the same category of patients with some genetic defects, and we were not able to detect those because we never did any test for that. So probably we might be having in India a bigger population of genetic abnormalities, and that Indian study will help us tell whether mycophenolate will be really helpful. So at least in my patient it worked. and I guess it is at least worth trying because no other immunosuppression has shown good results as good as mycophenolate. It is available. It is available.
Just one question about
Sir, sir, how often do you see C3 glomerulonephropathy progressing to HUS?
Progressing to HUS. See, basically this is a complement mediated disease, so there is a whole spectrum. There could be an overlap. Now what the literature says is that the disease prevalence is so low that the exact data is still not available. And in fact, I think we would be having more cases than the Western countries because as such we have more glomerular disease patients than Western countries. So we would be diagnosing it more since we are now aware of it. And we'll only come to know in coming future whether this is one of the part of the spectrum of complement mediated diseases and can lead to thrombotic microangiopathy in severe cases.
Yeah, one last question. Regarding mild disease and the conservative therapy which you suggested, those people who have hematuria and proteinuria less than 1.5 grams, how likely they are going to progress? Because some of them do progress.
They will not definitely going to go in remission, so they are likely to progress. So monitoring becomes important. So either you treat them with supportive treatment and monitor them. If you feel that the disease is progressing, start immunosuppression. And if the disease doesn't progress, then at least maintain a low level of proteinuria, low level of microscopic hematuria with normal renal function can be accepted with supportive treatment.
Thank you, Dr. Atul, for this wonderful lecture. And
thank you, sir.
We have started off this program trying to finish on time. We thank the organizers for giving us this opportunity to chair, and we can move forward.
Thank you. Thank you to the chairpersons as well as all the speakers. Requesting the chairpersons and the speakers of this session to kindly proceed to the stage up front for the felicitation so we can save on time. Requesting the chairpersons and the speakers to kindly proceed to the stage up front. Yeah, sorry, sir. For the felicitation. Just some small announcements. To all the speakers and the participants of Lalit Shah Award session, which is going to be there in the next session. Kindly upload the presentations in the preview room outside, which is set up outside. For the poster session, which is between 3 to 4 p.m., requesting the participants for the award session to kindly upload their poster in Chitrakut Hall. And for the non-award session in the dome area, that is the trade area, by 2 p.m. For the third session, which is again a very interesting session till they set up the stage, I'll just brief you about the session. So this part of the session resembles a courtroom debate where we are going to invite the accused and the defendant to defend their acts by providing all the essential facts and evidences before the court. A prosecutor to question the suspects and to lead the investigation. Judges to preside over the court proceedings and to ensure that the trial is done fairly and transparently and to decide whether the accused person is guilty or innocent based on the evidences given. And then to give the final verdict. For the first case, which is early initiation versus late initiation of hemodialysis, I call upon the judges, Dr. Shishir Gang, who is the chairman, the Department of Nephrology, Mulji Patel Urology Hospital, Nadiyad, and Dr. Niranjan Ambekar, consultant nephrologist and a transplant physician, Pune, who is again organizing the ISN in 2022 in December. Requesting the judges to kindly announce the prosecutor and the accused and the defendant.
You want this, sir? Oh, yeah. Ready?
Good morning, everybody. Welcome to our Adalat. So, it's really great to have this organizing committee discovering new methods of having debates. I think we should give them a big hand. So, today it gives us great pleasure. The topic of this Adalat today is early or late initiation of dialysis, which is better. And the main person is Dr. Umesh Khanna. Please give him a big hand and welcome him. Dr. Umesh Khanna is a consultant nephrologist and founder, director of Kidney Associates Mumbai, founder and chairman of Mumbai Kidney Foundation, trustee of Corep Trust and Sapiens Health Foundation, past secretary of Mumbai Nephrology Group. He is a pioneer in setting up dialysis centers, and he was conferred the Dronacharya Award for Excellence in Teaching. That's all. This is, and the participants, Dr. Mukesh Shetty, you are the first to come on to the dais, and Dr. Mukesh Shetty will speak on the early initiation of dialysis, its advantage.
No, but I want both. Ek bar.
And Dr. Tukaram, welcome Dr. Tukaram on to the... I don't know whether you should call it welcome or not. Doctor, sir, are we ready? The prosecutor? Yes, yes.
Hello, hello. Yeah.
Order. बड़ा संबर नहीं, यहाँ की ऑर्डर. Let the prosecution begin.
धन्यवाद, my lord. जिंदगी में बहुत सारे कठिन काम किए हैं, लेकिन अपने ही ऑनरेबल कलीग्स को लाइफ में कभी प्रोसिक्यूट करने का मौका नहीं आया। और मुझे लगा था द साइंटिफिक कमिटी एंड द ऑर्गेनाइजिंग कमिटी चेयरपर्सन्स आर माय फ्रेंड्स। इफ यू हैव फ्रेंड्स लाइक दिस, I am sure Jatin Kothari must be feeling the same. To prosecute your honorable colleagues is a very arduous task. जज साहब, आप लोगों को बधाई हो कि आप लोगों ने मोदी जी का सुन के कॉलोनियलिज्म का वो जो विग वगैरह नहीं पहना, that was a good gesture on your part. थोड़ा सावधानी बरतने के लिए एज अ प्रोसिक्यूटर मेरा फर्ज है कि आप तमाम सबूत और दलील को मद्देनजर रखकर ये फैसला करोगे, ना कि इन लोगों की जो ब्रांड इमेज है उसको सुन के। आपको कहना चाहूंगा कि डॉक्टर मुकेश शेटे नॉट ओनली इज एन एक्सेलेंट नेफ्रोलॉजिस्ट, इज अ ग्रेट टीचर, बट वो एक ड्रामाबाज भी हैं, ड्रामा बहुत बढ़िया करते हैं। ही इज अ ग्रेट मिमिक्री आर्टिस्ट, और आई एम श्योर वो इवन ओपोनेंट की मिमिक्री करके आपको कंफ्यूज कर सकते हैं। सो कीप इन माइंड। डॉक्टर तुकाराम जमाले, मैं जानता हूं कि आप संत तुकाराम जी के भक्त हैं, और तुकाराम जी ने भी एक अपनी छवि जमा ली है जिसमें उन्हें तो गीता के ऊपर हाथ रखने की भी जरूरत नहीं है। लोग यही समझेंगे मैं जो कहूंगा सच कहूंगा और सच के सिवा कुछ नहीं कहूंगा। चलो दोस्तों, जजेस ने ऑलरेडी कार्यवाही करने की तैयारी दे दी है, तो सबसे पहला सवाल हम डॉक्टर तुकाराम जी से पूछेंगे। डॉक्टर तुकाराम जी, आपके ऊपर इल्जाम है कि आप शुरू से ही लेट डायलिसिस के बारे में बातें करते हैं। जब पूरी दुनिया इलाइन ट्रायल सुन के AKI के लिए अर्ली डायलिसिस की बात करती थी, तब भी आपने तो ऐलान कर दिया कि डायलिसिस जल्दी करने की कोई जरूरत नहीं है, टाइम पे की जाएगी जब उसकी जरूरत होगी उसमें। तो क्या ये आज का जो डिस्कशन हो रहा है CKD में, अर्ली डायलिसिस वर्सेस लेट डायलिसिस, और आप बोल रहे हो कि अर्ली डायलिसिस नहीं करनी चाहिए, उसके कोई सबूत हैं आपके पास? आप तो एक आइडियल नेफ्रोलॉजिस्ट हैं, तो ये आइडियल ट्रायल के बारे में कुछ बताओगे क्या है ये?
पहले तो मुझे ये इल्जाम बिल्कुल मंजूर नहीं है कि हम लेट का
long term. It has noted to have a prevalence of 6 to 60% in different parts of the world, and in India, various studies showed a prevalence of 4.3 to 45%. Earlier, the HCV treatment used to be complicated, including ribavirin, which used to cause anemia. Now, with the advent of directly acting antivirals, the therapy of HCV has revolutionized. But there is a paucity of data regarding safety, dosage of the drugs, and especially sofosbuvir in stage 4 and stage 5 CKD. So, according to the available data, there is no dose adjustment required in CKD patients for the directly acting antivirals. Drugs like elbasavir, grazoprevir, glicopavir, preventesavir has been studied abroad for stage 5 CKD, and sofosbuvir regimens have been also studied, and latest KDIGO guidelines has shown a high evidence for the use of sofosbuvir velpatasvir in patients on hemodialysis. So our aim was to study the efficacy of sofosbuvir velpatasvir and in attaining end of treatment response at 12 weeks after start of treatment in maintenance hemodialysis patients. Our secondary objective was to determine the safety of this drug. We contemplated a sample size of 100 with a HCV RNA quantitative PCR positive. We recruited patients from multiple dialysis centers all over India. Patients were given sofosbuvir velpatasvir for a total duration of 12 weeks daily after dialysis. HCV quantitative viral load by PCR method at the start of treatment, and 12 weeks of treatment were done. CBC, SGOT, SGPT at baseline and at 12 weeks of treatment were done. So it was a prospective observational cohort study. All the CKD patients on maintenance hemodialysis thrice per week for at least 3 months prior to the inclusion study were included. Patients who had been diagnosed as HCV positive by HCV antibody ELISA method or who had elevated liver enzymes on screening were included. Patients less than 18 years of age, pregnant patients, and patients with decompensated CLD were excluded from this study.
So a total of 225 patients were screened based upon the anti-HCV ELISA, SGOTPT and SGPT. Among them, 123 patients were recruited who had detectable HCV RNA viral load. Among them, 102 patients were excluded who had negative RNA PCR. 106 patients completed the complete course of 12 weeks of treatment, and among those 17 lost to follow-up or either expired. Among them, 9 expired and 8 lost to follow-up. Among 123 patients, 106 patients completed the treatment. The male to female ratio was 3.82:1. Average age of the cohort was 53. This was the data regarding the anti-HCV antibody reactive by ELISA method in all the patients included. Among them, 107 were anti-HCV antibody ELISA reactive and 16 were negative. The negativity might be due to antibody responses because the antibody response is compromised in patients with hemodialysis, and second being the window period, that is the period between acquiring infection and production of antibodies is prolonged. So at the end of 12 weeks, this was the end of treatment response in all the patients. That is 89% of the patients responded and had a non-detectable viral load at the end of 12 weeks, and 11% of the patients had a detectable viral load. No major treatment related adverse events were reported during the study. Only one patient had to discontinue the drug due to GI side effects such as nausea and vomiting. So this is the available data regarding the safety and efficacy of this drug. The study done in Taiwan, which had a sample size of 105, showed a SVR of 89.4%. Study done in India by Taneja et al. Had a sample size of 51, showed a SVR of 96%. Bogia et al., which was done as a multinational study, recruited 59 patients, showed a SVR of 94.9%. Gore et al., which was a retrospective study, including 31 patients, showed a response of 96.7%. And one study done in 2021 in Taiwan, which had sample size of 117, showed 94.9% SVR, and our study showed a end of treatment response of 89%. So sofosbuvir velpatasvir is very commonly used in HCV patients. No large cohort studies have been done to study the efficacy and safety of this combination. In our study, end of treatment response was 89%. Majority of the patients showed no adverse events, and sofosbuvir velpatasvir being a pangenotypic combination, it is a very cost effective. So treatment with Sofvel combination for 12 weeks was safe and effective in patients with ESRD on hemodialysis. This study was supported by unrestricted grant from Apex Kidney Foundation. This study is the largest till date from India for use of Sofvel in hemodialysis patients. All patients were given Sofvel combination free of cost for a period of 12 weeks. Study related investigations were also done free of cost. The tablet used was of Sofocure V of MQ Pharma. Thank you.
Thank you, Aditya. That was a very well done study. So where was the HCV genotype tested for all
No,
these
ma'am, we
patients?
didn't test it because of the cost considerations.
What do you understand by early virological remission and sustained virological remission?
Sustained virological remission is which we see 12 weeks after the end of treatment. If the patient has non-detectable, it is called SVR after 12 weeks of end of treatment.
So what is ETR then? What is
ETR is after completion of 12 weeks of completion of treatment is the end of treatment response, ma'am.
So you said there were about 11 patients who got lost to follow-up or expired.
Yes, ma'am.
What do you understand by intention to treat analysis versus per protocol analysis?
Yes, ma'am.
What do you understand by intention to treat analysis versus per protocol analysis?
No, ma'am.
Was there any relationship of the drug to the viral load?
Ma'am, we did a viral load among the who responded, who not responded. There was no statistical difference between the both.
Why did you have a control group?
No, ma'am, we didn't have a
Why
control.
did you decide not to have a control
Ma'am,
group?
because it would be not feasible to not treat a patient with HCV without who has a detectable viral load in a body.
What do you understand by post-trial access?
Post
Trial access.
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 How much was the range of quantitative HCV RNA?
Sir, the average was 13.5 into 10⁵ international units per ml.
Whatever the level was there, positive level, you treated these patients?
Yes, whatever the positive level, if it was detectable, we treated those patients.
Okay. And no liver biopsy was done?
No, no.
Okay. And what was the percentage response?
So 89% at the end of treatment.
Okay.
Thank you.
The next presenter is Dr. Gauri Kulkarni. She's from Jupiter Hospital, Thane.
Hello. Good afternoon, everybody. Respected chairpersons, my teachers and my fellow colleagues. Today topic of my presentation would be Today the topic of my presentation would be kidney involvement in multiple myeloma, our experience since last 2 years. As we know, the kidney involvement may be a presenting feature in patients with multiple myeloma. All compartments of the kidney get involved and patient will have varied presentations. We present last 2 years experience of our patients who presented to us primarily as a kidney involvement and which later on evaluation were found to have multiple myeloma. Objectives of the study were to study the clinical spectrum of the kidney involvement, to explore the clinical presentation, laboratory findings, pathological features and treatment. Clinical outcome was recorded and multiple myeloma presenting as primarily as a kidney disease to the nephrologist cases were studied. It was a prospective single center study. We included patients who were diagnosed as multiple myeloma according to the International Myeloma Working Group. Patient underwent serum electrophoresis, immunofixation, serum free light chain assay, bone marrow aspiration biopsy along with immunophenotyping. Renal involvement was diagnosed as per structural involvement and functional impairment. Syndromic diagnosis was made and kidney biopsy was done whenever it was indicated. Patients were treated as a team with hematologist and they were followed up at least 90 days of follow-up was given. Our results were 10 were male and 11 patients were females. Age ranged up to from 45 years to 83 years, mean being 67.8 years. More than 50% of the patients had diabetes, followed by hypertension in 11 patients. The presenting features: 1/3 of the patients had rapid progression on pre-existing diabetic kidney disease. 6 of them had acute kidney injury and 5 of them had acute kidney injury on chronic kidney disease presentation. Remaining would have nephrotic syndrome, subnephrotic proteinuria, and 1 presented with asymptomatic urinary abnormality. While studying the lab parameters, the majority of them had presented with increased serum creatinine. 18 of them had anemia, of which 4 of them had presented with refractory kind of anemia. And the conventional parameters are high protein gap, hyperkalemia were present in 6 and 5 patients. 4 patients presented with hypercalcemia and 3 presented with hyperuricemia. Most of them had acute kidney injury, had multiple precipitating factors. Some of them had, majority of them volume depletion, infections and nephrotoxic drugs were present in 3 and 4 patients, and 1 patient presented with contrast associated nephropathy. When the myeloma characteristics were studied, on serum protein electrophoresis, 1/3 of them had absent M band on serum protein electrophoresis. Bone marrow biopsy results showed more than 10% plasma cells in 19 patients, and 2 of them had less than 10% plasma cells. The commonest type of myeloma was IgG kappa type, followed by IgG lambda type. And 1 patient had MGUS, and light chain deposition disease was present in 1 patient. 2 of them patient presented with amyloidosis. Along with the supportive treatment and the renal replacement therapy whenever indicated, the patient's treatment received were cyclophosphamide, bortezomib and dexamethasone in 15 patients. 4 patients received lenalidomide, 1 patient received daratumumab, and 1 patient is currently on surveillance. Hematological remission was achieved in all of them. 4 of them had relapse. The acute kidney injury returned to the baseline in 6 patients, and 6 patients progressed to chronic kidney disease. Out of 21 patients, 6 patients require hemodialysis as a treatment option, out of which 5 of them remain hemodialysis independent, and 1 patient is currently hemodialysis dependent. I would like to share my take-home message from our study is the elderly patients who are presenting with rapidly progressive declining renal function with anemia. Multiple myeloma is an important cause to be ruled out. High index of suspicion is required, and it is becoming a common cause of non-diabetic kidney disease in elderly diabetic patients with kidney involvement. Characteristics finding such as high protein gap, hyperuricemia, hypercalcemia were absent in significant number of patients, and only serum protein electrophoresis is not enough to diagnose the multiple myeloma, as 1/3 of our patients had absent M-band. It should be combined with a serum free light chain assay for a better sensitivity, and bortezomib based therapy has changed the outcome of multiple myeloma, that is all of them has achieved a hematological remission. Thank you.
So how many out of 21 patients, how many required dialysis at the time of diagnosis?
So 6 of them required hemodialysis.
No, at the time of diagnosis.
So all of them required at the time of diagnosis only. They presented with a severe acute kidney injury.
They presented with advanced renal failure.
Yes, sir. Yes, sir.
And how many kidney biopsies were done out of 21?
So we did 3 kidney biopsies, out of which 1 patient had presented with nephrotic syndrome, and subsequently he was found to have amyloidosis. 1 patient presented with rapidly progressive renal failure, and she had a progressive proliferative glomerulonephritis, and she was found to have light chain deposition disease. And
the classical like myeloma kidney findings, how did you see that finding on biopsy?
Actually, sir, the majority of the patients presented with severe renal failure with heavy light chain assay, heavy light chain load in the blood. So we treated with the standard therapy, and probably they were cast nephropathy because there were reversibility after the treatment. So we did not do biopsy in them.
And your treatment was uniform in all patients, like bortezomib plus steroids?
So actually, we treated as a team with hematologist. It was.
Did you treat with these 2 drugs, or did you add that thalidomide also, furosemide?
So it was treated with multiple regimens, like the Cybordi regimen, that is cyclophosphamide, bortezomib, along with lenalidomide.
Any use of this filter for removal of light chains?
We didn't do that.
Theranova?
We didn't do.
Highest level was 30%. This.
Pardon, sir?
Your level, highest plasma cells were 30% only. You didn't have more than 30% in any patient.
So we we categorized the patient like more than 30%.
How much was the highest level of plasma?
It was 60 to 70%. Okay. Yes, sir.
And even those patients also recovered after therapy?
Yes, sir. Those patients recovered.
Thank you for that presentation. There were 3, there was 1 patient who had less than 10, so you have said,
yes ma'am, yes, please tell me.
You have said that it's multiple myeloma, but you have also included MGRS. Yes, yes, ma'am. Yes.
So then, shouldn't you have changed the title?
So, ma'am, broadly the
Because
study
you
was
included one MG-US also, I think. I saw that
Yes,
one
ma'am.
MG-US
Yes,
was
ma'am.
included, MG-RS was included
Yes,
with multiple myeloma.
Yes, ma'am. The basic message I wanted to share was to diagnose the multiple myeloma. So the title was changed to multiple myeloma.
And you had told us that in the beginning of your presentation, you had told us that you're doing kappa lambda and immunophenotyping and electrophoresis for all patients, but we didn't see any of those results for those patients. Was there a reason why you didn't put it up?
Actually, I wanted to stress upon the clinical presentation message, to share the message of clinical
Even the
presentation.
treatment, you have not really put any slide. You've just said standard treatment. You've not put any slide on what kind of treatment it was.
Only one.
Yeah, it was just standard treatment given.
could
There's no
have-
standard treatment. Treatment varies from center to center and depending on the experience of the center. What is the role of lenalidomide in treatment of multiple myeloma? And what is the role of bone marrow transplant in the treatment of multiple myeloma?
Lenalidomide, the patients, we set on the second line therapy where the patient, the first treatment of choice would be cyclophosphamide, bortezomib and dexamethasone. And in some patients in whom we cannot give the cyclophosphamide, we would prefer for lenalidomide.
So there was one biopsy which you told us that there was proliferative lesions and you
Yes,
had
ma'am.
classified it as light chain deposition disease.
Yes, ma'am.
So why didn't you classify it as PGNMID? What is PGNMID and how is it different from light chain deposition disease?
Can you please repeat the question?
PGNMID. It's
Yes,
an acronym. You'll have to expand it.
Yes. This is, it is a entity which is synonymous with light chain deposition disease, but it's a biopsy finding that is proliferative glomerulonephritis.
Thank you.
Thank you, sir.
Now I invite Dr. Ankur Mittal from Nadiad.
Good afternoon, everyone. I am presenting my study of 1-year outcome of kidney transplant recipients harboring complement regulatory gene mutations. So, thrombotic microangiopathy is an occlusive disorder of the microvasculature characterized by thrombocytopenia, systemic or intrarenal platelet aggregation, hemolytic anemia caused by fragmentation of erythrocyte due to disturbed microvasculature secondary to platelet aggregation and thrombus formation. Post-transplant thrombotic microangiopathy affects 0.8 to 14% of the recipients and is associated with poor graft as well as patient outcome. It can be either de novo TMA or the recurrent TMA. De novo occurring for the first time without any evidence prior to the transplant. It has an incidence of 1.5% commonly occur during the first 3 months of the transplant, and the recurrent where the native kidney disease have failed as a result of TMA. The mutation in gene for complement regulation have been described in patients with atypical HUS, and the incidence of TMA in the Indian renal transplant patients was reported to be 1.1% and 9.1% in the biopsy studied from the post-transplanted kidney. So aims and objective of my study was to ascertain whether there is an association between the post-transplant TMA and the risk of graft failure in renal transplant patients harboring mutations in gene encoding complement regulatory proteins. So it was a single-center prospective observational cohort study conducted in Muljibai Patel Urological Hospital, Nadiad, from October 2019 to July 2021, and patients were followed up for 1 year beyond the last enrollment. All the patients who underwent live donor renal transplant at our center were included, and those who did not give the consent was excluded. MLPA and clinical exome sequencing was performed to confirm the genetic mutations, and the sample size was calculated using the online tool, and that was 76. The IBM SPS 25 software and Microsoft Office Excel were used to carry out the statistical and graphical analysis. So total 158 patients underwent transplant at our center, where 20 patients did not give the consent and 138 patients were recruited. Out of those, 93 had the undetermined native kidney disease and 45 had the established cause of renal disease prior to the transplant. Out of 93, 13 had the unspecified histology of 8 showing CGN, 8 6 glomerulosclerosis, 2 TMA, and 1 patient had advanced renal damage. 9 patients had congenital or hereditary kidney disease, and non-hereditary kidney disease include the diabetic kidney disease, IgA nephropathy, FSGS, membranous nephropathy, obstructive uropathy, granulomatous CTID, and lupus nephritis in one of the patients. This is the demographic and clinical characteristic of the patient, with recipients mean age of 36.39 years with a donor of 49.48. There was a predominantly male population of transplant 109 male and 29 females, with a genetically related donors for 96 and mean EGFR of the donor was 104. There were 14 blood group incompatible transplant, and 81 patients did not receive any immunosuppression, and remaining patients received either ATG, basiliximab, or followed a desensitization protocol. The mean total ischemia time of the surgery was 72.87 minutes, with a donor-specific antibody in class 1 in 6 of the patient and class 2 in 13. So this is the most important slide I would like to focus on, where total of 96 out of 138 patients had a mutation for either complement factor H gene or the complement gene or any other gene related to the AHUS. Out of these, the 93 patients who had the undetermined etiology, 47 showed the duplication, 9 with homozygous deletion and 4 with heterozygous deletion, 2 CFH, 1 CFI, 2 MCP, 1 DGKE, and 1 PLG plasminogen gene mutation. Out of these, 2 patients with homozygous deletion had the post-transplant TMA, and 1 with heterozygous deletion had the TMA, and 1 patient with CFI mutation had the TMA and he lost his graft secondary to it, and 1 patient with plasminogen gene mutation also had the TMA. Coming to the IgA nephropathy, total of 5 patients out of those 2 patients, 1 with duplication and 1 with homozygous deletion, developed the post-transplant TMA, and 1 patient with FSGS in a primary disease developed TMA and he lost his graft, and he had a duplication of gene in the reports. Coming to the CRG mutation, out of 72, 2 patients in duplication developed TMA, 4 out of 14 in homozygous deletion, 1 out of 5 in heterozygous deletion, and 1 out of 2 patients of CFE mutation developed TMA and plasminogen gene, 1 patient he had a post-transplant TMA. So the incidence of post-transplant TMA was nearly 8% in this study, with the incidence of complement regulatory gene mutation in patients of post-transplant TMA was nearly 80%, that was significantly high, with a graft loss secondary to TMA was seen in nearly 1/4 of the patients. So this is the comparison of EGFR at the end of 1 year, where between the patients having mutation and those who did not have the mutation, that was not significant, with a p-value of 0.118, and total 131 patients were followed up to the 1 year, and 6 patients lost his graft. So I would like to conclude that the prevalence of complement regulatory gene mutation in patients with ESRD is particularly high, although the association of these mutations with the underlying CKD is uncertain. Association of duplication in CFHR gene with TMA was poor. However, the deletion, either homozygous or heterozygous of CFHR, was seen in around 1/4 of the patients of post-transplant TMA. The graft function at the end of 1 year was similar between the patients having mutation in CRG and those who do not have the mutation. Therefore, the presence of CRG mutation should not preclude the option of renal transplantation in a patient with end-stage renal disease. To our knowledge, this study is the first of its kind in the Indian transplant population to look for the association between CRG mutation and de novo TMA after kidney transplantation. Thank you.
The patients who had CRG mutations and patients who had TMA, around maybe 8%.
9 out of 11, sir.
So were the same, these were same patients or these were different patients?
These are the same patient. Out of the total 138, the 11 patients.
The patients who had TMA, they were having these mutations?
No, they were having this mutation. 9 out of 11 patients had this mutation.
So only 2 were unrelated to this?
Yes, 80%, yes, sir. Only 2 patients did not have the mutation and they had a post-transplant TMA, sir.
What do you understand by MLPA?
Sir, ma'am, it's a multiplex ligation probe analysis. Primarily, we do it for look for the copy number variation, which is usually missed by the NGS, and for the particular gene like CFHR, the more common mutation that is seen is the copy number. So for that particular reason, we did the both MLPA as well as clinical exome in this study to confirm the CFHR as well as other complement gene mutations.
What do you understand by the terms SNP and indel?
I'm not sure of that.
In your population, you have, so was there any difference in the treatment of patients who had mutations versus who had no mutations?
No, ma'am. We did not make any intervention or any change in the treatment as far as mutations were concerned.
So there was no prolongation of treatment, no repeating of...
No, ma'am.
Nothing? It was all similar between those who had mutations.
Yes, we did not make any intervention particularly pertaining to treatment.
And your baseline and your outcome also was similar in the two
In both the groups with mutation or without mutation, the eGFR at the end of 1 year was similar in both the groups.
Do you know what is the baseline frequency of these mutations in the population that you studied?
Ma'am, the study from Pakistan and Sub-Saharan Africa, both...
No, those you may not be able, you need to have it.
The Indian data we don't have. The population frequency of these mutations in the Indian data we don't have, but in Pakistan one study was there which shows the frequency of 48% in general population.
Yeah, so then...
Percentage? 48% in general population, the duplication of CFHR gene.
48%?
CFHR, yes ma'am.
What do you understand by genetic polymorphism?
I'm not sure.
Can you call that 48% genetic mutation?
Ma'am, that could be as per ACGMI, it might be a variant of uncertain significance with no impact on the clinical outcome of any patients.
So if you think that this genetic mutation has not made a difference in your treatment as well as in your outcome, would you recommend genetic testing in donor population? And if you find a mutation, how differently are you going to counsel the patient?
One is we can counsel them regarding the recurrence of the disease if we know the primary disease of the patient. Second is the risk of like CF, if we found any particular gene mutation, not just the CFHR gene, the CFI, CFB, or like PLG gene, those patients lost his graft. And second thing, these patients are prone for TMA post-transplant, particularly due to tacrolimus-induced or infection-induced or ABMR after the transplant. So we can counsel them regarding the same.
Thank you.
Next, Dr. Apurv Bagade from Pune.
Good afternoon, everyone. My topic is impact of pandemic on the decision and histology outcomes of percutaneous native kidney biopsy, a retrospective study. As we all know, COVID-19 pandemic has led to widespread disruption of routine healthcare services. At our hospital, there was a conversion of a separate building into a COVID-19 center. There was diversion of hospital staff and doctors to dedicated COVID center by monthly rotation. There were protocols for restriction of hospitalization for elective surgeries and procedures. So we assumed that there was a delay in diagnosis or worsening of renal function for kidney patients. And kidney biopsy procedure was indicated when there was need for a prompt diagnosis as urgent indication or as a guide for management as a non-urgent indication. We conducted the present study to determine the impact of pandemic on the decision and histology outcomes of percutaneous native kidney biopsy. So it was a retrospective observational study. We divided the study period into two parts, pre-pandemic from Jan 2018 to December 2019, pandemic from 1st Jan 2020 to December 2021. Data of all the patients who underwent kidney biopsies during the study period were retrieved and their demographic, clinical and lab parameters were extracted. We excluded cases of pediatric patients and biopsy of renal mass. We classified the patients into clinical syndromes requiring kidney biopsy into first acute kidney injury, second chronic kidney disease, third acute nephritis, fourth rapidly progressing renal failure, fifth into nephrotic syndrome, and last asymptomatic mild urinary abnormalities. We analyzed the data into two periods, pre-pandemic and pandemic. We compared the total number of kidney biopsies performed in each period. We compared the clinical syndromes requiring kidney biopsy. We compared the major histological findings of each clinical syndrome across both the periods. Chi-square test or Fisher's exact test was used to compare the proportions. Total 239 kidney biopsies were performed during the study period. We excluded cases of renal mass, transplant kidney biopsy, donor kidney biopsy, and hence remaining 198 patients were included in the study. As we can see in the pandemic, 82 biopsies were performed as compared to 114 in pre-pandemic period. The results were as the biopsies for chronic kidney disease was more done in the pandemic period, while the less number of biopsies were required for the patients with mild asymptomatic urinary abnormalities in the pandemic period. We compared the demographic and comorbidities across both the periods, which were similar. What we found that less number of patients with SLE underwent biopsy during the pandemic period. We compared the histology of nephrotic syndrome in both the periods. We found that in the pre-pandemic period, minimal change disease was most common, while in the pandemic period, focal segmental glomerulosclerosis was seen. In this, p-value was found significant. Histology in acute kidney injury across both periods was compared, and it was not statistically significant. We compared the histology of chronic kidney disease across both periods, which was also not statistically significant. Histology among asymptomatic urinary abnormalities across both periods was also not statistically significant. Then we found some recent studies which describe the impact of pandemic on the kidney biopsies. Study by Hakrosh et al. Demonstrated that there was increase in cases of ANCA vasculitis in pandemic period, and a study by Chandra et al. In recent study demonstrated that there was increase in cases of diffuse global glomerulosclerosis in the pandemic period. The limitations of the studies that there were relatively small number of patients who underwent kidney biopsy and less number of patients with individual clinical syndromes, then hence the random variation cannot be ruled out. So to conclude, the number of kidney biopsies reduced in the pandemic period. COVID-19 pandemic may have impacted the decision of kidney biopsy, as patients with mild urinary abnormalities were less subjected to biopsy, and proportionally more patients with unexplained CKD needed biopsy in the pandemic period. The commonest reason for kidney biopsy across both the periods was nephrotic syndrome. A minimal change disease was mainly seen in the pre-pandemic period, while focal segmental glomerulosclerosis was seen in pandemic period. These results need to be confirmed from similar studies from another centers. Thank you.
How many you found de novo glomerulopathies because of COVID in your follow-up?
We didn't study the impact of COVID-19 on the histology of patients. We just retrieved the data comparing the year of admission and...
So by not doing the biopsy in these conditions, did it impact, had any impact on the patient's course of the disease or patient's treatment? Or maybe that it was good for the patient that the biopsy was not done?
Maybe because of the COVID pandemic lockdowns, less number of patients visited the hospitals, less number of references were given to nephrologists, or there could be a sampling error that because we have retrieved the data electronically. So less number of patients has decreased during the pandemic.
Yeah, this is just a descriptive study. I don't see much difference between 114 and 82. It probably is a sampling error. Did you find, so how many of them had EM biopsies in your cohort?
We didn't compare it, but EM biopsies were mostly done in the pre-pandemic period. Pandemic period, less number of will be there. We didn't compare, ma'am.
But that was an important information that you should have brought out, right?
Okay, ma'am.
Any collapsing FSGS in your cohort?
No, ma'am.
Thank you.
Okay, thank you, ma'am.
So now we invite Dr. Trishra Chabda from Indore. Study on urinary tract infection.
Good afternoon, everyone. My topic is to study the causative organisms of urinary tract infection, antimicrobial sensitivity pattern, and to decide antibiotic policy for urinary tract infection in central India. Urinary tract infection is one of the most common bacterial infection in routine clinical practice, clinical presentation of which may range from asymptomatic to severe sepsis. Infection of lower urinary tract includes cystitis, prostatitis, and urethritis, and infection of upper urinary tract include pyelonephritis. Bacterial colonization of the urinary tract may also occur without symptoms, which is called asymptomatic bacteriuria. UTI also contributes as the most common nosocomial infections in many hospitals and accounts for approximately 35% of all hospital-acquired infections. UTI is basically treated with broad-spectrum antibiotics to start with, which are de-escalated to specific antibiotic based on urine culture and antimicrobial susceptibility. The overuse and misuse of antimicrobial agents have contributed to the growing problem of resistance amongst uropathogenic bacteria, which is a serious threat to public health. Our objectives were to study the causative organisms of urinary tract infections, to study antimicrobial sensitivity pattern of uropathogenic bacteria, and to decide antibiotic policy for UTI in central India. Our research methodology was, the study was undertaken from a period of September 2021 to May 2022 at Department of Nephrology, SAIMS Indore. Clean catch midstream urine samples were collected from patients suspected of UTI from various departments, and the urine samples were processed for culture and antibiotic susceptibility testing after culture in McConkey or blood agars for 24 hours, and interpretation of the bacterial isolates were carried out by Vitek-2 automated system. The results were, a total of 3,241 samples were processed for urine culture and sensitivity. Out of that, 1,022 samples were found to be positive for bacterial infections, which is 31.53% positivity rate. The females were 522, 51%, and males were 500, 48.9%. The positive isolates were further divided into outdoor and indoor patients, of which OPD patients were 315 and IPD patients were 707, out of which 480 were in wards and 227 were in ICU. Sensitivity of the drugs was higher in OPD patients followed by wards and least in ICU patients, which indicates multi-drug resistant strains in ICU were more common. This is the table showing the causative organisms. It is showing that the E. coli was the most common organism in ward, OPD and overall, but the most common organism in ICU was Pseudomonas, and other organisms were Staph, Enterococcus and Acinetobacter. This is the table showing the oral antibiotic sensitivity pattern for gram-negative bacteria. It is showing that the sensitivity of the drugs were more for E. coli than Klebsiella, and the Pseudomonas were resistant to most of the oral antibiotics. Then this is the oral antibiotic sensitivity pattern for gram-negative bacteria overall, showing the three drugs nitrofurantoin, cotrimoxazole and phosphomycin, of which nitrofurantoin was most sensitive. This is the table showing intravenous drugs antibiotic sensitivity pattern for gram-negative bacteria, and the drugs used were amikacin, colistin, gentamicin, tigecycline, piperacillin, tazobactam, meropenem, cefepime, cefoperazone, sulbactam and ciprofloxacin. This is also showing that the E. coli was showing the maximum sensitivity and the Pseudomonas was showing the least sensitivity. This is the graph showing the intravenous, and overall all the organisms were clubbed, and the highest sensitivity was seen for colistin, followed by amikacin, then gentamicin, and then the least was for cefoperazone, sulbactam and ciprofloxacin. Then this is the table showing oral antibiotic sensitivity pattern for gram-positive bacteria, and oral drugs were, the used drugs were linezolid and nitrofurantoin, and it is showing that the Enterococcus was having more susceptibility than Staphylococcus. This is the graph showing oral antibiotic sensitivity for gram-positive bacteria overall, and showing that sensitivity of linezolid was 67.8 and nitrofurantoin 65.9. Then the intravenous drugs for gram-positive bacteria, the drugs used were vancomycin, teicoplanin and tigecycline. And here also the sensitivity was for enterococcus for more than staphylococcus. And overall, the highest was for teicoplanin, then vancomycin and then tigecycline. Our conclusion, increased resistance was observed for fluoroquinolones and cephalosporins. Resistance for carbapenems was also high. And antibiotic sensitivity, as per our study, the order was for oral gram-negative organisms. First is nitrofurantoin, followed by cotrimoxazole, then phosphomycin. For intravenous gram-negative organisms, it's first colistin, then amikacin, gentamicin, then piperacillin, tazobactam, tigecycline, carbapenem, cephalosporins, and last was fluoroquinolones. And oral gram-positive organisms, first linezolid, then nitrofurantoin, and intravenous gram-negative organisms, first teicoplanin, then vancomycin, then tigecycline. Empirical antibiotics based on regional antibiotic sensitivity patterns should be started and should be changed as per culture reports afterwards. It is need of the hour to conduct a regional research on the culture and sensitivity pattern of the bacteria, considering bacterial resistance and multi-drug resistant strains. Thank you.
What is the empirical antibiotic therapy you will prescribe to a patient who is having who requires IV antibiotics for UTI?
Sir, if the patient is in, it depends if the patient is OPD basis, is in what?
Patient is admitted, patient is sick, IV. My question is IV antibiotics.
Sir, based on our study, the colistin was having highest sensitivity, but not to go with that, we can use the, if the patient's renal parameters permit, we should not start with gentamicin or amikacin. If
what will you prescribe to the patient as a first line therapy, intravenous therapy, after your presentation?
Sir, we should start with either piperacillin, tazobactam or with meropenem.
But meropenem was something like number 6.
Yes, sir. But sir, actually, the if the patient is having increased creatinine, we cannot use colistin or amikacin, gentamicin. For nephrology purposes, we start with piperacillin, tazobactam, and then we go for tigecycline, as tigecycline is a bacteriostatic drug. So we, according to that, we keep it a little late.
And how much the oral phosphomycin? What was your experience?
So phosphomycin and the pattern, it came third number. First was nitrofurantoin, then cotrimoxazole, and third was phosphomycin. And it cannot be used for complicated UTIs also, as it's the tissue penetration is also not that good for phosphomycin. For pyelonephritis, phosphomycin has got a good results in lower urinary tract infections as compared to the upper.
How much was the resistance with colistin?
So colistin sensitivity was 82%, that means 82% sensitivity.
Yes.
Thank you for that presentation. Can you tell me what is the difference between ESBL or a carbapenem resistant organism?
ESBL and?
Carbapenem resistant, CRO.
ESBL is extended spectrum beta lactamase, and these are the organisms who are resistant to the beta lactamase, and carbapenem resistant are those who have also become sensitive to the resistant to the carbapenems.
So, do you see these organisms in the community or only in hospital settings?
Ma'am, we see ESBL most commonly, but carbapenem, yes, as the sensitivity of meropenems has decreased a lot. So carbapenem sensitive also resistant have also increased, but we have not included in our study different groups.
Now, you have told us that the yield of your culture in both males and females was only 50%.
Yes, ma'am, 51 and 49.
What were the reasons for collecting urine culture in these patients?
Ma'am, actually we have taken data from the microbiology department. All the culture reports we have analyzed. We have not taken the clinical, not seen the clinically the patients.
Yeah, so I think one major missing thing in your thing is a clinical correlation.
Yes,
so most of this could have been just contaminants, right? It need not even have been symptomatic UTI that requires treatment.
Yes,
it could just have been a localization or a contamination. You did mention that you need to have regional antibiogram. Can you tell us how your antibiogram is different from other regions in India?
Ma'am, we have seen the other studies from Lucknow and from northern India, and one study from southern India. So there the Pseudomonas was not that prevalent as it came in our study, and also the sensitivity of colistin was nearing to 98%, and here in our study it is just 82%. And the sensitivity of this carbapenem, meropenem, that has also decreased a lot in our study, but there it was a bit higher.
Probably you could have just put a tabular column saying, quoting the different studies.
Yes, ma'am.
And you always mentioned about overall bacteria. Look, when you are looking at gram-negative, each gram-negative bacteria has a different molecular mechanism of resistance to drugs. To club everything together also may not be a good way to go. What are the conditions that can cause gram-positive UTI?
Ma'am, gram-positive UTIs are more common if the spread is from hematogenous routes, like pyelonephritis. There can be gram-positive, and the complicated UTI contribute more to the gram-positive.
Thank you.
So now we come to the last paper. Dr. Vinay Kumar from Raipur about CKD-U and urinary concentration ability test.
Good afternoon, everyone. My name is Dr. Vinay Kumar. I'm going to present a study on urine concentration ability in residents of endemic area of CKD-U visiting AIIMS Raipur. So, CKD of unknown etiology has been reported from selected geographical areas in several countries like El Salvador, Nicaragua, Costa Rica, Egypt, Sri Lanka and India. Recent studies have shown the prevalence of CKD-U in state of Chhattisgarh and Orissa, especially the border between Chhattisgarh and Orissa. We are getting a lot of CKD of unknown origin patients, namely Gariaband, Mahasamund districts of Chhattisgarh and Balangir, Naupad and Kalahandi districts of Orissa. It has been observed previously that CKD-U affected several family members of a patient in same locality and sparing those who left away from the family in childhood only, like who left the place in their early childhood. CKD-U predominantly affects the tubulointerstitial compartment, which might affect concentrating and diluting ability of the kidney even before there is a decline in GFR. The cause of CKD-U still remains elusive, as the name itself suggests, with heat, water, pesticides, infections or other factors which are being implicated as the primary cause. CKD-U is clinically silent in early stages and usually carries a poor prognosis. Usually patient presents with advanced uremia with shrunken kidneys. It is already known that maximum urinary concentrating ability is an intrinsic kidney tubular function, and impaired urinary concentrating ability may reflect severity in tubular damage that is not captured by measurements which of glomerular filtration rate measurement alone. The clinical picture of CKD-U differs in some subtle ways from region to region. In India, CKD-U mainly manifests in 4th or 5th decade, but with minimal or no proteinuria and normal or only mildly elevated blood pressure. So aims and objectives. Research question: is there clinically detectable urine concentration defect in residents of endemic area of CKD-U with normal GFR visiting our institute AIIMS Raipur? Objective is to assess the prevalence of urinary concentration defect in residents of endemic area of CKD-U visiting AIIMS Raipur. Study design: it was observational cross-sectional study. Study area: it was OPD and IPD Department of Nephrology and Department of Medicine AIIMS Raipur. Study period was from it was for 1 year, from 1st January 2021 to 1st January 2022. Study subjects: adults of age between 18 to 60 years and accompanying a patient of CKD-U belonging to endemic zone of CKD of unknown origin visiting our institute. So the study subjects should be residing in endemic zone for at least past 10 years. Inclusion criteria: adults of either gender aged between 18 to 60 years. Study subjects should be residing in designated CKD-U for at least 10 years and they can be residing or they may be a relative of CKD-U. CKD-U will be defined as asymptomatic or progressive CKD, absent or subnephrotic proteinuria, absence of hematuria, absence of diabetes, chronic severe arterial hypertension, HIV, snakebite, other causes, normal HbA1c, blood pressure less than 160 by 100 millimeter in untreated patients, 140 by 90 millimeter of mercury in patients receiving up to 2 antihypertensive drugs, presence of bilateral small kidney or biopsy features suggestive of chronic tubulointerstitial nephritis. Patients with GFR more than 90, patients with 24-hour urinary excretion less than 200 mg per gram creatinine, and no known history of kidney related illness in the past. Exclusion criteria: patients with a known case of CKD of any other etiology, subjects with established traditional risk factor of CKD like diabetes, hypertension, autoimmune disease, other things, persons on diuretics or potassium supplements, pregnant women, subjects who had previous history of acute kidney injury were also excluded. Sample size, there are no previous studies which is done in a similar way, so we don't have the prevalence of the condition, so hence we could not actually calculate the sample. Methodology: residents of endemic zones of Chhattisgarh and Orissa attending AIIMS Raipur were interviewed. Epidemiological details were taken pertaining to the residents, duration of stay, occupation. Screening of the subjects: a structured proforma was used to assess eligibility, which included epidemiological detail, prior medical records, treatment details. After assessing for eligibility, patient information was provided and informed consent taken. Clinical history and physical examination was done. Test for urinary concentration ability which we used was fasting urinary sample after 12 hours of overnight water depression was collected to measure urine osmolarity. Urine osmolarity was measured with depression of freezing point method. Simultaneously serum sample was taken for serum osmolarity. So statistical method we used SPSS, categorical, they were percentages, continuous variables, mean with standard deviation. Laboratory assessment: blood we took renal function test with electrolytes, fasting urinary osmolarity. Urine we took urine protein creatinine ratio, fasting urine osmolarity. So among 70 patients of CKD, there were total 70 patients of CKDU origin who were admitted during the study period in 1 year. They belong to Garhiyaband, Mahasamund, Balangir, Nawapada districts of Chhattisgarh and Orissa. 120 relatives were there of 70 patients who were there with the patients. 75 relatives gave consent for the study, and 7 people were excluded as they were not meeting inclusion criteria, like they were not staying in the endemic area for last 10 years. 2 people were found to have GFR less than 90 on our initial testing, and hence they were excluded. 66 out of 120 relatives were subjects were included in the study, including 42 males, 24 females. 17 subjects were spouses, 32 were children, 9 were siblings, remaining 13% were neighbors of the index patient. So this is just a graphical this thing. 70 were admitted, 120 relatives were there, 75 gave consent, 2 people were excluded because they had GFR less than 90, and 7 people were excluded as they were not meeting inclusion criteria. 66 patients were included in our study. Baseline characteristics: this was a mean age was 37 years with weight of 55, BMI of 22. Patient had a mean GFR of 103. Mean urinary protein creatinine ratio was normal. Fasting specific gravity was 1.010 and urinary pH was 6.2. Fasting urine osmolarity was 742 mean with standard deviation of 215. Fasting serum osmolarity was 289 with a mean of 7. Fasting urine osmolarity to serum osmolarity ratio was 2.7. So discussion: subjects belong to Garhiyaband, Mahasamund districts of Chhattisgarh, Nawapada, Balangir district of Orissa. Normal fasting serum osmolarity after 12 hours of overnight water depression should be at least more than 850 milliosmoles per kg according to previous studies, and ratio of fasting urine osmolarity to serum osmolarity should be at least 3. That is, a normal person should be able to concentrate his urine 3 times that of his serum osmolarity from the previous studies. 26 subjects, that is 40% of study population, had fasting urine osmolarity to serum osmolarity ratio less than 30. 29%, that is 44% of study population, had fasting urine osmolarity of less than 850. Around 45% of seemingly normal patients who are accompanying the patients from endemic area, so belonging, so they have decreased ability of urine concentration ability. So advantages were stringent definition of CKD was followed. Therefore, we excluded other cause of CKD in our index patients. We were able to supervise the overnight water deprivation since patient relative also stayed with the patient in the hospital. Since index patients, implications were studies showed 40% patients have early tubular dysfunction. Therefore, they require long-term follow-up, monitoring their GFR, also monitoring their further serum osmolality, urine osmolality. Although cumbersome, if validated in larger population with community-based study, this test may be an early marker of tubular dysfunction in endemic areas. It is a hospital-based study, so it requires community-based study exactly in the endemic areas to know exactly what is the gravity. Sample size was small. Case control study should be done in the next subsequent studies, which will be comparing with the normal healthy controls from normal non-endemic regions. And in the subsequent studies, we are planning also to include other tubular function tests along with this osmolarity. Thank you.
So, how many patients had osmolarity after overnight water deprivation? How many patients had this less than 800?
Sir, 43%, 40%.
40%?
Sir.
Do you think there will be any role of doing genetic studies in these patients?
Yes, sir, genetic testing should be done, but overall worldwide studies have not shown any particular gene which is predisposing to endemic area. Since the patients are all from a particular endemic area, there must be some cause, like there is some mineral in the water or some other thing which is causing people. And it is not isolated in a particular family, it is there in all the members who are coming from that particular area.
And GFR criteria of more than 90, so that means you will be getting on most of the subjects will be younger patients, younger population.
Sir. Most seemingly healthy people, like who don't have any medical record.
Healthy but younger also.
Sir.
Second, third decade.
Sir. So usually the patients present to us in like fourth decade or fifth decade with end-stage renal disease. So before that, patient does not have any symptom. Directly he comes with creatinine of 10, 15, and we see the kidney size is shrunken. Patient does not have volume overload also. Many of these patients have hyponatremia, which we are studying why the people are having hyponatremia. So looks like some salt losing nephropathy kind of thing.
Other than this, what more tubular function tests you want to add in your future studies?
Sir, low molecular weight proteinuria can be checked. Amino acid urea can be checked. Fractional excretion of sodium. Tubular handling of electrolytes like calcium.
Thank you for that study. So this area that you have mentioned is a forested area, right?
Not forested area, ma'am. It is a border of Chhattisgarh and Orissa.
And there are a lot of mines.
Mines are there in the northern Chhattisgarh in Korba, not in this area.
So what do you think are the factors that contributed to high rate of CKDU here?
Ma'am, actually, previously this thing has been, we are noticing since last few years only, because previously there were no government based hospitals. So we are investigating, actually we are studying on mineral content of the drinking water which they are drinking, serum heavy metal analysis, all these studies are undergoing. Right now I don't have any idea why the people are having unknown origin CKD.
What are the other hotspots of CKDU in India that you know of?
One thing is Goa has a hotspot, ma'am, Kandkond, very well known for CKD of unknown origin. And other thing is this Uddanam from Andhra Pradesh, and this Tamil Nadu also has a area where the people come from CKD of unknown origin.
So why did you decide not to do a sample size for your study?
Ma'am, actually to calculate sample size, we require some prevalence. This type of study has never been done only. So this is just like a pilot study which we did to know initial like what can be our sample size if we are considering a large scale study, community.
So if you want to do a large scale study, what study design will you employ? Will you still employ a hospital based?
No, ma'am. Community based study is required, and we require like case control with people who are from non-endemic areas.
Randomized cluster design.
Randomized cluster is people who are taken from a particular area, and among them randomization is.
What is cluster?
Cluster design is like, for example, patient is attending a particular hospital, so we take from that hospital only. So we don't have idea of other patients who are attending the other hospital. Like that, patients we are taking from a particular geographical spot. So even the district is very big, we may take from a small area. So cluster sampling is from particular clusters which we are taking.
So you have taken children also in this cohort, right?
18 to...
So what was your cutoff for children? Was it the same as
No
adults?
children, ma'am, adults only, 18 to...
But you mentioned siblings and children in
Siblings of the...
So they were all adults. They were
Index
all-
patient who get admitted, no ma'am, their children who are adults or their siblings, like
It's all
patients...
adults, it's not
No,
less than...
no. These are all relatives of the patient admitted. Like, no.
No, are you suggesting that all these patients who had low osmolality have early CKDU?
We will follow them, ma'am. Right now, we don't.
So how do you ideally find out whether they have CKDU or not?
Ma'am, we have a separate CKD of unknown origin clinic now in our hospital. So these
No,
patients.
These patients, how? Yeah.
So their index patient is already registered with us. So they will be coming for follow-up every time. These patients' files also we have made. So with every follow-up, we will be checking their GFR, if possible, once in a year kidney size
You need
assessment.
longitudinal follow-up to
ma'am.
look at incidence.
Yes, ma'am.
You have not done any correlation with proteinuria in these patients.
No, ma'am.
Thank you.
Thanks.
Thank you. Yeah, sure. Yeah, sure.
And then
For the
you can
two
do
announcements.
Plus third announcement is, although this is a lunch symposium, lunch is not going to be served here.
Okay.
You can have
Yeah, you
lunch
can have
at
it.
your own leisure or aside.
Yeah, sure. Thank you. Thank you. Thank you to the chairpersons. I request Dr. A.K. Bhalla, who is a Padma Shri awardee, and Dr. Sakina Alexander ma'am to kindly proceed backstage for the felicitation. I have a few announcements for the postgraduates. First, those interested for the PG quiz, which is going to be held tomorrow, kindly enroll your name at the registration counter today before 3 p.m. Second, the panel of awards, the panel for a poster session are ready for the award session, The panels for the posters to be put up is ready in Chitrakoot Hall. Kindly put up your posters. And we'll proceed for the lunch symposium. And lunch, we are not going to have a break. We are just going to proceed with the presentations. So for the lunch symposium, for the first talk, may I request the chairpersons, Dr. Shiv Narayan Acharya, who is a consultant nephrologist and a transplant physician at Kingsway Hospital.
Included
Local.
and
Shiv Narayan Acharya.
No,
Talk is-
Atul Sasgure. Dr.
For
Atul
this?
Sasgure, yeah.
Okay. So kindly excuse me. For the first chairperson, we have Dr. Atul Sasgure and Dr. Lohitaksha Suratkal, who is a DNB teacher at Leelavati Hospital and Research Center.
And that announcement I said, lunch is not going to be served.
Yeah, lunch is not going to be served in this hall, please.
Good afternoon, everybody. We all know about the blockbuster molecule erythropoietin, what it has done to the quality of life of our patients. And we have been awaiting an oral drug for a long time. It's happy to note that we have a homegrown remedy here, and thanks to Zydus for this. To tell us more about this drug, we have Dr. Khandekar, and I would request my co-chairman to introduce the speaker.
Good afternoon, everyone. So I welcome Dr. Khandekar, sir. And actually, he doesn't need any introduction. He is a senior consultant nephrologist, transplant physician at Kingsway Hospital, Nagpur, HL Trivedi Gold Medal awardee, and has multiple publications and is author of patient education books, which are very well known. And I have come to know about them even from the patients, that they are very good books for patient education. So with multiple awards and achievements to his credit, without wasting any time, I'll request Khandekar sir to enlighten us about desidustat.
Thank you, sir. I must thank the scientific committee and the organizing team for giving me this opportunity. So I'm going to talk about desidustat and has it arrived, and should we all switch from erythropoietin or injectable ESAs to desidustat. So the outline of my talk is that I'll talk something basic about anemia in CKD, what is ESA hyporesponse, current options and the unmet needs from the current options, the newer agents, and my experience with desidustat. I may have to rush through some of the slides because I really want to highlight my experience with desidustat. The basics of anemia, we know that it is a disease of the late stage of CKD, and non-dialysis patients need ESAs more in number compared to dialysis patients. Initially it was all blood transfusion based treatment, much in the 50s. In 60s came the iron dextran, and that improved some outcomes. But the scene really changed with erythropoietin and injectable ESAs. The longer acting ESAs came later on and made life much easier. They all but eliminated the need for blood transfusion. And now the hypoxia inducible factor prolyl hydroxylase inhibitors have arrived, and they tend to take it one notch further, that the prick is going to be going away. We know that erythropoietin deficiency is the central to anemia in chronic kidney disease, but it's really an interplay of all the other factors also: iron deficiency, vitamin deficiency, reduced RBC survival, chronic inflammation. Just to give an estimate, in a hemodialysis patient, around 500 milligram of iron is lost annually for various reasons. So erythropoietin remains at the center of the cause of anemia. But iron, whether it is availability, mobilization from the stores, absorption or inflammation, is also less available. Hepcidin is a factor that hurts the anemia movement, whether it is from intestine to the stores or from stores to the circulation, and we'll talk a bit about hepcidin also. Erythropoietin basically puts hemoglobin inside the RBCs. It has this cascade of events that happen after erythropoietin attaches to the RBCs, but basically what it does is it prevents apoptosis and maintains the survival of RBCs. Hepcidin is like a gatekeeper. It is a small amino acid which is synthesized, small peptide which is synthesized in liver, regulates iron absorption from the gut, and prevents release of iron from the stores. And in fact, the deficiency of hepcidin leads to hemochromatosis. So, CKD being inflammatory state, the synthesis of hepcidin is high, and erythropoiesis is expected to suppress hepcidin, but inflammation really takes over. So, like we said, and then the next discussion in CKD always happens around the targets of hemoglobin, and there were various trials which happened around trying to decide the targets, but the last nails sort of were put by these two trials, CREATE and COIR, which came in the same edition of NEJM. CREATE said that the higher hemoglobin does not reduce cardiovascular risk. One could have taken that, but COIR went one step further and said that it actually increases cardiovascular risk and quality of life is also not better. So everybody started scrambling the targets of hemoglobin, and these were the two other trials, the normal hematocrit study and the TREAT study, which sort of came to the similar conclusion. So the guidelines, some of them were liberal, 12, 13, but the KDIGO came and said the target should be 11.5 and not more. So there's a very little margin where we have to aim the hemoglobin at. And the problems of increased cardiovascular risk could be multifactorial, and we'll come back to this slide if time permits. The other end of the spectrum is the ESA hypo-response. Around 10 to 15% of the patients will not respond to erythropoietin, and so it is defined as requirement of more than 300 units of erythropoietin per kg. So if somebody 50 kg or 60 kg person is taking more than 2 units, 2 injections of 10,000 units, he is ESA hypo-responsive. It contributes to morbidity, it increases expenditure, it increases hospitalization. Commonest cause is non-compliance and inflammation and iron deficiency. Then there could be many other causes as highlighted here. The ones that are light yellow or lighter in color are somewhat modifiable, the others are less modifiable or non-modifiable. The current treatments are oral iron, IV iron, injectable ESAs and blood transfusions. The oral irons are very easy to use, do not require additional hospitalization, not even a daycare visit. IV iron achieves the targets faster, is becoming more and more easy to use. We can now give larger doses much more easily, and erythropoietin, like I said, has made my life much easier, has all but eliminated the need for blood transfusions, and transfusion still remains in a small subset of patients, and that can be life-saving in patients with cardiovascular risk factors. But the limitations of oral iron are that it is poorly tolerated, it can be useless when it is in an inflammatory state, the hepcidin levels being very high. IV iron still has some concern of hypersensitivity reaction. There is a concern of infections flaring up, especially urinary tract infection flaring up. It cannot be utilized in active ongoing infection. Erythropoietin still, although it has made life easier, but there is this worry of hypo-response, and overshooting has its own problems, and blood transfusion has a risk of infection and allergic reactions. So what are the unmet needs with the current treatment? It is difficult to utilize in an inflammatory state. Diabetes adds to that inflammatory state one step further. There is some talk that even erythropoietin use can increase the risk of tumor progression. It is difficult to use in hospitalized patients who are inflamed and infected, and may be slightly difficult to use in kidney transplant patients. So injectable ESAs reduce blood transfusion, and but there is a break, there is a cold storage required, there is this worry of ESA hyporesponsiveness, and overshooting can create its own problems. So newer agents are now available: hypoxia inducible factor, prolyl hydroxylase inhibitors. It's easier to call them HIFI rather than HIF PHI. So HIFI, it basically hypoxia inducible factor is something that stimulates erythropoietin production but is quickly metabolized by prolyl hydroxylase inhibitors, and if somehow we were to sustain the action of prolyl hydroxylase, stop the action of prolyl hydroxylase and sustain the action of hypoxia inducible factor, then all these actions of erythropoietin synthesis of erythropoietin receptor, suppression of hepcidin, and therefore improved absorption of iron, improved production of even divalent metal transporter which transports iron across the gut, that also increases, and therefore the whole holistic approach is able to be achieved, because on one hand we are improving iron absorption, we are improving iron mobilization, on other hand we are improving erythropoietin and erythropoietin receptors. There are other targets also. We know that erythropoietin and the iron transport are the ones that are the most useful clinically, but then there are other factors also which are utilized, targets which are for vasomotor regulation, for growth and apoptosis, for which could be a worry in tumorigenesis, angiogenic signaling basically mediated by vascular endothelial growth factor. Even that is a worry in retinopathy, in tumor progression. There are some inflammatory gene targets also. So these are various, but all these other factors have not been proved to be clinically impactful, and that is something that will probably come from a longer experience and a longer use. So what we are looking at is increased erythropoietin production, indirect suppression of hepcidin, augmentation of iron absorption, and redistribution of endogenous iron stores. So that will help us in achieving the erythropoiesis in a better way without a prick. So most of these drugs, the drugs that are under development are daprodustat, vadadustat, molidustat, roxadustat, and our own desidustat. So roxadustat has the longest half-life, while daprodustat has the shortest, and roxadustat and desidustat inhibit all the prolyl hydroxylase enzymes, whereas for desidustat we don't know whether it is selective or non-selective. And most of the studies have also shown significant improvement in iron parameters. They have also shown reduction in LDL cholesterol as well. Most of the studies have not shown an increase in vascular endothelial growth factors. In fact, in roxadustat, there was a special mention in the investigator brochure that the increase in vascular endothelial growth factor was seen at much higher doses compared to what the doses are advocated clinically. This was the Olympus study in which Care Hospital Nagpur was one of the participants. Close to 3,000 patients. This is the non-dialysis study of roxadustat comparing with placebo. Close to 3,000 patients were enrolled and compared with placebo, and it was concluded that roxadustat effectively increased hemoglobin and the need for RBC transfusion with an adverse event profile which was comparable to the placebo. This was the Rockies trial, which was similar trial done in dialysis patients and reached a similar conclusion. Much lesser number of patients were required, and it effectively increased hemoglobin with CKD on dialysis and adverse events profile similar to erythropoietin alpha. Now dialysis patients, it was compared with erythropoietin, and non-dialysis patient, at least in roxadustat, was compared with placebo. Similar studies were done with daprodustat. This was the non-dialysis study where hemoglobin response was non-inferior and adverse event profile was non-inferior. So this concluded that in patients with anemia and CKD who were not undergoing dialysis, daprodustat was non-inferior. Similar study was conducted in dialysis patients of daprodustat, close to 3,000 patients, and concluded that daprodustat was non-inferior in both. But however, this was not sufficient for the US FDA to include it to approve its new drug application. So roxadustat new drug application was not approved, whereas daprodustat has been approved, and roxadustat has been approved in Europe for use, and I am told even in India it has been approved, roxadustat. So what about desidustat? Desidustat has been studied in India, developed in India, and in the phase 2 trial, it increased hemoglobin in a dose dependent fashion. It reduced LDL significantly, it reduced hepcidin significantly, it improved the iron parameters, and then the DREAM studies were conducted. A lot of us in this crowd were investigators in that, in those studies, DREAM non-dialysis and DREAM dialysis. In DREAM non-dialysis, close to 600 patients were enrolled, and 1:1 randomization between desidustat and darbepoetin was done, and the hemoglobin response and the iron parameters response was comparable in both the arms, and it was concluded that desidustat is non-inferior compared to darbepoetin in non-dialysis population. Similar study was conducted in dialysis patients, and close to 400 patients were enrolled. Now the difference here between and the conclusions were similar. The hemoglobin response was good and the iron parameters response was good, and it concluded that it is non-inferior compared to this was with erythropoietin. The difference between the trials of roxadustat and daprodustat and desidustat is that the roxadustat and daprodustat studies were event driven. So a particular number of events had to be met before the study was called off. Desidustat studies are more efficacy driven and more recording of side effects rather than being event driven. So the side effects were recorded both in non-dialysis and dialysis population. They look pretty innocuous. However, this does not tell us about cardiovascular events happening in these two studies. So it was eventually approved and by the DCGI and is now available for commercial use. The starting dose that has been advocated is 100 milligram 3 times a week, so 300 per week, and to be increased or decreased in the increments of 25 milligram or more. And if the hemoglobin response is good and adequate, we can reduce it by 25 milligram per dose, and if the hemoglobin response is inadequate, we can increase it by 25 milligram per dose. I really want to quickly go to my experience. So I extracted the data from my electronic medical record and OPD visits, and all the patients between 15th March to 15th August were included who at least had one follow-up and at least had hemoglobin data available. So this being a retrospective, it may sound a bit rusty, but I think it might show us a picture. I called them non-responder if they were switched back to injectable ESA, and I tried to collect data for up to 3 follow-ups. So there were 93 patients who were started on desidustat during this time. 41 patients had usable information, what I just mentioned. 19 were dialysis patients, 20 were non-dialysis patients, 2 were actually transplant patients. All of them completed follow-up 1. So that average duration was 42 days. 30 patients completed follow-up 2. The average duration was 81 days, and only 8 patients I have the data for follow-up 3, which is average duration is 92. Males were more as in everywhere else. 29 patients were switched from injectable ESA and 12 patients were de novo patients. Now since this was a retrospective and a non-clinical trial based scenario, some of them were already within the target range. The DREAM study said that the target range should be 10 to 12, so I took that as the parameter. So almost 50 to 60% patients were already in the target group, and the patients achieving that target range gradually improved as the follow-ups increased. So some of them actually overshot. Almost 13% patients by follow-up 2 overshot. So this is the overall performance, and if we try to compare those who were switched and those who started as de novo, this is the overall curve of hemoglobin, the average hemoglobin on baseline, day follow-up 1, follow-up 2 and follow-up 3. There is a slight dip on the follow-up 3, but how much that is significant given the small numbers, we don't know. Those who were switched followed the curve, and those who were de novo had probably a better response. And I tried to see if that is statistically significant. It was the improvement was statistically significant in those in the de novo patients, and the other curves did not achieve statistical significance. So probably stabilization is what I could achieve. This was the hemoglobin delta. Now I took the patients who started as less than 10 gram. Again, the numbers are small, but those who started as less than 10 gram at the baseline, almost 70 to 80% of this, let's say 60 to 80% of those patients achieved hemoglobin within the target range. Again, the follow-up patient number is very small, so we cannot interpret that. I tried to compare dialysis versus non-dialysis. This is the overall curve. This is the dialysis curve, which is slightly dipping after follow-up 2, and the non-dialysis somehow doing better, and you can see the trend line which is upwards. And again, I tried to apply some statistical parameter, and none of them came statistically significant, but the non-dialysis tended to perform better, is trending towards significance. Again, how many of them were within the target range? The dialysis patients started low, and initially they did jump up to target range, but some of them overshot, and roughly we can say that 60 to 80% of them remained within the target range. And in non-dialysis patient, the response was much more predictable and sustained. This was the hemoglobin delta. And I said non-responders were those who I switched back to injectable ESAs, and 8 of them I have to switch back to injectable ESAs. 5 of them were from dialysis group, and most of them I switched in the follow-up, second follow-up visit. And if I compare responders versus non-responders, then the trend line of responders is much better, is statistically significant, and the non-responders, the dip is actually statistically significant. So we need to analyze these non-responders also. One of the factors that I wanted to correlate was the dose, and I realized that this is between responders and non-responders, and I realized that the dose that I was giving them was slightly lower, was significantly lower, and it achieved a statistical significance. Non-responders were getting lower dose. We also saw that de novo was doing better, and I could see that the de novo was receiving a better dose. We also saw that non-dialysis patients were trending better, and again the first day, the first 2 visit doses were slightly higher. So this was my doing, whether I was giving them low doses initially and that was affecting the outcome. That could be a matter of discussion. I did not capture much of the side effects.
I think you'll have to wind up here. If you can just sum up quickly.
Right. So what we did not capture was inflammation status, iron status, quality of life, side effects, and comparison with ESA. And we noticed some of the logistic factors. And so to summarize, 80% of our patients will respond positively to desidustat. De novo patients tend to do better. Non-dialysis patients tend to do better. And higher initial dose might be preferable. Larger data and longer follow-up is required. Non-responders need to be analyzed further. I would stop here.
Thank you, sir, for the comprehensive review and your vast experience on this product, which has got launched just few months ago in India. And can we take a question? We don't have any time for questions. So when I was told that I'll be chairing the session, I just went through my data too, and roughly it is round about the same, that there is good response and it is comparable to, and in fact cost-wise I thought maybe it is better than erythropoietin. I didn't take into account the insurance thing in account. So thank you very much.
Thank you, sir. Thank you.
Thank you, sir. Requesting the chairpersons and the speakers to come backstage for the felicitation. And just about time for our last talk in this lunch symposium. I call upon the chairpersons, Dr. Harish Pathak, who is a consultant and a transplant physician, Nanavati Max Hospital, Mumbai, and Dr. Prakash Ketan, who is a senior consultant nephrologist and a managing director of Kingsway Hospital, Nagpur.
Then you have to anyway be there.
So,
good afternoon all. I'll thank the organizers for giving this opportunity, and I'll request the speaker to start his deliberation. The topic is use of inducing agents in kidney transplantation.
So thank you everybody. Thanks scientific committee and the organizing committee of ISN West Zone for giving me an opportunity to talk to you on such an important topic in kidney transplant. So I'll be talking to you about the induction agents in kidney transplantation, what is the need, which agents, why. So all of us agree that kidney transplantation is a better way to live for patients with suffering from end-stage kidney disease. It adds quality to the life, it adds years to the life. And how to improve the outcomes, induction agents help us to improve the outcomes of kidney transplantation by preventing an acute rejection. So this is the how immune response to allograft happens. As soon as the allograft is transplanted, there is a stage of recognition where the antigen presenting cells from the graft interact with the donor's recipient's helper T cells. There is an activation of helper T cells and downstream events which leads to activation of cytotoxic T cells, graft injury and eventually rejection. So the primary aim of doing transplant in the immediate post-transplant period is to prevent rejection, and all of us agree that induction agents help us to do that. So induction agents are administered prophylactically in the peri-transplant period to achieve that goal. These are powerful agents which lead to immediate and short-lived immunosuppression at the time of transplantation, and this prevents acute and hyperacute rejection. However, that is not the only thing that induction agents do. It helps us to achieve many other things. It prevents ischemia reperfusion injury. It allows delayed introduction of CNIs, especially in the cases of delayed graft function. It allows us to do steroid-free or steroid minimization as a maintenance immunosuppression. It allows us to use ECD kidneys very safely, and that helps to increase the donor pool. It also allows us to do immunologically high-risk kidney transplant patients, so patients with DSAs, HLA incompatibilities, ABO incompatibilities, and that too with an acceptable rejection rates. And it obviously allows to graft to function longer by preventing acute rejection. So this is why we need induction agents in kidney transplants, and most of kidney transplants, I mean, it's not, there is risk involved with every kidney transplant for rejection, and I think induction agents precisely prevent rejection. However, these benefits come at the cost. There is increased incidence of the infections and malignancy in the immediate as well as over the long-term period. So this is one of the earliest studies which looked at graft survival by immunosuppressive regimen. So this looked at PRA regimen, PRA levels less than 20% or more than 20%, and with or without induction agents. And these patients were followed over a period of time, and it is, you can definitely see that those with induction agents did fairly well compared to no induction agents, and this paved the way for using induction agents in most of the kidney transplant patients. How do you decide which induction agent to use? So it's multiple factors that are taken into consideration. First and foremost, risk, immunological risk, number of HLA mismatches, ABO incompatibility, whether there's an anticipated risk of DGF, especially in cadaver kidney transplants, recipient parameters, when there is an increased risk for malignancies, viral infections, and high number of comorbidities. And some of these have been immunosuppressed for a very long period of time, especially patients with vasculitis, SLE. So we need to be very careful about the induction regimen and the maintenance regimen. The choice of induction agent also depends on what is going to be the maintenance regimen. So whether it's going to be steroid-free, steroid avoidance, whether it's going to be CNI minimization, whether you are going to use mTOR inhibitors or belatacept. So that also decides, and cyclosporine or TAC. So that also decides what induction agent should be used. As I said earlier, these are the patients which are suitable for induction. So more number of HLA mismatches, ABO incompatibility, presence of DSAs, positive cross match, are definitely these patients should receive induction. Younger recipient's age, older donor age, PRA more than 20%, and cold ischemia time of more than 24 hours. So almost everybody needs, it's just that which induction agent to use. Induction agents are broadly classified into lymphocyte depleting. These are powerful agents which just destroy the lymphocytes for a period of 3 to 6 months till the reconstitution of the immune system happens. And they allow us to do high-risk kidney transplant safely. Lymphocyte non-depleting agents are agents which specifically block the T cell receptors. They block the activation of the T cells and allow us to do kidney transplants without increasing the incidence of acute rejections. They can also be classified based on the monoclonality, monoclonal versus polyclonal. The depleting agents which are commonly used now is thymoglobulin, different types. OKT3 is not being used anymore, alemtuzumab in certain cases. So these are the different polyclonal antibodies that are used. Horse ATG, rabbit ATG, and ATG, Fresenius ATG, which is also known as Graflon. The dose for thymocyte or ATG is anywhere from 1.5 to 6 milligram per kg per day over 1 to 10 days. However, we rarely go to such high dosages. The average dose that is being used is 3 to 6 milligram per kg total dose. Now, the mechanism of action of these depleting antibodies is T and B cell depletion, co-stimulation blockage of the adhesion molecules, inhibition of antibody-dependent cell cytotoxicity, and induction of apoptosis. And by these mechanisms, these agents literally wipe out your T lymphocytes, and this makes you very, very prone for opportunistic infection as well as malignancies in the long run. So there is very high increased incidence of infection, especially CMV, and hematological side effects, cytopenias and PTLDs in the longer time. So the agents with a better safety profile are interleukin-2 receptor antagonists. These are monoclonal CD25 monoclonal antibodies which block interleukin-2 receptor alpha chain on the activated T cells and block the downstream signals and complement activation. The commonest in use is basiliximab, which is a chimeric antibody, 75% of the human origin, 25% of the murine origin. 2 dosages given 4 days apart, 25 milligram immediately around the transplant time, and second dose is given on 4th day. It causes complete saturation of CD25 receptors for 30 to 45 days. And the daclizumab causes more prolonged saturation for lasting up to 120 days. The third antibody that is being used is alemtuzumab. It's anti-CD52 monoclonal antibody. It's again present, anti-CD52 is present on all B cells, T lymphocytes, macrophages and national killer cells, and it is really a powerful immunosuppressive agent, and it has been used in steroid avoidance programs. So 20 to 30 milligram a single dose on the day of transplant. Fourth induction agent, rituximab, anti-CD20 monoclonal antibody, which is an anti-B cell treatment used for the treatment of NHL, and now we have taken over. It has got many indications in nephrology. The commonest one being used as an induction agent in ABO incompatible kidney transplants, and it has virtually replaced the splenectomy. So coming to the guidelines, KDICO guidelines do recommend, there is a level 1A evidence of recommending a combination of immunosuppressive agents at the time of kidney transplants. As far as the induction agents are concerned, there is again a level 1A recommendation that induction agents should be used in almost all transplants, and more commonly interleukin-2 receptor antagonists as an induction therapy, level 1B evidence, and depleting antibodies should be used only in selected high-risk population. Now coming to an individual agent, so basiliximab versus no induction. This is an old study, 2003 came in transplant. So basiliximab versus a no induction agent, and the maintenance immunosuppression was cyclosporine, mycophenolate and steroids. And it did prevent rejections, and there was improvement in the long-term graft outcomes. Interleukin-2 receptor antagonist versus ATG, so essentially basiliximab versus ATG in a low-risk immune transplant recipients. Here the maintenance immunosuppression was cyclosporine, mycophenolate and steroids. So it looked at 105 patients, 1 year outcome in terms of the graft biopsy-proven graft rejections, graft loss, patient loss. And look at the results. So there was really no significant difference in terms of the biopsy-proven acute rejections, graft loss or patient loss or patient death in 2 arms. However, there was significantly more incidence of CMV infections, cytopenias in ATG arm. So this study safely concluded that basiliximab was as effective as ATG in preventing acute rejections, and it was more safe to use because it had a lower incidence of cytopenias and infections. Another study, this was a landmark study, came from Dr. Daniel Brannan's group, 2006 in the NEGM. It looked at high-risk population. So again, Simulect versus ATG, and the maintenance immunosuppression was cyclosporine, mycophenolate and steroids. Here in this particular subset, thymoglobulin really fared better. It prevented rejections, it prevented severity of the rejections, and it was statistically significant. So lesser number of rejections in immunologically high-risk patients with thymoglobulin. However, when you look at the composite outcomes of graft loss, delayed graft function and death, there was really no difference between the 2 arms. So ATG did reduce the incidence of acute rejections, but overall there was no difference in 2 arms in the incidence of delayed graft function, patient and graft survival. What do the meta-analysis say? So again, when you pull in all the studies comparing Simulect or daclizumab versus ATG, there was really not much significant difference in the composite outcomes of graft loss, biopsy-proven acute rejections, patient death or delayed graft function between the two arms. Does it really matter in the long-term outcome? Again, there's no really difference between the ATG induction versus basileximab induction. There was non-significantly improved trend in the patient and graft survival in ATG group, but again, that comes with the cost of more CMV infections, more malignancy in the ATG group. So again, as far as the safety profile is concerned, basileximab really fares well compared to ATGs. And this is again a meta-analysis looking at side effect profile of Simulect versus ATG. So more CMV infections, more malignancies in the ATG group. And basileximab definitely scored over ATG in this term. So long-term outcomes, not much significantly difference. Acute rejection episodes definitely better with ATG, but that didn't really change the final outcome. Now coming to second antibody, alemtuzumab induction in renal transplant patient. This was the first landmark study which looked at alemtuzumab versus basileximab in low-risk patients and alemtuzumab versus ATG in high-risk patients. And there was really no statistically significant difference between alemtuzumab and rabbit ATG in terms of biopsy-proven acute rejections or the graft loss or the patient death in the high-risk case. However, in low-risk case, alemtuzumab was better compared to basileximab on those outcomes. And the only alemtuzumab allowed us to do steroid-free transplants more effectively compared with the other induction regimens. So whenever you are contemplating steroid-free regimens, alemtuzumab probably scores better over ATG. And this is the meta-analysis which looked at alemtuzumab for induction in kidney transplant patients. So alemtuzumab plus steroid minimization reduced acute rejection compared with the ATG at 1 year. If you look at the 1 year data, there was no significant difference between the graft loss or death-censored graft loss when alemtuzumab versus ATG. Creatinine clearance was slightly lower with alemtuzumab plus steroids. However, there was not much significant difference on the NODAT. Now the last, looking at the induction agents in ABO incompatible kidney transplants, and specifically the anti-CD20 monoclonal antibody rituximab. So when you look at ABO incompatible living kidney transplants, and in addition to the plasmapheresis, when you use rituximab as an induction agent, it prevents rejections and the overall graft survival is much better. This is a 3-year data where they use anti-CD20 antibody versus no rituximab, and those who received rituximab had a lower incidence of rejections and a better graft survival. So at the end of 3 years, graft survival is better in recipients with anti-CD20 antibody induction. However, there is no statistically significant difference in the overall graft survival. There's another study which looked at different regimens in ABO incompatible kidney transplant. So this is basileximab, this is rituximab with basileximab and alemtuzumab alone. And when you look at the outcomes, rituximab and basileximab combination did well. These patients had lower incidence of biopsy-prone acute rejections, lower incidence of graft loss, and patient death. So, although there was no significant difference in patient mortality among 3 groups, however, the graft survival tend to be better in rituximab basileximab group compared with other groups. So, rituximab definitely seems to be a choice of induction agent along with basileximab in ABO incompatible kidney transplants. It has virtually replaced the splenectomy. However, low-dose ATG could be another option for induction in patients with ABO incompatible kidney transplants. So in summary, it is I can definitely say that with the available data that we have and all the analysis, the interleukin-2 receptor antagonist basileximab is definitely the preferred induction agent in most of the kidney transplant recipients. Only few selected high-risk patients should receive polyclonal antibodies like ATG or Fresenius ATG, that is Graflon. Rituximab and basileximab combination seems to do better when used as an induction treatment in ABO incompatible kidney transplant. Induction immunosuppression should be tailored based on the risk stratification. So the donor risk factors, the recipient factors, immunological factors around the transplant, like ABO incompatibilities, number of HLA mismatches, presence or absence of DSAs, and delayed graft function. And induction agents do make life simple for us. They reduce the incidence and severity of rejections, and by that same rationale, it may allow the grafts to function longer and may allow the better graft and patient survival. Thank you.
Thank you for a wonderful insight on the induction agents. And so only I have one question, Dr. Ravindra. What protocol and means you use, and what is your own experience with the indexing agent? Because as much as the crowd is in the hall, because when you are buying a vehicle, definitely you buy insurance. I don't know, means there is no person, well, because I'm giving an example, I'm passionate about the car racing, so always I used to give the cars example. Whenever you are buying a new car, you always take an insurance. So if you see this one, my insight, my boss is also sitting here in the hall only. So, so as much as the transplant is considered, induction is must one. So I would like to know from your own experience with the ATG and IL-2 blocker.
So thanks, Hari. So I learned, I did my fellowship in Toronto, and there was only one induction agent there. It was only ATG. So either it was low dose ATG for low immunologically risk patients, and then high dose ATG for high immunologically risk patients. So I had no exposure to Simulate. And over a period of time, I realized that ATG in our situation, especially in Indian population, it causes much more infections, much more CMVs, much more tuberculosis, and it really it negated the initial benefit that we have of avoiding rejection. And here in this patient, Simulate scores better because there is a lesser incidence of infection, and it is in low risk cases it is as good as ATG in preventing acute rejection. So now we look at the data, even in high risk cases like EBO incompatible kidney transplant, patients are doing well with basiliximab and rituximab combination. So I would say now the current practice is basiliximab for almost everybody and ATG for very select few. And the dose of ATG should be, in our Indian scenario, should not probably 3 to 5 milligram per kilo total, not more than that, because higher the dose, probably the incidence of infection and this PTLD and all goes really high.
No, but so when you are using the IL-2 blocker as an induction, so then you start the maintenance immunosuppression on a day -3 or day -5?
Day -3.
Thank you, Ravindra.
The session is open for discussion. Few questions from the audience. Yes, Dr. Ambike.
A good comprehensive discussion. I just wanted to ask you, in our usual setup where you have a HLA matched transplant due, do you still believe that induction agents are required? Because what we have seen is that most of the times you don't really require an induction agent, and you can do, because whatever data you showed of KDIGO, that is usually applied for all cadaveric transplants. Does it fit into our scenario also?
Yeah, so again, sir, I think this needs to be really individualized. I believe that every living related kidney transplant patient does carry a risk of rejection, and unless these are like really two HLA haplotype identical siblings, every transplant will have a risk of rejection. I mean, it's like taking a lot of risk not using induction in these patients. If they develop rejections, then again you have to intensify the immunosuppression, and again it kind of negates the initial benefit that you have achieved of not using any induction agent. So I believe at least Simulate should be used in most of the cases. I mean, that is my take on it. I mean, there are a lot of giants sitting here in the audience. I mean, they can differ with me in the opinion, but in my we have done fairly large number of kidney transplants in last 5 years at Apollo, and I think induction agents makes life easier, no doubt, and Simulate is really probably a better option in our setting compared with since we are really grapple with the high incidence of these tuberculosis, pneumonias, UTIs. So it really, probably it's a better agent for suited to our patients.
I think we'll take an audience poll on, yes, Jatin, you can have a quick comment.
Ravi, great talk. Just one comment. When we are looking at long-term infections, I understand that where you come from in terms of first 3 months of infections, etc. If you look at the timetable of infections, we are dealing with very specific nosocomial infections in the first few weeks. And if you take care of CMV, then pretty much if you compare the two drugs, there is not much of a difference, and which has been shown in large RCTs. So my take is a little bit different. And over the last 20 years, we have used induction agent, and I completely agree with your point that in the Indian setting, not to give induction is not an option unless and until you have a 100% haplotype match. We are having more and more marginal donors. We are having more and more extended criteria donors, even in cadaver. Induction is almost a must. Everybody here senior enough who've done large number of transplants will tell you that we had our own issues with maintenance immunosuppressive drugs, including tacrolimus monitoring, how to get a fair idea about what we are doing in terms of maintenance immunosuppression. But induction is almost a must to try and prevent the double-digit acute rejection rates. And if you are careful, it has been shown in large series across India that infections are manageable. If you look at the global data also, aside the push from pharma industry, and I know this is a lunch symposium which is sponsored by a company, but if you look at global data, 70% plus patients who get transplant across the world are getting some induction. So I don't think the question remains whether you should use induction or not. And your topic was clearly to differentiate between the two categories of induction choices. So thank you. Yeah, so I would not be the right person to tell you about Simulect versus ATG because I have not used Simulect in 20 years. But maybe somebody who's used equal amount of Simulect can comment. And maybe Harish and Prakash themselves.
Yeah, I think I have not used much of ATG in my practice. I have used more of Simulect, and I am happy with Simulect. I have done most of the spousal transplant with Simulect. Most of the cadaver transplant I have used Simulect. Only few patients who were second transplants, I had used ATG as or Grapholon as the induction agents. So I think I am happy with Simulect, and I had gone for a training to Tokyo Women Hospital for ABO incompatible. They don't use ATG at all. They do not mention ATG. They use more of Simulect and rituximab. Left, right, center, they use rituximab as one of the induction agents, and they do not use ATG at all.
No, actually, if you ask me my experience, most of the from CMC, we used to have the all induction, and then after coming back to the Mumbai also, and if you see about the IL-2 blocker, definitely IL-2 blocker is a good player. Second thing that you have to start with your maintenance immunosuppression day -5, and definitely the biggest problem with the IL-2 blocker, personally what I feel is that even in India we don't have any test or laboratory to do the MPA AUC, because if you see the area wise and region wise also, the people from north, south and east, everyone gut is in a different way it absorbs the mycophenolate. So it's very difficult in the initial period who is attaining the very good AUC more than 40, or still even if you are giving a good recommended dose, so most of them will not attain the recommended AUC. That is the only drawback, and that's why if you really ask me one, and before closing this, I'll tell that because I would like to tell ATG is our preferred induction agent, but it's like individualized experience. And thanks, Ravindra, again.
Thank you.
Thank you, sir. Thank you. Kindly, may I request the chairpersons and the speaker to kindly proceed backstage for the felicitation. For the next session, I'll request my co-host, Dr. Sameer Mahajan, who is a consultant nephrologist from Kamal Bajaj Hospital, Aurangabad, to kindly take over.
So, hello and good afternoon, everyone. So, it's actually post-lunch session, and Dr. Sachin has given me a very difficult task to keep all of you awake. Let's see how much success I get in this. Let's move towards the next session of interesting cases. I would like to request Dr. Jyotsna Zope and Dr. Kshitija Gadekar to chair the session. Dr. Jyotsna is head of nephrology and renal transplantation at Bhaktivedanta Hospital and Research Center, Mumbai. She is director of Mukta Kidney and Dialysis Clinic, Prabhadevi, and director of Kimia Kidney Care, Thane. Dr. Kshitija Gadekar is professor at MGM Medical College and Hospital in Aurangabad. Let's start with the session. I would like to request Dr. Vipul Parmar to come and present his first case, interesting case, that's total plasma exchange in hypertriglyceridemia induced pancreatitis, case report and literature review. Thank you.
Good afternoon, everyone. Screen because I am presenting a rare but interesting case. A 48 years old female patient, recently diagnosed diabetes mellitus in just 3 months back, taking regular treatment, presented to Apollo Hospitals International Limited, Gandhinagar, with chief complaints of severe left upper quadrant abdominal pain, sudden of onset and gradually progressive since 2 days, associated with 2 episodes of vomiting and reduced urine output since 1 day. Patient had no history of hematuria, bilateral pedal edema, renal stone disease, alternative treatment, or any nephrotoxic medication ingestion. Patient had past history of acute pancreatitis 2 years back when she was managed with injectable medications at some hospital for 10 to 12 days. Initially reports were done on the first day on which hemoglobin was 11.8, WBC count was 11,000, platelet 357,000, CRP was 1.3, HbA1c was 8.4, creatine was 0.5, SGPT was 11. Surprisingly, cholesterol level was 1009, triglyceride level 4626, HDL 31, LDL 81, VLDL 925, lipase 1415, calcium 5.1, magnesium 1.2, acetone 0.5, albumin 5.0, LDH 666, CPK total 233. To decompose ejection fraction 60% with mild pH, RVSP 38. CT abdomen with contrast was done, which suggested of acute edematous pancreatitis without necrosis, cholelithiasis, choledocholithiasis, or gallbladder thickening with modified CT severity score of 6 out of 10. Apache score was 7. Patient was evaluated further, in which she was found to have history of hypertriglyceridemia. 2 years back, patient's report was cholesterol 491, triglyceride level 930, HDL 61, LDL 244, VLDL 186, SGPT 35. Patient was on tablet rosuvastatin and aspirin combination 20 by 20 plus 75 for hypertriglyceridemia. Patient's elder brother was also found to have hypertriglyceridemia and he was on atorvastatin 40 mg daily. This was the blood sample. Immediately, just after taking blood sample, this was the picture. We clearly see that cholesterol, this lipid gathering is there. On the next day of admission, patient reports were done. Suggestive elevated liver enzyme, SGPT was 45, SGOT 43, alkaline phosphatase 34, bilirubin was 1.8. Increased creatinine from 0.5 to 0.93, lipase 1378, amylase 1101, CRP 13. Patient developed severe abdominal pain, backache, nausea, vomiting, 1 spike of fever, shortness of breath with drop in blood pressure during hospital stay. We shifted patient to ICU. In view of multiple organ dysfunction and past history of pancreatitis due to hypertriglyceridemia, decision of plasmapheresis was taken to reduce triglyceride load and to prevent further organ damage. After 1 cycle of plasmapheresis, patient's condition remained slightly better with borderline urine output. Next morning, 1 more cycle of plasmapheresis was done, followed by fresh frozen plasma transfusion. Patient became hemodynamically stable with adequate urine output in the very next day and relief of symptom and serum creatinine reduced to 0.6. Patient was kept in hospital for 2 more days with symptomatic management and was discharged with stable condition with serum triglyceride 422 and serum lipase 131 with medical management. Before plex, as we can see the reports, after first cycle of plasmapheresis, cholesterol reduced, triglyceride, all the lipids were reduced. After second plasma, there was further decline. Mechanism of hypertriglyceridemia induced pancreatitis. The mechanism of HTGP is occurring due to lipolysis of the triglyceride-rich lipid particles by pancreatic lipoprotein lipase with a resultant production of free fatty acids. This free fatty acids causes free radical damage to the pancreatic acinar cells and hence initiating a self-perpetuating cycle of pancreatic inflammation and destruction. Although no clear-cut cutoff has been established, it is observed that risk of precipitating pancreatitis increased with worsening of hypertriglyceridemia and is rarely observed with triglyceride level less than 500 mg per deciliter. Progressively higher TG levels more than 1000 have been associated with disease severity and multi-organ failure. Therapeutic plasma exchange involves removal of patient's plasma and replacement with colloid or crystalloid solution. However, TPA is approved beneficial for HDTP in various small studies and a few cases reports and currently has a category 3 indication in ASFA criteria. TPA can cause rapid decline in triglyceride level with documented decrease by as much as 70% after single session of PLEX. Although there are no set guidelines for the timing of initiation of TPE, there is some evidence from small studies and case reports that early initiation of plasmapheresis within 48 hours of presentation results in improved morbidity and reduction in hospital stay. It is also considered in patients with lactic acidosis and evidence of end organ damage. Current data regarding the replacement fluid in TPS is sparse. Histologically, both albumin and FFP can be given. However, FFP has a theoretical advantage over albumin as it provides patient lipoprotein lipase and apolipoprotein, both necessary for hydrolysis of triglycerides. Although TP results in rapid lowering of TG, it is not primary therapy to maintain HDV remission. To prevent recurrence, lifestyle modification including low-fat diet, alcohol cessation, exercise as well as medications such as fibrates, niacin or omega fatty acids are the cornerstone of the therapy. In case of severe hypertriglyceridemia, another agent of choice is insulin infusion. With or without heparin, that shows reduction of the triglyceride in 48 to 72 hours to reach level less than 500 mg per deciliter, in 70 to 96 hours to reduce lipase up to normal range. Insulin promotes the synthesis of lipoprotein lipase from adipose tissue and muscle cells, which is crucial enzyme for hydrolysis of triglyceride. Heparin also promotes the release of LPL from endothelial cells. Why did we these PLEX in this patient? To prevent further organ damage, as patient is having family history of hypertriglyceridemia and past history of acute pancreatitis. Standard insulin takes at least 48 hours to lower the triglyceride level, while one cycle of PLEX can reduce up to 70% of triglycerides. This patient had similar episodes 2 years back when she was hospitalized for 10 to 12 days, while here we discharged patient in the 5th day. Patient was given prophylactic aspirin and atorvastatin combination in close follow-up with serious lifestyle modifications. There are some evidence in case reports for this hypertriglyceridemia. One study was done in Methodist University Hospital between 2007 to 2016. Total 3 plasmapheresis patients were done in same condition and successfully treated with reduction of morbidity, including hospital stay. However, mortality benefit was not found because of very low sample size. Another study, as we can see, one large national multicenter parallel group study in China with 220 patients from the large 17 tertiary care hospitals suggested that insulin infusion was equally effective as plasmapheresis in terms of reducing triglyceride level. These are the references in which there is shown of this type of plasmapheresis hypertriglyceridemia. Thank you.
It's a nice case.
Thank you.
So what is the follow-up of your patient?
Right now, she patient is in stable condition. There is no we did plasmapheresis about 2 months back. Then after patient has come follow up for one time, and she is having cholesterol of 400 and triglyceride level 222.
So she might need.
She is on lifestyle. We have suggested some lifestyle modification, omega-3 fatty acid, and she is on aspirin and atorvastatin combination.
She might need another session of plasmapheresis in future, you think?
If patient has no any complication like gallstone is there or pancreatic inflammation necrosis is there, then we should go for surgical or other medical. But patient presented early and we just did in just 48 hours of admission. So that's why we just get the result in this patient.
No long-term maintenance plex. You don't think that is required even in the other studies?
No, actually they are only the studies have just done for the quite a short duration of period. They have not just any for longer duration.
Okay, yeah. We take next case.
Thank you, ma'am.
Yeah. It's Dr. Saili Dalvi, isolated renal allograft tuberculosis.
Good afternoon all. Today I am presenting a rare but atypical case of isolated renal allograft tuberculosis. So, our patient, 53 years lady, she was teacher by occupation, underwent live-related ABO-compatible kidney transplant in May 2016. Donor was her husband and it was 5/6 mismatch. ATG was used as induction and she was discharged on triple immunosuppressants. And lowest creat at the time of discharge was 1 mg%. On maintenance, tacrolimus level was maintained between 5 to 6 and she was on prednisolone 5 mgs and MMF 1 gram BD. Subsequently, she had 2 episodes of acute cellular rejections in May 2016 and December 2021, both responded to pulse steroids. She also had 3 episodes of urinary tract infections in 2017, 19 and 21 and treated with appropriate antibiotics, and in April 2021 she had COVID-19 infection without chest involvement, which was treated symptomatically and immunosuppression was continued. So graft function was stable during this period. Now in April 2022 the same patient presented to us with high grade fever with chills for 3 to 4 days, appetite loss, fatigue, malaise and nausea. There was no weight loss, no body ache, rash or arthralgia, and she denies the history of cough, loose motions, abdominal pain, or there was no history of dysuria. On her physical examination, she was febrile, tachycardiac and severe pallor was there. No other significant positive finding on the physical examination. So, we did her, on investigations, we found that she had severe anemia and leukopenia. Her ESR was high. She had mild transaminitis. All her fever workup including dengue, repeated malarial smears, Vidal, blood and urine culture was negative. And for the biocytopenia we did CMV PCR which was negative. Her chest X-ray was normal. Even her USG of abdomen and transplant kidney was normal. So she received empirical antimalarials. MMF was stopped and we started her on broad spectrum IV meropenem after sending cultures. But she still continued to have high grade fever spikes for 8 to 10 days when she was in a hospital. So we planned to do 2D echo, then PET CT scan and bone marrow examination because we didn't have the diagnosis clue. On 2D echo there were no vegetations. But on her PET CT scan we found a small area of metabolically active lesion at the lower pole of transplant kidney. And there was no other active lesion found elsewhere on the on PET CT scan. So that lesion was aspirated, that abscess. Gram stain was negative. Bacterial culture, there was no growth, and gene expert was positive without rifampicin resistance. So she was started on 4-drug AKT including rifabutin, and TAC dose was increased, and we monitored her tacrolimus levels and LFTs. Subsequently TB MGIT culture also came positive, which was sensitive to first line anti-tubercular drugs. So within 2 days of starting AKT, she became afebrile better and got discharged. She responded well, became asymptomatic, and graft function improved with return of creat to baseline value of 0.9 mg%, and no side effects of AKT we observed. So tuberculosis is one of the commonest opportunistic infection in post-renal transplant. Most commonly it involves respiratory system and then disseminated involvement is common. Incidence in post-transplant is as high as 13.5% in developing countries like India. Prevalence of tuberculosis in transplant kidney is very low and only few cases have been reported till now. If it is in an early transplant period, it is generally donor derived. So we reviewed the literature, and one review published in 2020 wherein they did a systemic search for the case reports of isolated tuberculosis without disseminated involvement, and to the surprise it was reported only in 6 cases in last 20 years, and theirs was the 7th case, wherein in earlier cases 2 were diagnosed by the urine TB PCR and 4 were diagnosed by the allograft biopsy. One more case report from CMC Ludhiana describes same isolated renal allograft tuberculosis, but the diagnosis was made by the graft biopsy, wherein they found the epithelioid granulomas and ZN stain was negative, successfully treated with AKT. One more case series from AIIMS Delhi reports 3 cases of isolated renal allograft tuberculosis, wherein diagnosis was made by the allograft biopsy or urine TB PCR. So what is unique to this case as compared to the available case reports? In our case, there was a late involvement of allograft by tuberculosis. She was 6 years post-transplant. There were history of cellular allograft rejections in the past. It was a very short duration of illness, and early consideration of PET CT scan has helped to reach the diagnosis. And none of the earlier case reports have reported the allograft abscess and TB tuberculosis detected with AFB on the aspirated pus. So what are the risk factors for allograft tuberculosis? The previous number of rejection episodes, dialysis vintage, cumulative amount of immunosuppression, and earlier episodes of UTIs or pyelonephritis increases the risk of allograft tuberculosis. So to conclude with, high index of suspicion is needed for the diagnosis and should be considered early when the donor or recipient is from the endemic area. And timely detection and early institution of anti-tubercular treatment can help to prevent graft dysfunction or graft loss. Short duration of symptoms doesn't preclude the diagnosis of tuberculosis in immunocompromised. High-grade fever, short duration, acute illness, and renal abscess with past significant history of bacterial infections does not always mean pyogenic infection, and PET CT is a very useful diagnostic tool in such cases. But the question of why tuberculosis affected only renal allograft after so many years of transplant still remains unanswered. We couldn't find the exact cause. These are the references. Thank you. Yes, ma'am. Now she is in a regular follow-up with us with her normal renal function. We have planned, ma'am, after the 2D echo, PET CT scan and bone marrow, there was a plan for biopsy because we were unable to find the diagnosis, but on PET CT only we got the diagnosis. Otherwise, the next plan was to do bone marrow because she was having leukopenia also, leukopenia with this thing.
Did the donor had a history of tuberculosis?
No, ma'am. No, donor and recipient both denies the history of tuberculosis. We asked.
So it was even 6 years after post-transplant, so probably de novo.
De novo, yes.
Okay. Good.
Thank you, ma'am.
The next case presentation is by Dr. Deepa, Page kidney and uncommon cause of secondary hypertension.
Good afternoon, everyone. So this was a very interesting case we came across, a case of a patient who was already diagnosed to have Page kidney, and he came to us to the OPD with uncontrolled hypertension. So he was a 44-year-old gentleman, and he has been suffering with uncontrolled hypertension for the past 20 years. And his mean blood pressure used to be around 160/100, but there have been peaks where the blood pressures have gone to about 200, which really worried him. He does give history of smoking for 20 years. He was investigated thoroughly for all causes, for renovascular and other parenchymal and endocrine causes, which really didn't lead to any diagnosis. And there were imaging studies which were done, and those images were available with him. And let's look at those images. So if we look at the CT, we can see that bilaterally perinephric collections are there, and they are more on the left side as compared to the right side. So this is again in the sagittal plane. So a quick look at his labs. His hemogram was fine, lipid profile was normal, We specifically did a ANCA profile because there have been 1 or 2 case reports where they have said that ANCA vasculitis can cause spontaneous hemorrhage and lead to page kidney. The creatinine was 0.9, urine routine was normal. Despite the long-standing hypertension and the compression, the 24-hour creatinine clearance which was carried out by us was 102. The endocrine workup, that is for NORAD, adrenaline and the VMA was fine. Thyroid profile was normal. The ultrasound which he came with showed right kidney 9.8 centimeters with a 5.5 centimeter collection, and the left kidney was 8.1 with a slightly smaller collection. The 2D echo ejection fraction was normal, but there was definitely concentric LVH which suggested that this hypertension was long standing. There was no evidence of renal artery stenosis which was done on the Doppler. We also went ahead and got a sleep study done with him just to see if that is also contributing to his uncontrolled hypertension. Overall AHI was okay, but in the REM sleep the AHI increased to 40. So we decided to intervene and see what we could do in the most non-invasive way, and so he was sent for an ultrasound guided perinephric fluid drainage. Almost 700 cc was drained from the left kidney and 150 cc from the right kidney. The content of the fluid was similar to serum, and the creatinine, as you can see, is 0.72, and so it was transurative. The post-TAP ultrasound shows a significant reduction in the perinephric collection as is observed. So post-perinephric fluid tapping, we were really excited to know what happens to the blood pressures, and the blood pressures actually normalized to 140/80 within the next 48 hours. And we actually had to start tapering the BP medications one by one while he was still in the hospital, because we kept him under observation to see what happens to the BP. And but only to our dismay that they had to be reintroduced again at the end of 1 week. The BP again started climbing. So one by one, periodically we had to again start reintroducing the medications, albeit at a lower dosage. So his current medications include telmisartan, amlodipine, hydrochlorothiazide and prazosin, and his mean blood pressure is at 140/90. So we did a quick literature search to see of the case reports which have reported page kidney. There are a number of case reports, but I could find relevant case reports, 4 of them. But most of these cases, they have been diagnosed and they have been immediately intervened. This patient who came to us almost after 20 years of diagnosis of hypertension and his page kidney. So this is a long-standing case. So if we go back and have a quick look at the CT image, it is we can actually see that their capsule is kind of calcified. So the basic pathophysiology, they say, is there is compression of the parenchyma, ischemia, a high renin state which leads to the hypertension. So though we have temporarily relieved the compression, it's hard to say whether we have achieved long-term success in this patient. So therapeutic options, we did continue the medical management and we have received reasonable success. The BP is around 140/90. Do we keep imaging him frequently and do a repeated percutaneous drainage? Probably no. That would carry a risk of infection, but we have to think about it. The other thing is, do we go in for an invasive procedure like open drainage and capsulotomy? That is again another intervention which we could think about. Whatever has been reported in case, they have done a unilateral nephrectomy in people who have got page kidney on one side because of hematoma secondary to trauma, and that has actually cured them of the hypertension. But in this patient, he has bilateral collections and the kidney function is absolutely normal. So that is not a possibility for this patient. I would like to end my talk with this. Thank you.
What is the occupation?
Pardon?
Occupation of the patient?
He is working in a professional, he's in a lab. He basically works in labs.
Okay.
Any lab microbiologist
Any
kind of.
AV malformations or bleeding diastasis? that
No,
we are aware of?
absolutely no. There is no history whatsoever of trauma. There was no AV malformation detected, no renal artery stenosis, nothing on the Doppler. We kept asking him again and again whether he doesn't know about it, can't recollect, but he says no history of trauma.
So that finding was there for last 20 years?
Yes.
And it was all missed?
It was diagnosed, but since he was taking BP medications and his creatinine was normal, nothing was really done about it. It was just left alone.
It's quite surprising that no one...
I mean, for us too.
So, any question from the audience?
This collection seems lymphatic collection. And there are plenty of cases where bilateral perinephric lymphatic collection where you get this type of pictures.
Okay.
And they are benign, they don't really do anything.
Yeah.
So I don't know whether that's the proximate cause for his hypertension completely. Because if you see the literature, and actually even IKD had reported 7 cases of bilateral perilymphatic collections in the native kidneys. We also had one patient like that. And of course they didn't have severe hypertension as you described.
Yeah.
But when I reviewed the literature, nothing is to be done. Because many patients, I mean this is not an unusual finding to find bilateral lymphatic collections around the kidney.
Yeah.
So I don't know how much is it contributing to the page, because any page would have led to a reduction in the graph or kidney function or something.
Right. That is what surprised us, because and his blood pressures are really uncontrolled, and that's the main reason he came to us with it.
That's the cause.
So the pathophysiology has been clearly defined in most of that the compression causes ischemia and high renin. So, but
ischemia would have led to
no, not yet. I mean, it's been 15 days. We plan to do another imaging. Yeah. So it didn't fill up. I mean, the sonography which was done after 1 week, because his blood pressure started climbing again, shows. This is the USG which was done after 1 week.
But after tapping, blood pressure temporarily improved significantly.
Yeah, for 1 week.
That is, we can go for lymphoscintigraphy and see whether there is a leak.
Surely. I mean, we'll definitely take that. We'll do it next for it.
Good.
So the conundrum we have is that we are seeing this, kidney function is great, lot of fluid, there is pressure, so there is high renin. This guy is moving around with 210 by 110. We had to do something. We did all the tests, everything is negative. What do? We put in a needle and drain it, and lo and behold, the BP drops to 100 by 70. BP medicine had to be stopped for 3 days, and he was rejoicing, and the 4th day he called and says, my BP is rising again. So what is it that dropped the BP? What is it that is raising the BP again? Is something that we haven't understood. It has not reaccumulated because we got another ultrasound done. And sorry.
Before the tapping and after tapping, if you would have done the MAC3 scan to look for the tubular compression and how much is contributing, because sir is definitely raised a good question. If you tap all and his blood pressure is controlled, but then why he is again rebounding the blood pressure? So now this time on imaging, if he has a recollection, then you can see the MAC3 scan and compare that. So before tapping and after tapping. So the difference will give the idea.
Thank you.
As a 4th case presentation by Dr. Bhagwan Kalani, arterial thrombosis in nephrotic syndrome.
Good afternoon, everyone. Firstly, I would like to thank the organizers for giving this opportunity to present this interesting case. This is about a 16-year-old boy. On his first visit in February 2021, he presented with edematous illness. He had edema up to knee joint as well as facial edema. His vitals were stable. Pulse was 96 per minute and BP was 100 by 70, and there was normal systemic examination. His labs showed normal CBCs, create of 0.96, total protein 4.5, albumin 2.11, 4 plus protein, and 1 to 3 WBCs and 1 to 2 RBCs. The urine protein create ratio was 12.4 and the cholesterol was 668. So the initial diagnosis, or we made the diagnosis as nephrotic syndrome, and he was advised kidney biopsy in view of nephrotic syndrome with normal sized kidneys at the age of 16 years. So he was put on salt restricted diet, water restriction, and he was also started on oral prednisolone 2 mg per kg per day, diuretics and supportive treatment. Now his second visit was at 1 a.m. in the night on 1st of March 2021, and he presented with left upper limb pain with cold peripheries, chest pain radiating to the left upper limb, and it was associated with vomiting. On examination, the left upper limb pulsations, radial and brachial artery were not palpable. Left upper limb SpO2 was 90 to 96%. Blood pressure was 96/70 in right upper limb. ECG showed QS complex in V1 to V4, suggestive of an evolved anterior wall myocardial infarction. He was given ecosprin, clopidogrel loading dose, Nicoran 5 mg, and he was put on intravenous heparin infusion. I could not get a cross reference of cardiology at that point of time, so we just played safe and we just put him on antiplatelets and heparin. Remarkably, patient's pain in the left upper limb and the chest subsided within 6 to 8 hours after starting the treatment, which was also not expected by us also. And on examination, the left upper limb radial brachial artery pulses were improved and they were palpable, and SpO2 had improved in the left upper limb to 97 to 98%. The left upper limb Doppler showed a partially recanalized thrombus in the distal brachial artery just above the bifurcation and extending distally into the radial and ulnar arteries. Patchy color flow was seen in these arteries. This is after the intravenous heparin infusion. And his echocardiography showed a regional wall motion abnormality, EF of 40%, severe hypokinesia of the anterior wall septum, distal IVS and apex was noted. And also a mobile LV mass measuring 2 by 1.2 centimeter was noted. Initially it was diagnosed as query tumor or query clot or query vegetation. During this episode, his creat had gone up to 2.29. He had steroid-induced leukocytosis. Albumin was still on the lower side, 1.66. TROP-T was positive, and SGOT was also elevated, 253. Cholesterol was still high, 502. And blood culture was also done to rule out any possibility of infective endocarditis vegetations. It was negative, sterile. The coronary angiogram done showed a normal left main, normal LCX, normal RCA, and LAD appeared recanalized with some amount of residual thrombus. So the diagnosis was nephrotic syndrome with hypercoagulable state leading to anterior wall MI with LV thrombus and left upper limb ischemia due to thromboembolism. Patient was treated with heparin, double antiplatelet agents, Nicoran, antibiotic, ceftriaxone, and steroids were continued. His renal biopsy was deferred in view of the need of anticoagulation therapy for coronaries as well as the peripheral arteries, and he was discharged on antiplatelets, anticoagulant, and steroids. His proteinuria improved, urine protein became nil, and weight decreased from 56 to 49.2 kgs in 3 weeks by the end of March 2021, and his peripheral pulses were well felt. Blood pressure was 130/80. His labs were normal, and his urine protein was trace. And in the meantime, just because we were not able to do a biopsy to see if there was a possibility of a membranous nephropathy, anti-plaque to antibody serum was done, it was negative. His third visit, he continued to improve. He did not have subsequent relapses, and this was in August 2021, almost a year ago, and urine protein is absent. 2D echo showed persistently suppressed LV ejection fraction of 40%, and regional wall motion abnormality continued to persist, but the LV thrombus was not seen this time after the antiplatelets and the anticoagulation. So this is his last follow-up now in 1 month ago in August 2022. Creat is normal, urine protein is nil, urine protein creat ratio is 0.14, and he's fine, he's doing well. And his thrombophilia workup was done recently after stopping the anticoagulants and not in a thromboembolic episode, and his thrombophilia workup is negative. Anticardiolipin, protein C, protein S activity is negative. And his present treatment is he's off steroids but on antiplatelets, anticoagulants, and aldactone and carvedilol for his congestive or the EF 40% or LV dysfunction. So this was a case of nephrotic syndrome presenting as arterial thrombosis and as well as anterior wall MI. We are well aware about the venous thrombosis, but arterial thrombosis relatively uncommon finding to have in nephrotic syndrome. Thank you.
What was your dose of heparin infusion?
Heparin infusion.
Yeah.
We had put 5,000 units and we had started at 10 ml per hour, madam, at that point of time.
5,000 units and?
10 ml per hour. Yeah, 1,000 units.
1,000 units per hour.
Yes, ma'am. No, we did, in the initial episode, we had given him the option of biopsy, and till the time they could make a decision, he came up with this episode of chest pain and left upper limb thromboembolism. And since he need to be on anticoagulant therapy for his coronaries as well as peripheries, we deferred the biopsy and he continued to be in the remission. And what? Yeah, left ventricle is thrombus.
That was thrombosis?
Thrombus, madam. Yeah, it all has.
So left ventricular thrombus and thromboembolic phenomena.
Thromboembolus.
So
we did only anti-PLA2 antibody to see if there was a possibility of a membranous nephropathy.
It's an interesting case, and I have a recollection of a similar case a couple of weeks ago, so I would actually want to elicit a reaction from the audience, what they think about the connection between nephrotic syndrome and arterial thrombosis. And the case I'm referring to is about a 50-year-old guy diagnosed to have nephrotic syndrome, biopsy done, all three, minimal change, treated with steroids. Over 5 years, he had 2 relapses. Last, he was on a small dose of steroid and cyclosporin. He presents with, he got admitted somewhere far away with no movement of both his lower limbs and swollen limbs. So somebody calls from there, potassium was 2.9, so we told them fix the potassium. Potassium was fixed, no movement in the legs, swelling was there. Then somebody there thought maybe it's GBS, and they decided to come here. And when he came here, what was found was his entire aorta, midway down, was thrombosed. So he had ischemia of his legs, his anterior spinal artery got thrombosed, he had virtually a transverse myelitis kind of situation, and he was in a relapse situation. And the last follow-up we had was about a month ago, he was in remission. So the relapse as well as this thrombosis almost seem to have come simultaneously. So what is the audience's view on nephrotic syndrome predisposing to arterial thrombosis as against venous thrombosis, which we are all well aware of?
So, Vishwanath, we do see arterial thrombosis with nephrotic syndrome. We have seen in a few cases, and they have required even surgical intervention remove. The other thing is, this man was treated with steroids?
Yes, sir. He was put on steroids.
And he responded to steroids?
When he came with this episode, he was not in remission at that point of time, but subsequently he has responded. He did not require any other second line immunosuppression for this.
So that is the point I would like to make, that while you asked him an option of doing a biopsy, while he's taking time to make a decision, we can empirically put him on steroids.
Yeah, he was put on steroids, sir.
He was put
on steroids.
With many cases do respond to steroids.
Considering the fact the cholesterol was very high, 600, and age being 16 years, so, and they were taking some time to make a decision for a renal biopsy, but in the meantime, he developed this kind of complication. He was already put on steroids.
He was already on steroids.
No, very interesting observation, doctor. Yes. No, all of us must have seen, I'm sure, at least
I remember more than half a dozen cases of arterial thrombosis in a nephrotic, somebody even ending up with total ischemia and gangrene of the fingers and upper limb. Seen cases in the femoral artery thrombosis, and then, so that is not the issue. In this case, I am really surprised, and that to a minimal change like illness, presenting with anterior spinal artery thrombosis is something which is presenting with paraplegia. Is something probably you will have to review the literature and see how many cases have really been, and that to a patient who was in remission 1 month back, a patient with minimal change having a relapse and goes on to the state of hypercoagulable state to precipitate a arterial thrombosis within, say, theoretically 4 weeks of his relapse is something which is very unusual, but certainly a very interesting observation, worth looking into it and looking at the literature.
We have reported a case of hemiplegia as a presenting feature of membranous nephropathy. A young female of 35 who came with hemiplegia, and then she was found to have proteinuria. We did biopsy, it was membranous. She was treated with anticoagulant with a complete recovery of hemiplegia, and now she is in remission without neural deficit.
This is the third case which I have seen. 2 patients have presented with the anterior wall MI, this one, and the other one had membranous nephropathy, and one steroid resistant nephrotic syndrome presented as peripheral limb ischemia, almost to the development of gangrenous changes, and he was given peripheral thrombolysis by a pediatric cardiologist.
This patient is in remission for more than a year, and the obvious cause was nephrotic syndrome. You could not find any hemophilic factors responsible for thrombosis.
Yes.
So how long one should continue oral anticoagulants in this patient? Will it be lifelong? How long you plan to continue oral anticoagulants? Antiplatelets are okay, but how long anticoagulants?
Sir, we had a discussion on this. Per se, we believe that he should be given only antiplatelets at the present moment, but the hematologists differ in their view. They say if you have any organ infarction, then because of any thromboembolic episode, then you need to continue lifelong anticoagulation, and therefore he was reinstated on anticoagulation. And in the meantime, when he was off anticoagulation, in that time we did this thrombophilia workup, sir. Yes, sir. Yes. He did not have any features of SLE to start with, and the fact that he has responded so nicely, just like any minimal change nephrotic syndrome, I never felt that we should work him up, but definitely worth pursuing. Thank you.
But you did anticardiolipin antibodies, isn't it? Yeah, it has been. Yeah. Next is by Dr. Maulin Shah, immune thrombocytopenia in asymptomatic COVID-19 positive patient with idiopathic membranous nephropathy.
Good afternoon, one and all. I'm going to discuss one interesting case what we confronted in last 7 months. So, a 53-year-old gentleman presented with the history of pedal edema, generalized weakness, low-grade evening rise fever and dry cough for a period of 4 to 6 weeks. He also had a weight loss which was unintentional for a period of 6 months before this presentation. This was in December 2021. He did not have any history of hematuria, burning micturition, or anuria, or any frothy urine. Did not have history of any rash, any skin discoloration, any joint pain. He denied use of any herbal medicine, analgesic medicine, any skin lightening cream. He was a known case of hypothyroid, and he was on tablet Thyronorm 75, and thyroid functions were in acceptable range. He was not a smoker, did not drink alcohol, did not use any illicit drug. He took 2 doses of COVID vaccine before the presentation, and there wasn't any past history of tuberculosis, jaundice, or any blood transfusion. So on general examination, it was showing pedal edema, mild pallor, nothing remarkable than this. Systemic examination was also unremarkable. And this was the report with the normal renal function, mildly low HB, platelets normal, high cholesterol, hypoalbuminemia, complements normal, ANA normal. Urine was showing +4 protein with nephrotic range proteinuria. It was 9 gram protein in the urine. And USG was suggestive of bulky kidneys with thrombus in right renal vein. We also got CT chased and it was showing discrete lymph node, multiple lymph nodes in mediastinal as well as axillary. Sputum AB was negative. So we did renal biopsy and it was membranous nephropathy with tissue plateau positive +2, but serum plateau was negative. And these are the biopsy picture of that gentleman. Past was showing thickened capillary loops with here thickened basement membrane with occasional spikes. And this was the IF with positive IgG, granular IgG almost +2, C3, kappa as well as lambda. And IHC picture I did not have, but it was also plateau positive on IHC. On based off his constitutional symptoms and chest finding, he was started on ATT along with the anticoagulation and ARBs. Immunosuppression was not offered in view of probably it was a case of coronary COX also. So the plan was to observe him. It was a clearer diagnosis of primary membranous nephropathy with partial renal vein thrombosis with COX and with hypothyroidism. He continued ATT for 6 months, but somehow he discontinued neuro-oral anticoagulant after 2 months. He was not in regular follow-up with us. And then after 7 months, in month of July, he again presented with the pedal edema, frothy urine, persistent weight loss, and anorexia. This was for a period of 1 month. And this time, what we got in investigation, it was anemia with significantly low platelets. Malaria, dengue both were negative, creatinine was still normal, severely low albumin, complements were normal, but this time we got ANA positive. It was +4 and DSDNA was negative and U1 RNP was positive significantly. ANCA negative, urine +3 protein with no RBCs and viral markers were negative. So this was the ANA report with UM RNP positive and DSDNA was negative. This time again Doppler USG was suggestive of bulky kidneys with thrombus. Now it was extending into IVC, and on PET CT there was thrombus in pulmonary artery also. So there was a pulmonary thromboembolism. Bone marrow was done, which was unremarkable because in view of low platelets. Pleural fluid tapping was transitive, cultures were negative. And we followed him up. It was reduced significantly, started on methylpred, not improving. So on day 3, rituximab was given. Considering positive AN, and probably we are dealing with the hematological manifestation of MCTD. So it was given, but still it was on the very lower side. And now we revisited the reports and D dimer was significantly high. So we sent COVID, which was positive, and the CT value was just 16. He did not have any cough, fever, nothing, no hypoxia. Lupus anticoagulant, anticardiolipin, everything was done, which was negative. So what we thought on 3 differentials. One is probably it was MCTD with Sharp syndrome with asymptomatic COVID, probably chance finding, and we treated with steroid and rituximab on that basis initially. But point against this, there was no Raynaud's at all and no musculoskeletal symptoms. So considering arterial plus venous thrombosis with ANA positive, so we also like to rule out antiphospholipid antibody syndrome, but LA was negative and clinical scenario was not convincing, and this much low platelet with APLA is not very much common. We haven't seen that like that. So probably we were dealing with the ITP secondary to COVID-19, and the point favors that it was asymptomatic, but CT value was 15 only. Even after IVAG, it increased to 45,000 platelets, and it gradually improved to normal value at the end of 3rd week, coinciding with the recovery from viral illness. And for that, steroid and IVAG is the treatment of choice, that what we have given at that time. And this was the follow-up. I can see, I show you the follow-up platelets. So that were on day 4 IVAG, day 5 IVAG, it was 45,000, and then just we monitored. Even neuro-oral anticoagulation was also started after platelet improved, and subsequently on follow-up, these were the platelets. It was 160, 90. Now it is normal. D dimer is also less than 500. plan is to repeat ANA after 3 months. Still, it was just September, 12 September we got this report, and repeat imaging after 3 months. If we see the literature, it is there are few case series where the COVID with this isolated thrombocytopenia, it has been reported more in children and as well as in elderly population with some symptoms like menorrhagia or epistaxis, not like any, those all were having fever, cough, some sort of COVID presentation earlier. And this was the very unique case. There was no symptoms of COVID at all. It was just low platelets, what we found on investigation. This was managed initially at MPOH, and later on we managed with hematologists and rheumatologists at our institution. Thank you.
It would be really nice to know the comments from the audience about post-COVID.
This was again arterial thrombosis along with the venous thrombus we got. It improved to more than 11 now. And he is completely asymptomatic now. Even we have given rituximab for membranous, so we just continued that. We are just following for the proteinuria now.
Okay, thank you.
Thank you, sir.
Is a last presentation by Dr. Bharat Shah, panel reactive antibody train, a guide to treatment of antibody mediated rejection.
So this is about a 63-year-old male, a doctor. He's 7 years post-kidney transplant with increasing swelling and uncontrolled blood pressure. So this man underwent a living donor kidney transplant in 2014 when he was 55 years old. It was a preemptive transplant, and the etiology of his end-stage kidney disease was ADPKD. The post-transplant course was uneventful, and he stabilized at a creatinine of 1 milligram per deciliter, and he did well until 2018. He then had multiple problems. In March, he developed right thalomocapsular hemorrhage, from which he made a good recovery. In July 2018, he had thoracic aorta aneurysm. Thoracic endovascular aortic repair procedure was done, complicated by partial loss of vision in left eye. In 2019, he developed acute coronary syndrome, for which PTCA was done. In January 2020, he underwent bypass. In July 2020, he developed right vocal nodule, squamous cell carcinoma, exophytic, treated with radiation therapy. In April 21, he was admitted at a hospital for altered sensorium and found to have high blood sugars. So he had multiple complications in 2018 and thereafter. He presented to us in August 2021 with increasing swelling of legs and uncontrolled blood pressure. He had massive edema, and for his high blood pressure he was on following medication, and despite this medication he would have times when his blood pressure would be very uncontrolled. His routine urinalysis showed 3+ proteinuria. The urine protein to creatinine ratio was 3.7. Creatinine was 1.24. And the transplant kidney doctor showed reduced perfusion with increased cortical echogenicity. There was no evidence of renal artery stenosis. What to do? Until few years back, for someone presenting like this, we would do every permutation and combination to try and reduce the proteinuria. We had no answer. And unfortunately, there would be a progressive decline in function. How should one approach late allograft dysfunction? By 10 years after kidney transplant, up to 25% develop de novo DSA. Thus, it is not surprising that antibody-mediated rejection is the most common cause of allograft failure. In the past, we often used to think of CNA toxicity, but it's now realized that chronic allograft nephropathy is more of antibody-mediated rejection. In a multi-center cohort study, antibody-mediated damage caused allograft dysfunction late post-transplant in nearly 60% of renal transplant patients. Accordingly, we immunologically evaluated the patient for antibody-mediated rejection. His panel reactive antibody to class 1 HL antigens was negative, but to class 2 HL antigens was positive. Single antigen bead assay could not be done as donor HLA was not available. Allograft biopsy showed features of antibody-mediated rejection. Glomeruli showed thickening of GBM with double contour. There was no tubulitis. Vessels showed mild medial thickening and hyalinosis, and C4D was positive. He was treated as antibody-mediated rejection with plasma exchange followed by 100 mg per kg IVIG on alternate days. We didn't want to try increase in immunosuppression given his past history of multiple problems that he had, including a vocal cord nodule which was malignant. 4 such procedures were performed. After the 5th plasma exchange, 1600 milligram per kg of IVIG was given, making total dose 2 grams of IVIG per kg. UPCR, which was 3.7 milligram per deciliter, dropped, and blood pressure control also improved with requirement of less number of blood pressure medicines and a uniform control. And here you can see that his UPCR, here you can see that his UPCR has remained low at 0.4 to 0.5 from the time he has shown a response, and even today his UPCR remains around 0.3 to 0.4. His antihypertensive drugs now include azalnidipine, Concor and moxonidine, and he has a fairly well-controlled blood pressure. This was the PRA at baseline. The one in the blue line that you see is the PRA at baseline, and we have been following his PRA at 6-month intervals, and it shows that the PRA still remains low. So to summarize, late antibody-mediated rejection is the commonest cause of allograft dysfunction and graft failure. It is most commonly due to development of de novo DSA. Monitoring PRA is useful in identifying development of de novo DSA at an early stage. Rising PRA with increasing proteinuria and high blood pressure would suggest AMR. Prompt treatment can stabilize the graft function, and PRA trend could be used to guide your treatment of antibody-mediated rejection. Thank you. Harish, can you come to the mic?
It's a great case, and there's definitely we underestimate the DSA de novo development. Just in this case, I want to know the dose of mycophenolate, how you maintain the mycophenolate dose till you come across with this proteinuria and the problem with the rising uncontrolled blood pressure.
No, his maintenance immunosuppression remained the same. We didn't make any change, and by this time most of our patients will be on mycophenolate sodium 360 milligram twice a day.
No sir, that's only I'm trying to this one, because what happens now, we goes only by a fixed dosing of mycophenolate mofetil, and we not have like assays to have a AUC, because sometime what I see in the literature also, and myself and our experience also in a CMC, Susina is also there, she can correct me. So like that, de novo development of donor specific antibody. So then definitely somewhere there will be a dosing we are giving appropriate as recommended, but probably it's a gut or the AUC which is developing, that is not developing. So that may be the one reason ki in spite you are maintaining the good doses, he has developed the de novo, and then definitely that ki we have to practice this. This only I want to point it out. Thank you, sir.
Sir, in a similar situation, if the creatinine would have been 3-4 and the graft biopsy would have shown a lot of IFTA and glomerulosclerosis, would you have given similar treatment or would you have differed in your treatment?
So,
this patient had only proteinuria and creatinine was 1.24 after 7 years.
so that is precisely the point I am making by this case presentation, that we should not wait until the things progress. Picking up at an early stage, when it starts developing significant proteinuria and worsening blood pressure, is the time when any therapy is likely to be effective.
Yeah.
Once the creatinine goes to 3 and you develop IFTA, no matter what you do, nothing works. Then it's a progressive condition.
Okay, thank you.
If there are no more comments, we declare it as closed. Thank you.
So, I think we had a wonderful session. Each case had something new, unique thing, and which initiated a scientific discussion. Without wasting much time, a small announcement here. We are heading for poster session. Posters are divided into two sections. One is in Chitrakoot Hall, which is behind this hall, and other one is in the dome area, that is the lunch area. And after the poster session, that should be about 45 minutes break, we'll meet here again for next scientific session, that is around 4 o'clock sharp. Thank you everyone.
Check.
कैमरे पे था इधर खड़ा था काम इधर सुशांत वो लोग के साथ क्या रखा
में
हेलो
हाँ सर बोलिए ना। हाँ नहीं थोड़ा औरंगाबाद आ गया हूँ, तो भाई को बोल देता हूँ टाइम के बाद ठीक है। हाँ बोलिए। ठीक है भेज देना, पर क्या मैं थोड़ा औरंगाबाद आया हूँ, कल आऊँगा, परसों आऊँगा इसी। हाँ परसों मिल जाएगा शाम तक। चार्जिंग में डालना है ना, भाई क्या हुआ मेरा पांडु नहीं अभी नहीं किया मेरा अभी थोड़ा आराम किया इधर बैठता हूँ ना मैं सुबह नहीं निकाला उसको कितना देना।
अरे ये लोग पता नहीं कैसे निकालते हैं। हाँ, चार पांच निकाले, वो भी सही नहीं निकाले हैं।
क्या सही निकाले ये बसता है
बजेगा ना भाई, लगाए काई के लिए हम लोग हैं।
अरे क्या हुआ
ये क्या हुआ इसका देख
गेटिंग इन द रीड डोंट टर्न ऑफ योर कंप्यूटर ओके
वो बाहर ना लेके निकल
तो
साला स्टेटस डाला हुआ है साला पता नहीं क्या होता है क्या होता है क्लियर करना है कान से भी कर दिया डिसेबल सेटिंग ये डिलीट हो जाएगा स्टेटस रखना स्टेटस क्या डिलीट करना है ये बताइए क्या लिखा है कान से टेंशन है ना जिंदगी में। सब मोबाइल में गान नहीं करते पैसा आएगा। कल भी कुछ तो किया था ना मोबाइल में इसने, वो बोला था इतने हो रहा है टीवी का तुम्हारा मजे ही मजे था, रुकना चाहिए था। फिर सवाल की जिंदगी तुम जी रहे थे, हम लोग तो नरक में चले गए थे। आपको लेट हो गया, रुकना चाहिए था। 12 ही बज गया था आने में, तो रुकना चाहिए था ना, मजा था। अभी आपको लोग एनर्जी देगा, क्या देगा एनर्जी, इसलिए अलावा कुछ नहीं देगा। जो भी लेना सुमड़ी में लेना, लगी है सामने तो भाई वो ला के दिए उसको तो ऊपर नहीं मिला, एनर्जी लेंगे एनर्जी बंद हो गया भाई। अरे यार वही है ऑपरेटर। भाई इधर दूंगा बंद रहेगा ना तो खाली खबर दे लैपटॉप है कल कॉल करेगा ये भी इधर दूंगा। क्या बात कर रहा है?
सध्या मग पेशंटला कन्झर्वेटिव्ह नाही म्हणून सांगून काय म्हटलं सर काय
चालू करा दो काही नाही पण सुरुवातीपासून हेच प्रिन्सिपल ठेवलेलं आहे नो वेटिंग जो है चालू ठीक ये तो होना ही टाइम से होना ही चाहिए है ना हेगड़े सर है वहाँ सामने चालू करो
सर टाइमिंग 7 मिनट है
7 minutes हाँ तुकाराम is here you can start तुकाराम is here
Right.
Pandya is here
Right.
जो नहीं रहेगा वो तो पोस्ट ग्रेजुएट है ना they are supposed to be here
Right. So, welcome each one of you again. Let's start the next session. Dr. F.F. Wadia grant presentation. I would like to invite chairpersons, Dr. Umapati Hegde on the stage. He is Vice Chairman, Department of Nephrology, Mujibhai Patel Urology Hospital, Nadiad, Gujarat. He has published a lot of articles, book chapters, and he has been Chairman of Scientific Committee, ISN West Zone Chapter. So, Dr. Umapati Hegde, please take your chair. I would like to invite another second chairperson, Dr. Atul Mule. He is consultant nephrologist and clinical epidemiologist, Department of Nephrology and Transplant Medicine, Dinath Mangeshkar Hospital, Pune. He is a DNB teacher. He is Vice Chairman, Zonal Transplantation Coordination Center, Pune, ZTCC, Pune. I would like to invite Dr. Tukaram Jamare from KM Hospital, Mumbai, to start his presentation, which is on complement system abnormalities in patients with atypical HUS. Over to you, doctor.
Thank you. So I will present the interim report of a project for which we received FF grant from ISN West Zone. So this project was about the genetic abnormalities that are prevalent in patients with atypical HUS that are encountered. It is one of the most common renal emergency in our practice. We started with this rationale that what are the genetic abnormalities that are specifically associated with this disease in our population, and are there any predictors, clinical and genetic, of the persistent renal damage that is one of the common complication even after the apparent recovery of AKI in these patients, and whether there are any predictors. So we set out with evaluation of the genetics based upon the data that is available in India. Initially we thought of screening for deletions by MLPA followed by NGS if it is negative, and this was the primary endpoint, that is persistent kidney dysfunction defined by persistent hypertension, proteinuria and decreased GFR. Several secondary outcomes were also studied. We prospectively evaluated this cohort from our renal clinic, adult and pediatric patients with AHUS. Minimum duration of follow-up that was required was 3 months, and patients with known secondary causes were excluded. We evaluated basic clinical demographic parameters that are standard of care in the evaluation of such patients, and at the outset we collected the sample for genetic testing. In addition, several management details were recorded, immunosuppression, plaques, frequency and etc. and outcomes were evaluated. These patients were followed up in our renal clinic initially as demanded by their renal function at discharge, and subsequently every 3 months. We dealt with a very young cohort of patients. As you can see, median age was 14.5 years, and almost half of them were females. Most of them presented with advanced AKI with complications of renal failure. Severe hypertension was common. Hypertensive emergencies were observed in around 30% above patients. Severe anemia was there. Platelet count was around 50,000. And at discharge, a significant proportion of patients were requiring multiple antihypertensives. Anti-H antibody was positive not only in pediatrics but even in patients who were about 12 years of age. 70 to 80% had anti-H antibody positive. Some triggers were identified in the form of infections, drugs, systemic diseases and pregnancy. 90% of the patients received the plaques. Some patients had spontaneous recovery of renal function that was apparent at the time of consultation itself, so they were not offered this treatment. And about 35% underwent kidney biopsy. This was the immunosuppression that we use whenever it was indicated. Steroids in most of them, and several others depending upon the indication, severity and affordability as well. We are following these patients up. We have completed about 3 years plus follow-up of these patients. Of the 60 patients that are in our follow-up, 80% had one or other abnormality of kidney function even at the end of 3 years of follow-up. These included most commonly hypertension, followed in frequency by proteinuria and then by decreased GFR. 11 patients relapsed, 5% that is 3 are on dialysis because of lost kidney function, and 10% that is 6 died. Of the 6 died, persistent kidney injury was observed in all of them, and 3 of them were in relapse when they were hospitalized. What were the associations with the persistent kidney injury? That is the primary outcome. Prolonged hospitalization was one of them. Multiple antihypertensives, not statistically significant but numerically yes, and relapse was associated with persistent kidney injury. Several other parameters were studied, whether they were associated with persistent kidney injury. This is a univariate analysis, and anti-H antibody specifically here to mention was not associated. Genetic analysis is not yet complete. it's ongoing. We have done MLPA for 10 of our patients. Samples are collected for MLPA and NGS for 32 patients. And we are evaluating these factors and their association with the outcome. And these are the results in the patients in whom, as described in the Indian literature before, this large deletion in the CFHR 1-3 were amongst the most common abnormality that are observed in the patients studied so far. And there were some variants of unknown significance also they were observed. One patient did not have abnormality on MLPA. So these are the detailed reports, homozygous duplications. So deletion and duplications are the predominant ones, and then sometimes heterozygous, and then C3 gene mutation. Most of them are known mutations and some are variant of unknown significance. So this is the interim report summary of our projects. 91% of the patients presented with severe AKI and 80% were in fluid overload, 70% were hypertensive. Antibody positivity was very common, even in the adults, not only in the pediatrics, and triggering factors continue to remain elusive. Hypertension is extremely common, emergencies are common. Duration of hospitalization initially probably is a marker of, again, the severity of illness, and severity of kidney injury was a strong predictor of persistent kidney dysfunction. However, several known severity factors like hematological severity and factor H positivity were not associated. So we have learned so far that these patients are at extremely high risk of chronic kidney disease in future. Given their age of 14 years, they require very close follow-up, and we are looking forward to find whether we have some genetic predictors of the patients who are likely to recover without sequelae, or the ones which recover completely. Thank you.
Thank you, Dr. Tukaram. What about when we are going to analyze this patient's genetics?
So,
what is the hurdle? Anything
yes,
zone, or we can do it anything?
So we are collaborating with KM Pune for the genetic analysis MLPA. These 10 patients we have done at our end itself, but in next 6 months, Dr. Lobo is, if he is here around, he may. So timeline is given of 6 months. We have ready samples. So because of COVID and their lab assigned to genetics of COVID, all that got delayed. But likely in next 6 months, we will be able to process all the patients' sample for genetics.
Any C3? What about the C3 in these patients? Whether they are low or?
Yes, it was low in about 60% of them, but that was not sensitive enough to be diagnostic of.
Any questions from the audience? Any patients who are requiring continuous plasmapheresis or intermittent plasmapheresis because getting multiple relapses?
Yeah, so we had patients who have relapsed on more than 3 occasions, at least 3 of them. And those patients had persistent renal dysfunction, and they were treated as they recurred. None of them required continuous or periodically or proactive plasmapheresis as such. They required it for relapse, but they were achieving remission at the end of each treatment.
Thank you. Thank you very much.
Thank you.
I would like to invite next presenter, that is Dr. Akash Pandya from MPUH Nadia.
Good afternoon. I am here to present the interim analysis of our project, Clotho in CKD at our institute MPUH. So Clotho is associated with suppression of several aging phenotypes, and alpha Clotho is found in proximal convoluted tubule and distal convoluted tubule and kidney, and secreted in circulation, which is the soluble form of the alpha Clotho. Clotho has both paracrine and systemic functions. In paracrine functions, in kidney, it's a co-receptor for FGF23 and helps in FGF causing phosphaturia. Directly inhibits sodium phosphate transporter and causes phosphaturia. It prevents internalization of TRPV5 and helps in calcium reabsorption in kidney. it has local anti-inflammatory action also due to its antioxidant mechanism. It prevents insulin resistance, helps in maintaining cardiovascular health, and maintains longevity of stem cells. So the key debate was Klotho levels are associated with various prognostic markers of health like cardiovascular health, vascular calcification, insulin resistance, and renal function. Klotho may have potential clinical implication into diagnosis, progression, and also external complication of chronic kidney disease. We designed our study to look for association between serum soluble alpha Klotho levels and parameters and outcome in chronic kidney disease patient at our center. So the aims and objective were to observe association of soluble Klotho with inflammation, mineral bone disease, progression of chronic kidney disease, and atherosclerosis. The study was a prospective observation single center study to evaluate association of soluble Klotho, CKD progression of and CKD and progression of chronic kidney disease and its complication. The inclusion criteria were adults older than 18 years of age because that's how the CKD is defined by CKD EPI. Diagnosed to have chronic kidney disease and are in CKD stage 2 to 4 because we want to see for progression also. And the first visit between October 21st to March 22, which is our registration period. Exclusion were pregnant female, CKD5 and patient on transplant list. So we required 4 ml of serum of recruited patient and it could be stored at -80 degree for 1 year. And we performed double sandwich ELISA of stored serum sample of 92 patients in June 22 by human alpha Klotho kit sold by MyBio source and distributed by Biotechnologies Delhi. So it's a quantitative sandwich. Detection range is from 0.05 nanogram per ml to 20 nanogram per ml, and all those who are non-chronic kidney disease adults will generally have more than 12 nanogram per ml of level with intra-assay variability of less than 8% and inter-assay of less than 10%. So I will present our interim analysis. We recruited 92 patients. We have run the first batch of Klotho and have second follow-up of 30 patients, and plan is to run second batch in November 22. So if we go into the Klotho and inflammation, we can see that as the Klotho in the first section, as Klotho level gradually decreases in patient, the GFR we see is also decreasing. The mean hemoglobin is decreasing. Mean albumin level is also decreasing. And CRP is increasing along with the ferritin, which is marker of inflammation. In mineral bone disease, we can see that as mean GFR and soluble alpha Klotho levels decrease, PTH level also increase. For staging of chronic kidney disease, we can see the mean GFR as it reduces in all the groups, mean Klotho level also falls. For atherosclerosis, we can see as Klotho decreases, the mean ankle brachial pressure index decreases and carotid intima media thickness increases. As of economical consideration, each alpha Klotho kit costs of 49,000 with transportation, and we have 96 wells. We can run 92 samples because we require 4 wells for standardization. What to be done is we have to see after follow-up batch we run and take follow-up of those patients. We want to see for significant reduction in GFR, requirement of RRT, cardiovascular event and death in those patients. Thank you.
Thank you for the interim analysis. I'll have a couple of questions. So, the data you presented were the cross-sectional, only the first analysis.
Yes,
right?
sir. First analysis.
So, what was the spread of Klotho level in a small range of GFR? Let's say CKD2.
It's a 0.28 to more than 12 in GFR of 90. That is the spread of Klotho.
In your sample.
Yeah, in our sample, sir.
So, in the patients of about 96 patients.
Yes, sir. 92.
So, whatever number of patients were, let us say, stage 3 or stage 4, what was the range of Klotho in that one subsection of GFR?
Chronic kidney disease patients, sir. Sir, as GFR reduced, Klotho also reduces. I have not categorized patients based on their chronic kidney disease stage and clotho range. That will do, sir.
What is the minimum clotho and a maximum clotho level you got?
That is, sir, minimum is 0.28 in a patient of CKD4 and maximum is more than 12 who is a patient of CKD2, sir. But mean of each stage we have taken, but the range of each stage I have not calculated, but I will do that,
mean, a scatter diagram would be very helpful otherwise.
Yes, sir, definitely, we will do that, sir.
So what is the normal level of clotho in the general population?
More than 12, sir. Indian population,
so whether we need to take Indian populations as a control to.
In the table that you showed, the upper category was more than 6.
Yes, sir. Yes, sir.
So why not up more than 12?
Sir, only one patient had more than 12. It's an outlier, sir. GFR was 90. I want to see for follow-up also, so I have included that patient, but it was an outlier.
All except one patient had clotho less than 12.
Less than 12, sir. Second highest was 8 nanogram.
Okay,
it's more than 6.
To have a sample.
I think we can take the donors, at least around 20 donors. So as a control, how much it is in the Indian population?
Sir, actually, what we plan to do is take 25 at least of patients who are non-chronic kidney disease and also 25 who are on maintenance hemodialysis more than 3 months. So that will give us the range of clotho in Indian population, CKD or otherwise.
I'm not sure about dialysis patients. Transplant patients might be helpful otherwise.
Donors, sir.
In the normal population, it may be donors. He said the transplant population, what happens after the transplant, it may be helpful.
Okay.
That's what he said. Any questions from the audience?
Test regularly?
Commercially, it's not available in India, sir, but we can order the kit and it's available in 3 weeks time.
Okay, thanks. If no more questions, we'll thank you.
Thank you,
Akash.
So, I invite Dr. Kiran Bijapur to speak on sarcopenia in patients with ESRD on hemodialysis. Technical issue, so maybe we'll have to wait a couple of minutes till we get the slides.
To everyone, this is the Dr. F.F. Wadia grant which ISN West Zone gives. So each year it is given to 2 people. 1 lakh rupees is given. So it is in the last year 3 people were given because last to last year 1 person did not receive it. So last year 3 people have received it. So that is, this presentation belongs to the interim result of Dr. F.F. Wadia grant. So the ISN each year the people who are interested for this grant, they can apply before the stipulated time to Dr. Hasse sir was basically evaluating it. So it will be considered and it will be evaluated and the recipient will be announced after the AGM. So next year onwards also, if all people, all the residents or anybody, any consultant also, they can apply. This is the interim result of the last year's awardees.
A very good afternoon, everyone. Myself, Dr. Kiran Bijapur. Now, I am here to present my topic on sarcopenia in ESRD patients on maintenance hemodialysis. As we all know, sarcopenia is characterized by progressive loss of muscle mass as well as muscle strength, with risk of development of physical disability, poor quality of life, and death. It is highly prevalent but under-recognized in ESRD patients, more so in patients who are on dialysis. Sarcopenia prevalence has been reported as 28.5%, varying between 25.9 to 34.6% from different studies worldwide. It is diagnosed when low muscle mass is associated with low muscle function. Low muscle mass is usually diagnosed by using DEXA scan, CT scan, or bioelectrical impedance analysis, and more low muscle strength is usually diagnosed by hand grip strength, which can be done through handheld digital dynamometers. And the low physical performance is usually carried out by doing a 4-meter walk test or a 6-minute walk test, where if the patient is not able to cover a distance of 4 meters in a period of 4 seconds, it is considered to be low physical performance. Aim of our study was to assess the prevalence and etiology of sarcopenia, and if possible to correct the factors which will reverse the loss of muscle mass and strength among patients with ESRD on maintenance hemodialysis. Primary objective was to study the prevalence and factors contributing to sarcopenia in ESRD patients on hemodialysis. Secondary objective was to identify the response as measured by changes in the hand grip strength and skeletal muscle index to dietary counseling and adequate dialysis. Study procedure. Type of the study was prospective observational study. Sample size was 70. It was calculated using 22% of prevalence of sarcopenia with 95% confidence interval and 10% margin of error. Inclusion criteria was ESRD patients of age group 18 to 80 years who are on maintenance hemodialysis for at least 3 months. Exclusion criteria were bedridden patients who are not able to stand on the bioelectrical impedance machine, patients with CLD, malignancy, HIV, and active tuberculosis who on themselves can cause sarcopenia, patients of less than 18 years of age, and pregnant women, patients on hemodialysis for less than 3 months of age group. Methodology. Site of the study was done in Nephrology, PD Hinduja, Department of Nephrology, PD Hinduja Hospital in the AKD department. Institutional Ethics Committee approval was obtained before commencing the study. Patients meeting inclusion and exclusion criteria were enrolled after obtaining the informed consent. This is flow diagram of my study. Average KT by V of previous 4 weeks of hemodialysis session was obtained to see for the adequacy of dialysis. Nutritional assessment of patients performed in terms of body mass index, malnutrition inflammation score, hand grip strength, mid-arm muscle circumference, and skeletal muscle index using bioelectrical impedance assay, Tanita machine, and 4-meter walk test to see for the physical performance. The prevalence was calculated using skeletal muscle index and hand grip strength. Renal dietitian counseling at 0, 1, 3, and 6 months. That counseling included 72-hour diet recall of all the patients and appropriate adjustment as per the QI guidelines. Patients' dialysis monitored throughout the study, targeting a KT by V of more than 1.2. At the end of 6 months, nutritional assessment will be done again in terms of body mass index, malnutrition inflammation score, hand grip strength, mid-arm muscle circumference, and skeletal muscle index. Results between baseline and 6 months will be compared. Definitions. There are different cutoffs for sarcopenia definition. As per European Working Group of Sarcopenia for Older People 2010, it was less than 7.23 for males and less than 5.67 for females. And for Asian Working Group of Sarcopenia, it is less than 7 for males and less than 5.7 for females. And hand grip strength of less than 28 for males and less than 18 kg for females. So in our study, we have used Asian Working Group for Sarcopenia. Dialysis adequacy was defined as total overall well-being of the patients and KTB-V of more than 1.2 and urea reduction ratio of more than 65%. The study is still ongoing. We are about to complete the study by the end of December. So I am just giving the interim analysis of my study. Demographic features. Number of the patients enrolled was 70. Average age of the population was 55.37. Commonest comorbidities seen were diabetes mellitus 44.3%, hypertension was seen in 90% of the patients, and ischemic heart disease was seen in 32% of the patients. Mean CKD duration of the patients was 8.3 years plus or minus 5.2 years. Mean dialysis vintage was 3.8 years plus or minus 3.38 years. Results. 2/3 of our population was male and 1/3 was female, and the prevalence was seen in 1/4 of the patients, that is 25.7% of the patients had sarcopenia in our study. Grading of sarcopenia. Sarcopenia is graded into three things. One is probable sarcopenia. That's a new entity introduced by ASN Working Group for Sarcopenia in 2019. That is the patients who are having only low muscle strength. The muscle mass will be normal. So in our study, out of the 18 patients who had sarcopenia, 5 patients had severe sarcopenia. Severe sarcopenia are the one who had low muscle mass, low muscle strength and low physical performance. So total 5 patients out of 70 had severe sarcopenia and 13 patients out of 70 had only sarcopenia. So the total of 18 patients had sarcopenia, and of the patients who did not have sarcopenia, that is 52 patients, 6 more patients had low muscle strength. So they had normal muscle mass. So 6 plus 18, overall 24 patients out of 70 patients had probable sarcopenia. That comes to around 34.2% of patients had probable sarcopenia. Age distribution, more than 60 patients were 50% of the patients were of less than 60 years age and 50% were more than 60 years age. It is seen that prevalence is more in patients who are of more than 60 years of age with p-value of less than 0.05. Sex distribution, 2/3 were male and 1/3 were female. There was no statistical significance as we got p-value of 0.7. We wanted to see whether the dialysis vintage has anything to do with occurrence of sarcopenia, but in our study we did not get any significant. P-value was 0.472%. And among the patients who had diabetes, prevalence of sarcopenia was on higher side with a p-value of 0.0017%. And the hypertension was not significantly associated with sarcopenia. Adequacy of dialysis was measured using KT by V. Only 5 patients had less than 1.2 of KT by V. Other patients had more than 1.2, but the prevalence of sarcopenia was not significantly associated with low KT by V. HSCRP, higher levels of HSCRP was seen in 70% of the patients. That is also not statistically associated with sarcopenia prevalence. We also did other nutritional assessments like body mass index. That was also shown p-value of 0.4915. Mid-arm muscle circumference also we did. It shown that higher mid-arm muscle circumference had lower occurrence of sarcopenia, but however it was not statistically significant. Malnutrition inflammation score was recorded in all the patients. That is also not showing any significant association with sarcopenia. Inference, sarcopenia is highly prevalent in ESRD patients on hemodialysis, 25.7% in our study. Study is still ongoing. We have 38% who have finished 3 months and 8 patients who have finished 6 months follow-up. Further analysis of the data will be done after the study is finished. Part of the study was funded by National Health and Education Society and partly it was funded by Dr. F.F. Wadia grant, mainly used for study-related investigations and travel allowances. Thank you.
Thank you very much. So, what about your walking test and everything was done because the data
Yes, sir. We used 4-meter walk test in our patients.
Right. What was the patient? How many minutes they were?
Yes, sir.
What time they were able to finish?
Sir, 5 patients.
How much distance they were able to travel?
Sir, actually there are different tests to see the physical performance. As most of the patients were not able to continue a 6-minute walk test, we did a 4-meter walking test. So the patients who had gait speed of less than 0.8 meter per second were considered low physical performance. So among that, among 70 patients, 5 patients had low gait speed of less than 0.8 meter per second.
Is there any correlation with the NPCR?
Sir?
NPCR.
NPCR, I didn't get it.
Protein catabolic
surrogate of protein intake. Are you measuring protein?
No, sir.
You have collected dietary data, na? 72
Sir,
hours.
72 hours diet recall we are doing.
So you can use that data to guess or estimate the dietary protein intake.
Yes, sir. That we are doing at 0, 1, 3 and 6 months. The study is yet ongoing. So we will be doing at the end of 6 months. We are about to correlate dietary intake, diet components with the sarcopenia, and if there is any improvement after 6 months, after following the proper diet and adequacy of the dialysis as well.
Okay. You showed that the sarcopenia was more in those who have less than 1.2 kT/V. Is there any other factors responsible for poor dialysis, the time on dialysis, or any issues with vascular access or anything?
Sir,
because
as
if
of
you
now,
improve it, whether it will improve, that is the another
yes,
question.
sir. It is proved in many studies that lower dialysis adequacy has associated with overall poor nutritional status of the patients. But in sarcopenia, we do not have major studies. So that's why we will be looking after that in the studies. We are making sure that the patient is getting KT/V of more than 1.2 for the study period.
Overall, a very good study and quite novel. My only concern is that there are so many factors which may be potentially associated with sarcopenia that will be very difficult to tease out in a multivariate analysis, because the number of actual people having sarcopenia is pretty limited. So my suggestion would be to expand the numbers and get more people involved.
Yes.
Get at least 100-150 patients with sarcopenia, and of course 500-600 patients total. Then we can have a very good analysis to look at what are the associative factors.
Actually, we could enroll only 70% because our dialysis unit has 110 patients. Out of them, many of the patients were immobile, so we were not able to enroll them as well, and some patients did not give consent.
Team up with other people.
Any suggestions or any comments from the audience, please? If no suggestions or comments, thank you.
Thank you.
Thank you very much. And thanks to the organizers, and the session is closed.
So, nice interactive sessions of 3 presenters. I thank chairpersons and the presenters for this session. And without wasting much time, we will start with the next session, that is on acute kidney injury. I'd like to invite chairpersons Dr. Rajesh Bharani. He is consultant and head at Department of Nephrology, Bombay Hospital, Indore. He is ex-associate professor of AIMS Medical College, Indore, and organizing secretary of ISN West Zone, Indore, 2017. I would like to, sir, please take your seat. Yeah, I would like to invite Dr. J.P. Tiwari, who is professor and head Department of Nephrology, GMC Goa. He is ex-professor of nephrology, IMS BHU Varanasi. Let us start with the first case presentation, that is 30-year-old pregnant with preeclampsia. AKI pathogenesis on management, that is presentation on pathogenesis management of AKI. I would like to invite Dr. Kalpana Mehta for this presentation. Yeah. She is professor and head of Department of Nephrology, TNMC Nair Hospital, Mumbai. Yeah.
This way mouse works.
Good evening, everyone.
This one?
Yeah, right or whatever.
No, the next speaker is Dr. Kalpana Mehta. Requires no introduction. Everyone knows her. She is professor and head Department of Nephrology, the TN Medical College and Nair Hospital, Mumbai. She is teaching and clinical nephrology experience of more than 30 years. Initiated DM nephrology at the TN Medical College, Mumbai. His many research papers, and there is the first ABO compatible kidney transplant in Public Health Institute, Maharashtra. I request Madam for her presentation.
Yeah. Good evening, everybody. We'll start with the topic. Can we have the slide presentation here? I wanted the presentation in...
Bigger one.
Bigger one. Can you stop the time?
Time what is?
Yes. Yeah. So good evening, everybody. There is a declining trend of incidence of pregnancy-related AKI in developing countries, but still it accounts for around 5 to 20% of total AKI population.
Now, this is our own case studies where we had 70 cases of kidney dysfunction in pregnancies, which were about 2 years, which has been accepted by AJKD. And if you see, the most common causes of AKI in pregnancy were preeclampsia and sepsis, around 25 out of 70. So this is the one which I moved. No, this is not.
नहीं मैम बड़ा करेंगे तो क्या इसकी नहीं दिखेगी.
Okay. So the importance of this pregnancy-related AKI is obviously because of immediate affection on mother, involvement of maternal mortality, which is almost in our group was 18.2%, and the fetal mortality was almost 50%. We all know the definition of preeclampsia, and I will not waste time on it. It's a combination of hypertension and proteinuria, and we also know that in the absence of proteinuria, with new onset, one can diagnose and label preeclampsia. With new onset hypertension, with new onset of any of the following, these are the warning signs which I would read it out because they are important. Thrombocytopenia less than 1 lakh, renal insufficiency with creatinine of more than 1.1 or doubling of the creatinine in the absence of other renal disease, transaminase liver more than twice, pulmonary edema or cerebral or visual symptoms. Now coming to pathophysiology of preeclampsia, you know the 3 most vital organs affected are kidney, liver and brain. And it is a disease of maternal endothelium with widespread endothelial dysfunction with vasoconstriction of all majority of important end organs. And this causative role of placenta in the hypoperfusion is all known to us again because we have seen this is happening in the medical conditions with vascular insufficiency like diabetes and SLE. Also there is increased conditions like hereditary mole and twin pregnancies where there is an increase in the placental mass but without any corresponding increase of blood flow. Not only that, even at high altitude, the preeclampsia incidence is higher. Now, normally when there is a placental vascular remodeling, normally the invading tropocytoblast will take the maternal endothelial phenotype leading into the good large capacitance vessel. But in preeclampsia, though there is invaginous cytotrophoblast, it fails to acquire the endothelial phenotype resulting into the small capacitance and high resistance vessel. Now, if you look at the placenta, which in the preeclamptic woman, this is what it will show. It will show the changes of acute atherosis, which is usually with the macrophages laden with fat and the oil stain showing the red globules of the fat, with changes of intimal thickening, necrosis, atherosclerosis, and so forth. So if you come to a pathophysiology in short, because I can't really cover up every aspect in that time, but there are multiple factors responsible for it. One of them, which is said, is the oxidative stress. Now the oxidative radicals have been found in preeclamptic women, but whether it really has a causative role or whether it is just a secondary phenomenon and it has no clinical relevance in the treatment. Same thing applies for the inflammation. The debris of cytotrophoblast has been seen in the circulation causing the inflammation and is said to be responsible for the severe vasoconstriction. Immune intolerance to fetus is another next factor which has been considered, and that is said to be because of one is a HLA-G which is present in the syncytial trophoblast are important for this immune tolerance, and it is minimally expressed in this woman. Also, the NK cells which are responsible for the vasculogenesis are usually abnormal. So these two together leading to immune intolerance and another pathophysiological factor. Also the agonistic autoantibodies against AT1 receptors has been seen in these patients, in this preeclamptic women, which stimulate AT1 receptor leading to increased sensitivity to angiotensin 1 and again vasoconstriction. Beyond that, of course, there are other factors which have been said, including the, angiogenic factor which come to it, which are increased in this patient. And so these changes are seen prior to onset of hypertension and proteinuria, and not only that, it persists years after preeclampsia episode. So this is what we are talking about. The most promising pathophysiology which has been brought forth and has been used now is the angiogenic imbalance. Now we have the angiogenic factor which is VGEF and anti-angiogenic factor SFLT and endoglyne. Now there is upregulation of SFLT in placenta and there are increased levels of it which inhibits angiogenesis, and this is said to be the circulating pathogenic toxin in preeclamptic women. Now, the maternal serum levels of SFLT1 and endoglyne both rise to prior to preeclampsia onset. So, what are the renal changes in preeclampsia? Now, we all again know, and it has been documented, is that primary glomerular target in preeclampsia is endothelial cell. And VGEF is important for the health of the endothelium. And this is VGEF is expressed by glomerular podocyte as well as endothelial cells. And early in the course, the podocyte is normal, but in later course, in particularly severe cases, podocyturia is seen. And if you look at the postmortem reports and the renal autopsy, there is reduced expression of nephrin in this patient. So, if you look at the renal histopathology, because of endothelial swelling, which you call at endotheliosis, with the bloodless glomerulus seen, and on the EM one will see the fibrillar material, some endothelially placed. In severe preeclampsia and eclampsia, one can almost get, apart from bloodless glomeruli, the changes almost like early thrombotic microangiopathy. So, the AKI in preeclampsia is because of two main reasons: fall in GFR because of increased afferent arterial resistance and because of decreased ultrafiltration coefficient because of endotheliosis. And preeclampsia is the most common cause of AKI in pregnancy. But the DFR decreases is less than 30 to 40%, and requirement of renal replacement therapy is uncommon unless it is with severe preeclampsia or associated with HELP, which usually has abruptio placenta and coagulopathy, or there is severe PPH or sepsis. And this AKI has been accounted in HELP is almost around 3 to 15%, more towards 15% if HELP is there along with it. So can one prevent the preeclampsia or detect it early? And that is the thumb rule, that early detection, monitoring and supportive care is most important, with risk assessment in early pregnancy. And this is what we see at Public Health Institute, the patients which are referred from periphery, absolutely not much monitoring, and hence they land up in the very poor state. Adequate antenatal care is very important, because in women with no underlying disease, preeclampsia will be 5%, but if with high risk, it also straight jumps to 25%. So risk assessment early in the pregnancy is very important. Frequent monitoring after 20 weeks of gestation for hypertension, proteinuria, headache, visual disturbances, and epigastric pain must be looked out for. Uterine arterial Doppler or fetoplacental monitoring has a prediction of sensitivity and specificity of 65 to 85% and should be used and have been used at many centers. Now, next important now is the serum biomarkers. There are many, but what is used mainly is the ratio of SFLT1 by placental growth factor. Now, this has a negative predictive value of 100% as quoted in this study. And the significance of these markers, and especially this ratio, is that it is early detects, precede the clinical onset of preeclampsia weeks prior, higher in severe preeclampsia, higher in those with adverse outcome, and it also helps to differentiate from other diseases. So, can they prevent with aspirin? As per the literature, the low dose aspirin around 81 milligram per day has been the practice advisory by this group, and this has been given between 12 to 28 weeks and continued till the until the delivery. And these are the ones where they have used in these patients. As per the practical advisory, our common risk factors of multi-fetal gestation, chronic hypertension, kidney disease, diabetes, autoimmune diseases, any one of this, or one of the multiple factors in this, one of more moderate risk factors, including small for gestation, low birth weight babies, previous adverse outcome, family history, which are very important for us. What about the role of calcium? This has been studied again in these two studies. In this particular study, they have used it for patients who have the basal calcium intake of less than 600. The dose given was more than 1 gram per day, and they found there was a significant reduction in preeclampsia risk. And this was tested by this group, and they found there was no difference in incidence of preeclampsia, but there was lower rate of eclampsia, complications of preeclampsia, gestational hypertension, and neonatal mortality. What about the LMWH? Now the 15 studies which were studied here in RCT, the conclusion is that there is a significant reduction in the risk of preeclampsia and other placenta-mediated complication when started before 16 weeks. And if it is combined with low-dose aspirin, it is still further significant in reducing the risk of preeclampsia. I will not again go into more details. All of us are well known with which drug to use and which are the contraindicated drugs. But BP should not be lowered too much because we don't want fetal or maternal complications because of low blood pressure. What most important I would like to focus that the treatment is, all of us again know, is the delivery, the prompt delivery. Right? If it is less than, so generalization can be made, which cannot be always applied for all. Less than 24 weeks of gestation, termination of the pregnancy, because the complications in severe preeclampsia is more than 80% for the fetus and very high complications in mother. More than 37 weeks, immediate delivery. But in the gray zone between the two, potential neonatal benefit of continuing pregnancy versus possibility of maternal complication in delaying delivery, one has to consider. We have not used it, but dextran sulfate apheresis, which has been used presently for familial hyperlipidemia, has been used in 11 women, which have helped in the very preterm preeclampsia with the ratio of more than 85, and there was 81% reduction in the markers, improvement in proteinuria, and prolongation of the pregnancy. Is there a role of therapeutic plasma exchange in preeclampsia and help? No. Because this will delay the treatment. What is required is prompt delivery in this. But having said that, if the maternal condition doesn't improve in 72 hours, that is of course queries, the period which we say golden period observe, and if there is worsening during that period, then one must consider TPE along with the looking out for the causes for it. And we as clinicians, all of us are aware how difficult it is, and notoriously many times, to differentiate between preeclampsia and TMA, many times. So I quickly go through 3-4 cases. All of them have the almost severe presentation. This lady, gravida 4, 36 weeks, all the warning signs with high BP, creatinine which went from 0.6 to 2.3, proteinuria, Doppler showing severe placenta insufficiency, high LDH, high GOT-PT, low platelets, right? Now, we always, these 5 syndromes which can happen in pregnancy with the similar syndrome, that is TTP, HUS, acute fatty liver of pregnancy, acute phospholipid syndrome, and SLE. Now, this lady's cystocytes were negative, induced labor, improved markedly. So, obviously, she was a severe preeclampsia with HELP syndrome, AKI, complete recovery. But the point to be noted that she was detected to be hypertensive first time in the fourth pregnancy, and hence will need very close follow-up. This case, of course, it is not always so easy that everything is preeclampsia and AKI, as has seen by in this case. And she is a lady which is 27-year-old, third gravida, came, was somewhere else, 8 months of gestation, hypertension, diminished vision, fluid overload, low HB, low high count, platelet low, LDH normal, HGOT-PT as a 60-39, creatinine went from 1.9 to 5 and almost became dialysis dependent, was given antibiotics. And this is a CT scan of hers showing typical features of acute cortical necrosis. And the concerned, the hospital wherever she was outside, had labeled her as acute cortical necrosis, which was secondary to severe postpartum hemorrhage and sepsis together, apart from she being hypertensive and proteinuria earlier. And she was referred to us for transplant 3 months later. Now here was the patient where before taking her for transplant, we did her C3 nephrotic factor and anti-CH50 and including genetic test, where we did clinical exome which was negative for 6675 genes. And here we lose the graft on 3rd day. And the biopsy showed TMA without any other causes of antibody mediated rejection. So one has to be always alert when dealing with these cases. This was again bad obstetric history, seizures, high BP, IULB this time again not evaluated in type of 2 to 3 loss of pregnancies earlier, and she turned out to be APLA positive, right? So these are the important factors one must remember while evaluating this preeclampsia with AKI. And this is my last part of the talk, that what is the role, what should nephrologists evaluate the patient in long run is the follow-up required with nephrologists. So I'll look into these 3 parts. Looking at the recurrence of preeclampsia, now this is the study in BMC in 2009 where 7 lakhs plus primary mothers were evaluated with 21,000 multiple gestations. And if you look at that, what is the recurrence of preeclampsia? If the first pregnancy, no preeclampsia, 1.1. If second pregnancy, preeclampsia, 14%. And if both the pregnancies, first and second, have, then it's almost 31.9%. Now, the preeclampsia women who have early and severe preeclampsia have the greatest risk of recurrence, that is 25 to 65%. While those who come with mild preeclampsia in late pregnancy have 5 to 7%. So it is said that these two, late mild and early severe preeclampsia, might differ etiologically, and early onset preeclampsia being affected by risk factors like genetic and environmental factor and has familial aggregations and more complications. What about cardiovascular disease after preeclampsia? Now in this, it has been said that there is a graded relationship in this journal, American Heart Journal, between the severity of preeclampsia and the risk of future cardiac disease. And as one goes from mild preeclampsia to severe preeclampsia, the risk of cardiovascular disease increases too. And that also includes not only hypertension, stroke, thrombosis, as well as peripheral artery disease. And the last is that cardiovascular disease after preeclampsia is highest with early onset preeclampsia, early onset severe preeclampsia, recurrent preeclampsia, or gestational hypertension, or preeclampsia with onset as multipara as the highest risk. And the last is end-stage renal disease after pregnancy, those who develop preeclampsia. So microalbuminuria has been seen in almost after 3 to 5 years who develop from preeclampsia is around 23 milligram per day, while in control group it is 6.7 milligram. Those with preeclampsia with offspring weight of less than 1.5 kg have a higher incidence of kidney biopsy in mother, and the incidence of 3.7 per 1 lakh women per year of ESRD was noted in the NEJM from medical birth history of Norway. So this is the last slide. Post preeclampsia is follow-up required with nephrologist. Yes. Not all. Women with early onset severe preeclampsia, recurrent preeclampsia, gestational hypertension, or preeclampsia with onset as multipara for the first time. Thank you.
Thank you, madam, for covering this complicated topic so nicely. But you had made our life complicated by how to give this 81 milligram of aspirin. Thank you. Now the topic is open for discussion.
Actually, I have cut down many slides because I had to finish it in so-called 17 times. So, आपण मराठीत म्हणतो वाक पाठी लागल्यासारखं, so I had to really control it. There are other studies which have used 150 milligram. And in fact, when they have used 150 milligram, they have used the biophysical algorithm. Looking at the mean arterial pressure, even looking at the SFLT1, these multiple factors were combined together, and I agree, 81, they have said 81, but it is, have been also mentioned as 150 in some of the studies.
Madam, it's a very excellent presentation, the complicated topic, but only problem patient presents with the 3rd trimester pre-eclampsia with AKI, and usually comes with the IUD, some patient in ICU. Now, how to differentiate with the different entity, like this is due to preeclampsia, TTP, HUS? Because if you do the peripheral smear, histiocyte you not usually seen. That is the clinical spectrum is so overlapping. How to go ahead with these patients?
Yeah, actually that is the reason those three cases which we put it together. It is very difficult because TME will have its own presentation, as we said, with hemolytic activity. Same thing applies with HELP also. I mean, preeclampsia with HELP will also have the similar features. So only way is a prompt delivery, which is many times difficult to convince gynecologists because patient has thrombocytopenia and all those things, right? So and these patients, the best thing is prompt delivery. After prompt delivery, if there is no improvement, as it is said, wait for 72 hours, but it is very difficult many times. We have, again, I would resist one case where the patient improved in the sense creatinine started showing downward trend with increased urine output and everything, and she went out of radar, right? And only when was referred back with proteinuria 4+, and which was biopsy showing acute cortical necrosis again with TME, and the genetic studies also turn out to be positive, right? So that's what I'm saying, it should start very early detection, drive for prevention. Those hypertension should be looked into. Most of them, they come towards end age with creatinine of 2.5. They have a regular good follow-up, and in spite of that, sir, it will be difficult at many times, and only the prompt delivery, which is treatment, observe, if not, go for TPE, and simultaneously start working for the other causes of non-placental TMA or HUS.
Question from audience.
Okay.
Any comment?
Thank you.
Thank you, ma'am, for excellent presentation.
Thank you, ma'am, for in-depth discussion on pregnancy, preeclampsia and AKI. For the next talk, I would like to call upon Dr. Siddharth Jain, talk on post-operative AKI, causes and management. Dr. Siddharth Jain is a consultant nephrologist and transplant physician at Kidney Care Clinic, Surat, and attached to major hospitals of Surat. He has got multiple publications in various national and international index journals. So, over to you.
So, thank you. Good evening all. So we'll discuss regarding post-operative AKI. So acute kidney injury is a common complication in patients undergoing major surgery. It is associated with both short-term morbidity, mortality and long-term adverse outcomes. Perhaps there is a room for improvement in pre, intra and post-op period. So what is the outline of today's talk regarding why AKI matter to us? What are the diagnostic and staging criteria for AKI? AKI risk factor in perioperative patients, what are the novel biomarkers, clinical challenges, impact of fluid overload and take-home messages. So perioperative AKI is never a benign phenomena. The development of post-operative complication after major non-cardiac surgery, particularly AKI, has been consistently associated with substantial long-term morbidity and mortality. There is an increased risk of death. There is an increased risk of occurrence of other post-operative complication, increased length of hospital stay, and development of progressive chronic kidney disease. How common is post-operative AKI? So the incidence of post-operative AKI is different in different studies depending on the definition of AKI used and the type of the surgery. In general, incidence is high in major cardiovascular surgeries and intra-abdominal surgeries. How do we define AKI? So in 2012, KDIGO has defined AKI as increase in serum creatinine more than 0.3 mg per deciliter within 48 hours, or increase in serum creatinine more than 1.5 times the baseline value, or urine output less than 0.5 ml per kg per hour for 6 hours. KDIGO has further classified AKI into stage 3 depending on the serum creatinine and urine output criteria, which we all know. So how do we define post-operative AKI? So post-operative AKI is defined when the KDIGO criteria for AKI are met within 7 days of an operative intervention. So any patients who met post-operative criteria for AKI within 7 days, we call that AKI is related to surgery. What is the pathophysiology of post-operative AKI? So we all know to function normally, kidneys require normal renal blood flow, functioning glomerular tubules, and a clear urinary tract outflow for drainage and elimination of formed urines. So pre-renal AKI occurs when the perfusion to the kidneys is altered. Kidneys normally receive 15 to 20% of total cardiac output, highly perfused state, and this high perfusion rate makes kidney vulnerable to any sort of hemodynamic injury. Intrinsic AKI accompanies when there is a major structural component injury to the kidneys, embolic events and vasculopathies caused by malignant hypertension or microangiopathy induces damage to renal vasculature. Infectious organism can generate renal interstitial damage. Damage to renal tubules can occur due to profound hemodynamic deterioration in the kidneys or nephrotoxic substance such as antibiotics or contrast media. Tubular damage is the most common underlying etiology for intrinsic AKI occurring after any surgery. So tubular damage is the most common thing. So pathophysiology of post-operative AKI is usually multifactorial. So various pre-op factors like pre-existing kidney disease, diabetes, hypertension, sepsis, volume depletion, hepatic injury, crush injuries, along with various intraoperative factors such as hypovolemia, kidney ischemia, inflammation, increased intra-abdominal pressure, decreased cardiac output and vasodilation caused by anesthetic agents, along with various post-operative factors cause decreased renal blood flow to the kidneys and increased oxygen demand in the kidneys, giving rise to AKI. What are the risk factors for post-operative AKI? So comorbidities, demographic factors such as elderly age and male gender have been closely associated with AKI. Renal response to vasodilatic factors are weaker in elderly patients. Additionally, older patients are more often exposed to medications that can affect renal functions. Underlying medical conditions such as CKD, diabetes, hypertension, cardiovascular disease, liver disease, COPD are well documented risk factors predisposing patients to post-operative AKI. Obesity, especially when there is BMI is more than 40, is associated with higher incidence of post-op AKI. Abdominal obesity was particularly more associated with post-op AKI. Why? The reason may be increased related to changes in renal hemodynamics induced by adipose tissue in obese patients. Metabolic acidosis, low pre-op serum bicarb less than 23 MEQ was independently associated with twofold increase in post-op AKI. Metabolic acidosis is known to induce medullary ammonia production, which in turn activates alternative complement pathway and aggravates tubular inflammation in animal model. Additionally, excessive acid loading in mice results in reactivation of intrarenal RAS inhibition, RAS systems. This may contribute to AKI with patients of metabolic acidosis. Types of surgery. The risk of post-operative AKI is more in emergency surgery rather than elective surgery, and compared with other surgical procedure, intraperitoneal surgery has got more risk of AKI. Why intraperitoneal surgery? Because there is an increase in intra-abdominal pressure caused by excessive fluid administration in this type of surgeries, which results in the situation in which intra-abdominal pressure compresses renal vessels and activates sympathetic system, which is known as abdominal compartment syndrome, which triggers AKI. Major vascular surgery and cardiac operations also increases the risk of post-op AKI. Why? Because several pathophysiologic factors plays role like ischemia, reperfusion, injury, inflammation, microembolism, decreased renal perfusion. CABG operations using cardiopulmonary bypass were more associated with higher incidence of post-op AKI compared with off-pump CABG. Drugs. So several medications such as RAS inhibitor and NSAIDs increases the risk of post-operative AKI. Again, why these medications are thought to blunt the effect, compensatory mechanism effect that maintains GFR under hemodynamic compromise conditions. And the combinations of two or more nephrotoxic agents like ACE inhibitor, NSAIDs, diuretics increases the risk of AKI. Similarly, patients undergoing radiological examination involving contrast media before surgery are more at risk of post-op AKI. The mechanism of contrast-induced AKI is not fully understood, but may be due to direct damage from reactive oxygen species, and it is important to maintain effective blood volume in patients exposed to contrast before surgery. So these are the enumeration of risk factors for post-op AKI like age, male sex, ASA, CKD, diabetes, liver disease, CHF, hypertension, emergency surgery, cardiac surgery, perioperative nephrotoxic drug use, intra-aortic balloon use during CABG, intraperitoneal surgery, and perioperative use of contrast media. So this is a net-based risk predicting tool for prediction of post-operative AKI requiring renal replacement therapy. And this tool uses 11 markers like age, history of CHF, diabetes, ascites, emergency surgery, hypertension, pre-op serum creatinine, hematocrit, serum sodium, post-operative sepsis and type of surgery, which helps in predicting the risk of post-op AKI requiring renal replacement therapy. Coming to early diagnosis, so creatinine is used for diagnosis as per AKI criteria, but creatinine is having its own issues. What are the issues? The creatinine varies with the muscle age and mass. It is insensitive to rapid changes in the renal function. It is also insensitive to lesser degree of renal dysfunction, and we frequently doesn't have baseline creatinine. So there is a lag time, lost opportunity for therapy. Also, creatinine is altered by fluid shift and the fluid balance, and positive fluid balance can sometimes hide AKI, and hence there is a need for biomarkers. Recent investigations have focused on finding practical serum and urinary biomarkers that help us in identifying early injury before profound renal functional damage has occurs. What are some of the candidates biomarkers? NGAL, neutrophil gelatinase associated lipopelin, it is released from neutrophil and induced by inflammation. Elevated urinary and serum NGAL reflects tubular damage. Cystatin C is a protease inhibitor produced by all nucleated cells. It is filtered freely by the glomeruli and reabsorbed completely by the renal tubules. Cystatin C is normally not found in urine, and detection of cystatin C in urine may indicate tubular injury. Kidney injury molecule is highly upregulated in proximal tubules after kidney injury. Combination of KM and NGAL enhances the sensitivity of early detection of post-operative AKI. Then tissue inhibitor metalloproteinase and insulin-like growth factor binding protein 7 are cell cycle arrest protein. In the event of tubular injury due to toxin exposure, hypoxia, inflammation, these proteins are released in the urine. Recent and multicentric studies have demonstrated that TIMP and insulin-like growth factor binding protein 7 are superior to existing biomarkers for providing additional information in detecting AKI. So what are the biomarker time course? NGAL is usually released after 2 to 3 hours, KIM after 6 hours, cystatin after 24 hours, and serum creatinine is usually late after 48 hours. However, there are so many unresolved issues with biomarkers like lack of real world assay validation, timing and frequency of testing are uncertain. There is a lack of evidence of what best to do next, and the impact of testing on outcomes are not very clear. So what are the challenges in peri-op AKI? How we can keep it up? So what we can do for prevention? So there are several pharmacological and non-pharmacological intervention tried and tested for prevention of post-operative AKI. Coming to pharmacological agents, diuretics, vasodilator agents, N-acetylcysteine and statins. So diuretics have been extensively used for both prevention and treatment of AKI. It is thought that loop diuretics may decrease oxygen consumption, thereby potentially reducing ischemic injury and wash out necrotic debris, preventing intratubular damage. However, the use of loop diuretics is only recommended in the context of fluid overload, and it is not recommended for prevention of post-operative AKI. Vasodilator therapy. So the theory behind the use of vasodilator therapy like dopamine, phenol-dopam and atrial natriuretic peptide is that they increase GFR through renal vasodilation and cause natriuresis. So dopamine was previously used widely for AKI, but its use now is not recommended. Similarly, phenol-dopam, a multicentric randomized controlled trial of patients undergoing cardiac surgery showed that phenol-dopam did not reduce the need of RIT or 30-day mortality. However, it was associated with more hypotension. Its use is also therefore not recommended. Studies of atrial natriuretic peptide has shown potential benefit, but there has been small, underpowered, and there is an incidence of systemic hypotension, so its use is also not recommended. Other pharmacological agents like N-acetylcysteine, it is a potent antioxidant and vasodilator effect as a result of increased nitric oxide availability. The use of N-acetylcysteine in cardiac surgery has been extensively examined. However, there is no benefit. Statins have been studied again with conflicting results. Aspirin, clonidine has been studied again, neither reduces the risk of post-op AKI. What are the non-pharmacological intervention? This is maintaining renal perfusion through perioperative hemodynamic optimization. This is arguably the most effective means to prevent post-operative AKI. This involves use of perioperative monitoring and volume expansion through use of fluids, blood transfusion and inotropes to improve cardiac output and improve oxygen delivery. Importance of achieving the balance of adequate resuscitation without causing volume overload is becoming clear in the management of AKI. Fluid overload can be detrimental, leading to the reduction in GFR through increased subcapsular pressure and intra-abdominal pressure. So what are the problems with fluid overload? They do not resolve vasodilated hypotension, associated poor outcome, causes organ edema, tissue edema, causes venous congestion versus tissue perfusion and causes intra-abdominal hypertension. Choice of IV fluid, the high content of normal saline has been associated with increased AKI compared with balanced solution. However, RCT comparing NS with normal balanced crystalloid show no reduction in the risk of AKI in balanced crystalloid solution arm, and the use of hydroxyethyl starch is no longer recommended due to the concern of nephrotoxicity. Although there is no RCT to support the avoidance of NSAIDs, aminoglycoside, RAS and contrast media in perioperative setting per se, but there is ample evidence that nephrotoxins cause significant kidney injury in other settings. So minimizing exposure to nephrotoxin would be logical approach, especially in high-risk patients. Intraoperative strategy, most important is to avoid hypotension. Initial approach to mitigate intraoperative vasodilation is by fluid therapy. The concomitant use of vasodilator, vasopressor should be considered if hypotension doesn't appear to be fluid responsive. So targeting MAP of more than 65 has been demonstrated to improve outcome in several observation studies, and MAP less than 60 for 20 minutes or less than 55 for even 10 minutes has been shown to be associated with post-operative AKI. Once AKI is established, management approach is same like that of any other AKI. Diagnostic workup is obstructive causes should be ruled out, and prevention of further renal damages of paramount. Application of KD-KL bundle can be applied. This consists of supportive measures including volume replacement, maintenance of adequate blood pressure and avoidance of nephrotoxic agents. So management of AKI complications like management of fluid balance, electrolyte, metabolic acidosis, nutrition and procedure considerations. Finally, take home message, the incidence of post-operative AKI is growing with the increase in surgery in elderly and comorbid patients. Development of post-op AKI increases mortality risk, lengthens hospital stay and worsens long-term morbidity. Recognizing risk factor for post-op AKI and understanding the management option would be beneficial in prevention and improving patient outcome. There is no evidence to support the use of any of the pharmacological agents, interventions preoperatively for prevention of post-op AKI. In patients identified at high risk of post-op AKI, hemodynamic optimization is recommended, and interventions through judicious use of IV fluids and or vasopressor medication is appropriate response to minimize the risk of post-operative AKI. Thank you.
Thank you for lucid presentation. Any specific treatment apart from the risk assessment, hemodynamic monitoring and avoidance of nephrotoxic drug, what we have learned from this? Any specific treatment for that?
So once the AKI is established, there is no specific treatment, especially in the context of post-op AKI. We just manage just like a routine AKI, and the main thing is that use of KD-CO bundle, avoidance of nephrotoxic, maintenance of perfusion. And for maintenance, they shows that avoid nephrotoxic, trying to maintain volume, and all the pharmacological agents used for prevention actually has not been proven, so it's not recommended.
Any question from the house?
What about the use of SGLT2 inhibitors and metformin? These two drugs are also commonly used most of the patients.
So use of this two drugs for prevention of post-op AKI, sir?
Would you like to avoid these drugs in a post-op situation?
Yeah. So again, SGLT2 inhibitors definitely and metformin, both these drugs we would like to avoid post-operative patients, especially if they are high-risk patients, SGLT2 inhibitors, more chances of volume depletion and some chances of UTIs. However, newer studies and newer data regarding SGLT2 inhibitors, they have been shown that they are still using in previously there was a dictum that whenever any patient get admitted for any major surgery, they stop that. But the newer data regarding the DAPA, CKD and few trials show that it can be easily continued. Regarding metformin, definitely as we see that low serum pre-op bicarb is also a factor for post-operative AKI. So any patients creating more than 1.5 or patients of diabetic undergoing major surgery, we usually try to stop OHA and metformin and try to put on insulin sliding scales.
So now we conclude with a remark that minimum you intervene, maximum benefit you give the patient. Only manage the hemodynamics, metabolic parameters as and when needed, renal replacement therapy. Now for the next
session is virtual session by Dr. Claudio Ronco, and moving from diffusion and convection towards adsorption.
Yeah, so we'll move to the next session, that is virtual as sir has described. Dr. Claudio Ronco, he is head of division of nephrology in San Bartolo Hospital, Vicenza, Italy. He has over 1,000 publications and he is considered as authority in acute kidney injury and CRRT. So just a small announcement before we start the session. Chairpersons for the previous session, that is Dr. Umapati Hegde and Dr. Atul Mule, and the speakers Dr. Tukaram Jamale, Dr. Akash Pandya and Dr. Kiran Bijapur. Please, you may, if you are available, we may proceed to the backstage for felicitation. Let's start the next session.
Ladies and gentlemen, I've been asked to cover the rationale and role of adsorption blood purification. And I must say that whether you are in the acute or chronic setting, there is a complex increase in molecules in the blood of patients that may require blood purification and extracorporeal removal because their accumulation in the body of the patient represents a possible harm. And this is a typical example of how uremic ultrafiltration appears with presence of urea and other molecules compared to a normal ultrafiltration. There are several different separation processes. We are familiar with the classic separation by a barrier like dialysis, ultrafiltration. But we also have the possibility to include separation by solid agent called adsorption. While diffusion relies on membrane permeability and characteristic of the solutes, and one can expect clearance based on molecular weight, having large molecular weights, lower diffusion capacity, although they can be modified by electrical charges like lipophilia, protein binding, etc., or high filtration rate and specific sterical configuration. Still, diffusion coefficient tends to be limited by the permeability of the membrane cutoff. And in fact, membranes are classified by characteristics of permeability, leading to specific curves of sieving that characterize their ability to remove, in presence of diffusion and convection, specific molecules. As you can see here, most of the membranes are very much limited in the capacity of the removal of solids when you go above 10,000 volts. We have studied in the past the capacity of membranes to absorb pro-inflammatory mediators and become an active component. But then, if adsorption can be one of the interesting components of extracorporeal blood purification techniques, why not using specific sorbent technology? Therefore, while adsorption is a new option in the characteristics of membranes, using sorbent sorbents coupled with the classic dialysis may represent an interesting solution. Today's art of the name perfusion, which is passing blood through a sorbent bed, disclaims specific advantages, including overcoming limitation of dialysis membrane, potential selectivity of the process of removal, and possibility of classing the sorbent in contact with blood. But these require hemocompatibility of the sorbent, mechanical strength, no fouling of clotting activation, well-designed cartilage. The rationale is in the fact that we have a limited efficiency of membrane separation processes. We have possible selectivity of site exclusion in the absorption process, and the possibility of placing the sorbent in direct contact with blood is an important potential effect that, however, require again hemocompatibility. Sign-dependent non-selective absorption may cause unwanted losses, and we should consider this. And finally, sorbent might alter the requirement for repelling the circuit. The history of sorbents is quite long, but it's only at the end of last century that improved design and coating for better hemocompatibility led to hemoperfusion as a potential treatment for blood purification. Originally, this was simply a circulation of blood through a sorbent cartridge. However, with chills, fever, cutaneous rash, thrombocytopenia, aluminum load, due to the poor quality of the sorbents. But more recently, we have excellent sorbent, and in order to carry on hemoperfusion, we need effective and safe sorbent material, adequately designed cartridge, and optimal utilization of the funds. The requirements are basically high selectivity, high capacity to minimize the amount of sorbent, favorable kinetics for absorption, chemical thermal stability, hardness and mechanical strength, free-flowing tendency for easy filling of the cartridge, high resistance to fouling, no tendency to promote undesirable chemical reaction, possibility of regeneration, and relatively low cost. We have natural sorbents, zeolites, porous carbons. We have synthetic sorbents, dysfunctional and highly functional monomers, may lead to highly cross-linked polymers that are characterized by specific absorption capacity. And normally, you can see that polymeric substrates can be also functionalized with specific chemical substances. For example, DIA or polymixin B, or specific particles that can be functionalized with divinylbenzene or other compounds. They can come in solid gels, spherical or granular forms, and they have a fractional bed porosity in the range of 30 to 40%, using a three-dimensional polymeric network to maximize the surface available for absorption. Sorbents can be macroporous, mesoporous, or microporous, depending on the average pore size. But there is a pore distribution that actually affects the entire capacity of absorption. And as you can see here, per gram, surface area can vary from 300 to 1200 square meters. They can come in fibers, granules, sphere, pellets, flakes, powder. The most important aspect is the high surface area per gram of sorbent. How do we analyze sorbents? We use equations derived from industrial chemistry called isotherms, and we analyze equilibrium concentration and the amount of adsorbed substance in a specific experiment. For example, this is an experimental condition we did to test the capacity of absorption of the HA380 cartridge for vancomycin, and you can see a typical reduction in the concentration of the solid with the possible saturation of the cartridge occurring around 3 hours after the application. This is close to the isotherm curve. Certainly, there are several steps that should occur for absorption. The external interface bringing the fluid phase external to the sorbent beads, internal interface where the fluid permeates the bead, and finally surface diffusion and absorption onto the surface of the sorbent. Normally packing density is between 30 and 60%, and this depends very much on the characteristic of the beads. However, this influences the flow distribution analysis, which we tested in specific cartridges like the Jafron HA series, and you see that in all cases the distribution of the dye inside the cartridge is somehow describing a kind of blood flow with full utilization. Also, the utilization of these cartridges in conjunction with the dialyzer display no significant problem in terms of pressure profiles that remain stable, as you can see here, both in the arterial and venous side of the circuit over a significant amount of time. The all distribution guarantees the maximum utilization of the sorbent, but we need the mechanical strength to avoid somehow particle dissemination in blood. To avoid these, support springs or retention springs are utilized in the cartridges. There are several variables that affect absorption and from packing density to geometry of the fiber that describes the so-called interparticle porosity, which is governed by specific laws that are not only the Hagen-Poiseuille law, but also the Darcy law and the Kozenik-Karman equation that is well known to people studying industrial chemistry. Mass transfer zone is characterizing the adequacy of design of the cartridge, and as you can see here, maximum ideally efficiency would be when you have a completely stoichiometric front for a fixed bed absorption. Subsequently, however, you may have an even concentration built-in mass transfer zone, and when you have a mass transfer zone, which is the distance between maximum absorption and minimum absorption in the cartridge, exceeds the length of the cartridge, this means that the design may be not optimal. Also, beads may require time for the fluid phase to permeate inside, and most of the time only the surface area is utilized with specific forces, van der Waals forces, ionic bonds, and hydrophobic bonds, which are generated by the hydrophobic affinity. And here is a structure inside a bead where you can see absorption layers on surface of the channels and pores that can be strictly analyzed with specific techniques. In the past, uncoated charcoal was utilized with limited biocompatibility, and you can immediately see why this was occurring. But more recently, coating of the sorbents could be achieved, representing the possibility to put the sorbent in contact with blood. And from these, hydrophobic resins have been developed with a very, very smooth surface that limit at the maximum unwanted effects. And you can see here also a limitation in the used sorbent of absorption of platelets and endogenous proteins. Of course, coating may represent a limitation for diffusion of solids inside the bead, but nevertheless, development of macroporous resins more recently have allowed to utilize at the maximum the surface available for absorption, leaving solid inside the beads. We have studied the biocompatibility and the cytotoxic characteristic of these new sorbent cartridges. You see here the HA series from Jafron, produced in Zhuhai, China, and you see that both in static test and dynamic test, viability of cells was not significantly affected, apoptosis was not affected, and necrosis was not affected. This was done utilizing a specific cell line of monocytes U and 937. So available spectrum of absorption cartridges made possible to identify different clinical indications of these resins. And you can see here, for example, that hemoperfusion can be utilized alone or in combination with dialysis or CRRT, and this is the case depicted in these figures. We can have, for example, the HA130 applied in conjunction with the classic dialyzer in chronic patients where it has been demonstrated to offer significant benefits in terms of removal of larger middle molecules. And therefore, indications are described as potential solution for uremic toxin accumulation and complications such as beta-2-microglobulin, PTH, leptin, etc. etc. In some studies, the combination of maintenance hemodialysis with hemoperfusion has demonstrated safe and effective results in terms of reduction of specific large middle molecules. But also, these sorbents can be utilized after plasma separation, leading to removal of cytokines and mediators and bile and bile acids and liver products that can not be eliminated in case of liver dysfunction. Finally, this utilization of the HA330, 380 in critical disease has demonstrated beneficial effects for sepsis, burns, trauma, cardiac surgery, ARDS, and pancreatitis. And indeed, this sequential integrated approach to sepsis based on the cascade of events in sepsis may suggest possible removal of target molecules due to different potential solvents. Beginning can be utilized affinity filters to remove pathogens, for example, and this is the case of the serum. Polymix indeed-based medical device can be utilized to remove endotoxin. But after hyperinflammation occurs in sepsis, we know that patients may die due to overwhelming inflammation and late intractable inflammation. But they may also die due to late persistent immunosuppression, leading to the so-called immunodysregulation of sepsis. And the peaks of these different mediators can probably be targeted as potential for removal in blood purification therapy offering immunological support. As you can see here, most of these molecules are in the so-called large middle molecule of the new classification that we have contributed to create. And therefore, this HA330, 380 series has been mostly utilized in sepsis because of the capacity to remove molecular weight solids in the range of 10 to 60 kilodaltons, leading to the exploiting the capacity of the so-called peak concentration hypothesis, where higher substances in the circulation can be somehow removed and the peaks of the substances can be reduced in order to achieve some kind of immunohomeostasis. Changes in interleukin-6, interleukin-8 levels have been demonstrated in different studies, including studies where the solvent has been utilized in conjunction with the extracorporeal membrane oxygenation. The rationale for application of solvents is also typical in case of intoxication from pesticides, herbicides, biotoxin, drug overdose, and industrial toxins. And there are some emerging studies showing the evidence for clinical rescue after intoxication from these different substances. We also have advocated the use of solvents for cytokine removal in case of COVID. In this paper on Nature Reviews, in fact, this has been largely utilized all over the world, with the concept that, again, that peak of systemic cytokine release can be partially affecting inflammation and immunosuppression, and leading to the possibility to eliminate the peaks of these substances. Endothelial protection can be achieved by hemoperfusion or by hemoperfusion combined with dialysis. This is a typical example of a case of a patient treated with hemoperfusion for 3 days after being admitted to the hospital with COVID-19 infection and hyperinflammation, leading to hemodynamic stabilization, normalization of cytokines, and improved hormone exchanges at day 12. Not only that, but we also found specific biological results with reduction of cytokines, reduction of the amount of noradrenaline required to maintain adequate mean arterial pressure, but also restoring the capacity of monocytes to respond to inflammatory and endotoxin challenge, as it is in the case of sepsis. In particular, we have an improved capacity to present the antigen, and HLA-DR expression on the surface of monocytes is the typical evidence of this effect after treatment with 1 or 2 sessions of hemoperfusion. So, after 40 years of CRRT and dialysis, the evolution of devices and machines has recently led to the possibility to consider hemoperfusion, including hemoperfusion combined with hemodialysis and double plasma filtration molecular absorption system, as additional weapons in the hands of physicians that need to fight against critical care disease and also chronic kidney disease. With this, I thank you very much for your attention, and I like to give my regards to people who kindly invited me to give this talk.
There is no question answer session in this after this talk, but anyone wants to comment anything are most welcome. No, but he is traveling, sir, so he is not taking questions. It is recorded and he is traveling at present, so he requested. But if anyone wants to comment on this, they are most welcome.
I think a lot of us are using it sporadically, but it is hard to see. It will be interesting to see hard data, and that's what we are hoping to see, because there is no strong data to support absorption-based treatments at the moment. So, if anybody has data, please present somewhere so that we will see it.
Wanted to know the financial involvement in all this. And as Atul said, if it is going to help and there is some data, then it's probably worth all this.
But as far as that one absorption therapy, cytosorb, is available and many are using, I don't find that is useful. We had used in many patients, and even they themselves claim that that just reduces the level in the serum, but there is no mortality benefit in that.
There are 2 studies on cytosorb which are published in 2017, RCTs, which have shown a higher mortality in the cytosorb group. So those really convinced me that I should not use that.
Only biological, only serum benefit is there, levels are decreasing, but patient does not get any benefit.
I think Atul wanted me to. We have used another membrane, a polymethyl methacrylate membrane. Last year that was presented by one of my students in the West Zone. 13 cases of COVID with cytokine storm. 8 out of 13 survived. 5 died in any case, though there was cytokine reduction in all. And that number is far too small to do any sort of statistics or show that this is significant. And we have one published report on Oxiris in cytokine storm, which was published in Indian Journal of Nephrology last year. That was a case report where there was a dramatic improvement after using CRRT with a cytokine absorption membrane, Oxiris. Yeah.
This one means you are using CVVHDF or CVVHD along with the you are using, because if you see definitely cytosol has not given a very promising results. Okay, so depending on that also means like that you see this the data na, so what type of renal replacement therapy is used along with the cytosol, and comparatively our experience is now, if you ask me, so many our center, so HA130 its cost is 9,000, definitely less compared to cytosol, and it works. And then definitely you have to use the continuous therapies CVVHDF, then you will get the outcome.
There is a 2021 meta-analysis which has shown they've taken CVVHDF as the standard, and they've shown a higher mortality with CVVH compared with that. The odds ratio is 1.39, and it's only SLED-F which have, and PD surprisingly, which have a lower mortality in all the AKIs. I'm using Oxiris and Hemophil for one reason, that they are both, they do this, the renal replacement therapy as well. So I don't need something else in addition. That makes it easier. I use it in patients who need renal replacement therapy. If there is cytokine removal, that's a bonus. I don't use these only for cytokine removal. Absolutely. That's why we need studies. But that's what studies have shown, there is no benefit. Early versus late, no benefit of early, no benefit of cytokine removal in any study till today.
So at the end, we will conclude the session and come to the end of this.
So,
thank you.
Yeah, that is the end of the session. Before we proceed to the next session on transplant update, I will request the chairpersons to proceed backstage for felicitation, and also the speakers.
My pleasure.
So next session is on transplant update. I would like to invite our chairperson, Dr. Tushar Dige. He is professor and HOD of Department of Nephrology at D.Y. Patil Medical College, Pune. He has received Young Investigator Award and travel grant for ISPD. He is a PhD and DM in nephrology guide and examiner, and he has got various national and international original articles publications in index journals. Also, I would like to invite Dr. Ramesh Rao. He is a senior consultant in nephrology practicing in Mumbai. So I invite both the chairpersons to chair the next session, that's on transplant update. To begin with the first topic, that is outcome of expanded criteria disease donors, I would like to invite Dr. Bharat Shah. Obviously he needs no introduction. Over.
Good evening, chairpersons. I'm going to talk on outcome of expanded criteria deceased donors. When you have an expanded criteria donor, one wonders whether to accept this kidney or not for the recipient, and I hope my presentation will help you in taking that decision. I'll start with a quandary that I faced in 1999. There was a 70-year-old female with history of diabetes and hypertension for 2 years, and she had developed brainstem death following intracerebral bleed. Routine urinalysis was normal. Creatinine was 0.6 milligrams per deciliter. Kidneys were harvested at the hospital where she was admitted. No center, including the center where kidneys were harvested, were willing to accept. And therefore the hospital called us whether we would be willing to accept the kidneys, should they be accepted. So with this case in the background, what I plan to do in next few minutes is to tell you what do we mean by expanded criteria donors, what is the outcome of kidney transplant with expanded criteria donors, and how is our experience of kidney transplants with expanded criteria donors. Expanded criteria donor is defined as a deceased donor who is more than 60 years old, or a deceased donor who is 50 to 59 years of age with two of the following three characteristics: terminal serum creatinine level more than 1.5 milligram per deciliter, hypertension, and death from a cerebrovascular accident. But this is a very simplistic definition. When you say more than 60 years, it could be 70, 80, 90, 100. So it's a very simplistic definition. And when you talk of terminal serum creatinine more than 1.5, it could be anything from more than 1.5. So this is too simplistic a definition. Not all more than 60 years are the same, and not all with terminal creatinine 1.5 are the same. In United States, Kidney Donor Profile Index was introduced in 2014 to guide the decision making of clinicians with respect to accepting or declining a donated kidney. It is a percentile measure that is based on United Network of Organ Sharings data from the Scientific Registry of Transplant Recipients, and it examines the relative risk of allograft failure with a particular donor. This takes into consideration 10 parameters: age, height, weight, race or ethnicity, which actually are parameters to tell you about the glomerular filtration rate of the donor. History of hypertension, diabetes, cause of death, serum creatinine, hepatitis C virus infection, and whether it is donation after circulatory death. Based on these 10 parameters that you feed, a score will be given. How do you interpret the score that you derive from this KDPI calculator? It is an indicator of relative risk of graft failure. For example, if your kidneys are from a donor with a KDPI of 90%, it means a risk of graft failure which is greater than 90% of the recovered kidneys. That means if your risk of graft failure is 10%, if your risk is 90% more, it will become 19%. 90% more than the average risk of graft failure. It doesn't mean that the risk of graft failure is 90%. So KDPI, high KDPI score kidneys does not mean that you need to not accept. The reference population used for this mapping is all deceased donors with kidneys recovered for the purpose of transplantation in the prior calendar year. So yes, the higher the KDPI score, the higher the mortality. This graph shows that when you have someone with a low KDPI score, the survival is very good, and when you have someone with a very high KDPI score, the survival is less. But this is a simplistic way of looking at it. There are multiple factors that one needs to look into. Many times one talks about doing histopathology before deciding to accept or not. In our experience, histology has several limitations: sampling errors, inter-observer variability, prolongation of cold ischemia time, difficulty in getting the procedure done. I don't find it very useful in deciding whether to accept or not. Clinical behavior, KDPI score, your recipient are the factors that one should look into. What is the outcome of kidney transplants from expanded criteria donors? So there is definitely a survival benefit of expanded criteria donor transplants as compared to dialysis. So recipients with KDPI scores 71 to 80, 81 to 90, 91 to 100, they all had a survival benefit, but there is a risk of higher mortality in the early period after transplantation. That risk will equal at certain months after transplant equal to the people who are on waiting lists on dialysis, and this period to equal the risk of death on dialysis becomes more when your KDPI score is high. A high KDPI score does not automatically constitute a reason to reject a deceased donor kidney. So this is how you should look at. If you do deceased donor, expanded criteria donor transplant, then your risk is high in the early period. It will equal at about 7 months when your score is about 70 to 80. But it will equal at a later period after transplant when your KDPI score is very high. So there is a higher risk in the early period. Europeans looked at validation of KDPI score, and yes, they found similar thing, that when your KDPI score is low, the eGFR is higher at 1 year as compared to when the KDPI score is more than 85. Date-censored allograft survival is low when your KDPI score is more than 85. But they found that this almost matches, the graph almost matches what you would see when you take donor age into consideration. So according to this study, the most important parameter in deriving the KDPI score is the age. So these are two scores that you can see, and you can see the two graphs. When you use KDPI and when you use age, the graphs are similar. And they suggested that donor age is the most important factor which determines your KDPI score. Transplant outcomes using kidneys from high KDPR with acute kidney injury donors. So we talked about age, but I think equally important is whether this donor has an acute kidney injury, and if there is an acute kidney injury, how severe it is. So with use of Akin scores stage 2 and 3, there were more primary non-failure occurrences, and 1 year date-censored graft survival was reduced. Given these findings, additional precautions should be undertaken when assessing and utilizing kidneys from severe acute kidney injury in patients with high KDPI scores. So degree of acute kidney injury is also important, and your creatinine of more than 1.35 as you take into consideration when you define expanded criteria donor by itself is not enough. And not only donor age, the recipient age also matters. When you have an expanded criteria donor kidney, you would be reluctant to give it to someone who has a long lifespan to live. So you would be reluctant to give to someone who is young. And that means that you might use it for someone who is old. But that is not a good idea. So this study looked into patients who received transplants from expanded criteria donors. They divided patients into two groups. Group 1 consisted of patients more than 60 years of age who received an expanded criteria donor kidney, and 2 included patients, group 2, 40 to 59 years of age who also received an expanded criteria donor kidney. Group 1 recipients had significantly worse outcome than younger patients who received an expanded criteria donor kidney. Does kidney transplant with a standard or expanded criteria donor improve patient survival? This was another study from a Belgian cohort. They also found the results of this study suggest that in the older patients, the survival benefit with expanded criteria donor transplantation versus dialysis may be very small. So recipient age is also an important factor in determining the outcome of ECD transplants. I'll briefly tell you about our experience with kidney transplants using expanded criteria donors. And this has been essentially based on our clinical evaluation of the donor and the recipient's risk characteristics. From April 2017 to March 31, 2021, we had 40 adult patients receiving kidneys from deceased donors. 17 received grafts from expanded criteria donors. One patient died intraoperatively of a cardiac cause, and this patient has been excluded. Before accepting ECD kidney, we ensured that estimated creatinine clearance, this was our way of assessing, was at least more than 60 ml per minute based on baseline creatinine. And if creatinine clearance was 50 to 60 ml per minute, we would consider doing a dual kidney transplant. And we always looked at prior reports to determine the element of acute kidney injury. Of 16 patients included in the analysis, there were 11 males and 5 females. The mean age of these patients was 48, but the range is 30 to 70 years. So a large number of patients were not that old. This is the observation, this is the data of all those 16 patients who underwent a transplant. 2 of them underwent a dual transplant, and all of them have done well. Some patients were discharged at a higher creatinine, but over a period of time, they continued to have a drop of creatinine, and the survival is 100% of all these patients, with all of them having a decent kidney function. Coming back to the case, should they have been accepted? This was in 1999. This was before the era of defining expanded criteria donors, before the era of kidney donor profile calculation. We looked at the fact that she was otherwise in a good shape. Her urine was completely normal. Her creatinine was 0.6. We calculated a creatinine clearance which was decent. We thought, why should we waste these kidneys? So we accepted the kidneys. The kidneys were already harvested in another hospital, so you can imagine that the ischemia time must have been long, because since the hospital where they were harvested were not accepting it, we were called, and then we started working on calling our recipients whether they would want to accept the kidney, doing a cross-match test, and then taking up for surgery. The kidneys were transplanted in a 43-year-old male. The graft functioned for 19 years until he died of a cardiac cause. This is the nuclear scan showing 2 kidneys in 2 iliac fossas, and he lived all through with a creatinine of 1 to 1.3 milligrams per deciliter. When we did this, there were guidelines from the Director of Health Services from Maharashtra about cadaver transplantation, and the guidelines were that if the age of the donor is less than 2 years or more than 65 years, he or she is not fit to donate, which meant going against the guidelines. But it didn't really make sense to not accept kidneys which look good, and therefore we went against the guidelines. And we had well-functioning graft, but because we went against the guidelines, we were served with a notice for having gone against the guidelines and done a transplant, which actually turned out to be successful. So what factors should be considered while accepting an expanded criteria donor? Calculate KDPI. You should have some criteria. So do calculate KDPI. Check the baseline creatinine. Very often you don't get information about baseline creatinine. So it's good to call the ICU and find out from the physician or the primary doctor whether there was any prior report done recently. Check the severity of acute kidney injury. If you have a very severe acute kidney injury, so we had a case where a patient had a road traffic accident, prolonged hypotension, he was anuric. We also did a histopathology. Histopathology reported was ATN, that was a young donor. We went ahead, but that was a primary non-function. So look at the severity of acute kidney injury. I think it's a very important parameter that one should look into. Decide an appropriate recipient based on age and comorbidities. Don't take someone who is very old and who has multiple comorbidities. If you have a prolonged period, a delayed graft function with use of all immunosuppression, they may end up with other complications. And check the position of recipient on the waiting list. So if you have someone who is high up in the list, you may wait for a better kidney. But someone who is way behind, and if he is not doing well on dialysis, you can accept that patient as a potential recipient. So we had a patient, donor was HCV positive, the recipient was HIV negative, you can take this. He was way behind. We offered him the kidney, he did it, he's doing well. So even the position on the waiting list is one of the parameters that one should look into while deciding whether to accept this expanded criteria donor kidney or not. So in summary, with widening gap between the need and availability of kidneys and the fact that many patients die waiting for transplant, all potential kidney donor kidneys should be used. I talk of potential, not all. When selecting expanded criteria donor, it is important to look at KDPI, baseline creatinine and severity of AKI. And when baseline creatinine clearance is less than 60 ml per minute, better to do dual kidney transplant. It is important to select an appropriate recipient, keeping in mind age, comorbidities and position on the waiting list. It is also important to minimize the ischemia time. And today you can use hypothermic oxygen perfusion if the ischemia time is likely to be long. And accepting ECD kidneys can narrow the gap between the need and the supply of kidneys. I would like to thank all my parents, my mentor, my teachers, my colleagues, my students and all my patients who have helped me in making some decisions in crucial times. I would like to end with this message that we need to keep educating our people. Don't take your organs to heaven, for God knows they are needed here. And we should make them sign an organ donor card in our office itself. When the patient tells me how long will it take, I say, if you signed an organ donor card, if you have not signed, how do you expect others to sign when you need it? And if we do this, hopefully there will be no gap between the need and the supply. Thank you.
Hello. Yeah. Open for questions. Anyone? Any comments?
Thank you, Dr. Bharasha. It's a very, very important topic because at ZTCC level, we have been trying hard for last few years to improve the utilization of kidneys. And we have seen year on year in Pune ZTCC that about 20% of the donors are not accepted. The kidneys are not accepted. So one of the reasons when we looked at was actually the expanded criteria donors. A lot of nephrologists have reluctance to accept that. So we have had multiple meetings with nephrologists, and Tushar is aware, and so we are trying to emphasize that you have to, if you are careful in selecting the appropriate expanded criteria donor, the outcomes are good. The other thing that I would like to mention is that our center, we have about 46 cadaver transplants done in the last 6 years or so, and this paper we have sent, it will be presented in ISOT next month, and we have done similar analysis regarding donor age. I would not like to disclose the results right now, but the same thing will be presenting next month.
Thank you, sir, for an excellent talk. And as Atul mentioned, we have had this kind of experiences where the donor age was high and no one was ready to accept, and we have done both the transplants at the same institute, both kidneys given to same institute, and they have worked well. So yes, we agree that extended criteria donors should be accepted, and we should be, only thing is we should be careful enough to decide which recipient and which donor, and they will work. Thank you, sir. If there are no other questions, may I hand it over to the ceremonies. Right.
Thank you, sir. Next, there is a bit of change. Dr. Rajsekhar Chakravarti, due to some personal reason, is not available. So again, we have to listen to a recorded talk regarding renal transplant in sensitized host, hurdles and ways to improve outcome.
Good evening, friends, seniors and teachers. It is my pleasure to discuss such an important topic in front of such an august audience. I am grateful to Dr. Soni and Dr. Barnela and other organizers in allowing me to learn more about this particular cohort of patients. Let us start the discussion with what we have faced recently. This is a 31-year-old lady, married, has 2 children, end-stage kidney disease secondary to presumed chronic glomerulonephritis, was started on dialysis elsewhere, came to us for a transplant. She was being worked up with prospective donor being mother. There is history that the mother got some transfusions, and I will tell you the details. The first cross match that we did was negative, and we proceeded to look at other workup for this patient. As you can see, typically mother and daughter, mother was 65-year-old. There is a half 3/6 match, HLA A locus, B locus and DRB 1 locus. With this, the first cross match which was negative, we posted them for a transplant in November 2021. Our protocol is to do one repeat cross match 1 day before the transplant, and to our surprise we found that it was positive for T cell 60%. At that point in time, we gave them couple of options, but they wanted to wait, and after close to 5 months, the repeat cross match was positive again, and recently in July 2022, which is close to 8 months after the first cross match positive, it is still 25%. So how do we proceed in a patient who has a positive cross match? To understand this a little, we have to know a little more about the methods that we are employing in finding out whether the patient is high risk or not. As we know, human leukocyte antigens primarily determine alloimmunity. Cross-match test determines the risk of the recipient with a potential donor. So you can do a physical cross-match, you can do a CDC cross-match, you can do a flow cytometry, then there is talks of what is known as a virtual cross-match. So many things are available to us today to risk stratify the patient. And we know that once you risk stratify, those who have a positive cross-match, even historically positive cross-match, are more prone for rejection, delayed graft function, and even the long-term outcomes are not great. What are the options for a person like this? You can wait, repeat. When it is negative, go ahead. Even if we do that, because of the historical cross-match positivity, the amount of immunosuppression has to be more, as they are more at risk for a rejection. You can change the donor, and that is simpler said than done, because even to get this particular donor, the family would have gone through a lot of energy, including sometimes expenditures. Paired donation is something that is talked about in the literature, or you can desensitize. So more and more units, including in India, are comfortable talking about desensitization regimens. So the presence of alloantibodies against human leukocyte antigens of potential donors was previously considered a major barrier to kidney transplant. I can clearly say, with whatever my understanding today in the literature, both Indian data and elsewhere, that it was previously considered a barrier. It is no longer a barrier. And how do we go about this? There are so many technologies now which look at the strength and characteristics of the donor-specific antibodies, and you can immunologically risk stratify these highly sensitized risks. So once you know or you have identified the donor-specific antibodies, by these methods of complement-dependent cytotoxicity cross-match, flow cytometric cross-match, or solid phase binding assays, you can reach a appropriate target antibody range before which you cannot transplant, and then you can do once that particular range is reached. So CDC cross-match, all of us are using it on a routine basis. They fix or they look at or they detect whether complement fixing immunoglobulin M and IgG antibodies targeting donor lymphocytes are present in the recipient serum or not. The test is positive only when there are sufficient antibodies to bind to the donor antigen and activate the complement cascade. Therefore, the sensitivity of CDC cross-match is relatively inferior, and you can get a negative report and have a positive report in some other method. So a CDC cross-match has limitations. It can detect only complement fixing antibodies, requires viable donor lymphocytes for testing. The sensitivity depends on the batch of the rabbit complement. CDC cross-match is a reaction between patient serum and donor lymphocytes. Hence, the specific profile of the antibody will be identified. So as I just mentioned, you can get a false positive CDC cross-match and you can get a false negative CDC cross-match also. When you use rituximab in a recipient, this can be detected in the patient's serum for more than 3 months. Hence, B-cell CDC cross-match can produce false positives during this period too. So, flow cytometric cross-match, which is now available for most of us, is a more sensitive test than the CDC cross-match, and the incidence of delayed graft function, acute rejection, graft failure was higher in flow cytometry positive CDC negative cohort, suggesting that it is a better form of doing a cross-match. The cell-based method, which donor lymphocytes react with recipient serum, the flow cytometry signal is read by adding fluorochrome conjugated antibodies rather than by employing a cytotoxic response. So in some laboratories, the donor lymphocytes are pre-treated with pronase to remove the FC receptors and CD20 from the B-cell surface. So by removing this FC receptor on the B-cell surface, the background noise that may occur due to binding of non-HLA antibodies can be removed, and therefore even the effect of rituximab on the B-cell flow cytometric cross-match is not there. So this is a table which talks of interpretation of CDC and FCM results. So when you get all of them positive, the job is easier. But you can get in a particular patient CDC negative, flow cytometry positive, or CDC positive and flow cytometry negative, and this is available in published literature. It is very easy to look at it and interpret depending on which is positive and negative. So we move on to the Luminex technology or solid phase binding assays, a step ahead of what we just discussed. We also can look at the panel reactive antibody which are available now everywhere. One of the problems that we should keep in mind is if you are using a PRA, you should make sure or ensure that the antibodies are from local pooled antigen of the population. If it is using some other population, not local, it does not help us. So the single antigen bead panel is most sensitive test method because each bead is coated with only one HLA allelic antigen, presenting the advantage of being able to detect specific DSA. Antigen coated microbeads are incubated with recipient serum followed by addition of fluorescent labeled anti-human IgG. If anti-HLA antibodies are present in recipient serum, they bind to the microbeads, and as the fluorescent labeled anti-human IgG binds sequentially to HLA antibodies, it can be detected using a laser instrument. So Luminex SAB provides semi-quantitative information regarding anti-HLA antibody titer through median fluorescent intensity, which we read as the MFI volume. Luminex SAB may present false positive or false negative results owing to IgM or various inhibitory factors present in the recipient serum. So, though this is the best, it also has some problem. Therefore, people have moved on to using all these together rather than a single assay. So, you can avoid interpretation errors when you use these things in combination. So sometimes you may get a false negative result when there is a strong CDC cross-match even on a SAB. For this reason, the recipient serum is diluted and the SAB assay can detect with an increased MFI value. So interpretation of all these will need some amount of experience and expertise. So one of the team members should have some familiarity with these testings and their. So let us move on to what we know from our own country. This is a case report published in September 2022 in Indian Journal of Nephrology from Dr. Pandey's group. The heading is From Hesitancy to Certainty, in patients, transplanting patients with high sensitivity. So you can definitely do transplant in these individuals who are highly sensitized, is the message that this article gets across. They discuss a lady who had a MFI of more than 23,400 and after desensitization regimen having a successful out. So they talk about all the three methods which we just discussed. If they are negative, you can proceed with the transplant. Any of them being positive, look at a solid assay, and then if there are non-DSAs, you can proceed with transplant. If there are donor-specific antibodies positive, please look at desensitization, and the protocol that they have used is rituximab, standard triple immunosuppression, IVIG, therapeutic plasma exchange and induction with ATG. So this is what most of the units across the world have used with small variations. We will spend a little amount of time discussing a couple of these protocols. So most of these will start -30 from the transplant, and you look at these tests in combination. Once you know that the recipient is sensitive, you can go ahead and use rituximab around 20 days before the transplant. Start immunosuppressions all three by -20, and then you can continue doing plasmapheresis at a fixed interval, and the day before the transplant you should have a negative cross match by more than one method. Induction with steroid and ATG, and then postoperatively too, these patients need plasma exchange, sometimes more than 2 to 3 sessions. So this is the data from Delhi, Noida. Desensitization therapy in kidney transplant cases with positive baseline CDC cross-match and high donor-specific antibodies. They looked at retrospectively in their own records and found altogether they had around 5 patients in whom the MFI values were very high and DSAs were very high. They went ahead and did these regimens of desensitization and achieved successful outcomes in the form of good graft outcomes, no rejections, and also other problems like postoperative infections being very, very minimal. The particular protocol that we discussed, including rituximab, plasma exchange and ATG induction, was used by this group. So they concluded that high-risk transplants can be done using these MFI Luminex single antigen assays even with 23,440 being the MFI value. So the mean follow-up of this cohort was around 308 days, and they concluded that good outcomes are possible post-kidney transplant without any post-operative infections, and they mentioned it as short-term outcomes because their longest mean follow-up was 308 days. So this is a summary of all the protocols which were available at this point in time. So you look at the center, John Hopkins, Mayo Clinic, University Hospital, Maryland, University of Illinois, and the last one is University of Warwickshire. So most of them talked of antibody removal using plasmapheresis and IVIG. There has been some debate about low dose IVIG versus high dose IVIG. If you are using high dose IVIG, they have not used plasmapheresis, and some units have also used double filtration plasmapheresis with IVIG. The antibody synthesis blockage, many units are comfortable using rituximab. Some of them have done away with rituximab using only IVIG and plasmapheresis in view of historically significant infections being reported in these cohorts. Almost all of them have used induction of ATG, and then of course standard triple immunosuppression that we are using. So the concept of desensitization, to be summarized, you use anti-CD20 monoclonal antibody so that preformed B cells are not there. Sometimes if there is clonal expansion and there are plasma cells, you use proteasome inhibitor. This you know because after a couple of sessions of plasmapheresis, there is still a positivity in the cross match and you are not able to get a decrease in the value. And of course, at the time of your transplant, you want to make sure whatever other antibodies are there are destroyed. So you do plasmapheresis sessions and also you use IVIG to achieve this. So the other protocol which is popular is desensitization protocol of Seoul St. Mary's Hospital. The standard protocol, as we discussed, uses more than one method to pick up the antibodies, and then their aim is to achieve MFI less than 3000. For this they do the same rituximab 375 milligrams per meter square, plasmapheresis day -13, -11, -9, repeat a cross match, and then look at continuing them till the date of transplantation. In case they find that after the 3 or 4 sessions there is a positive cross match and they have not achieved the MFI titer of less than 3000, they will add bortezomib to the entire protocol. And the specific reason to add bortezomib, a proteasome inhibitor, is to ensure conversion from a positive cross match to negative cross match because of already formed plasma cells in the circulation. So let me quickly tell you our own experience. We have no experience with doing a transplant in highly sensitized individual, but we have done in the last 2 years or so around 10 ABO incompatible transplants, which is close to the transplant in highly sensitized individual. 14 days prior to the transplant surgery, we rule out any active infection by sending a CRP, CBP to look at the counts and also cultures, CUE, all of them being normal. We go ahead and give 200 milligrams IV standard dose of rituximab. 10 days prior to transplant surgery, we start triple immunosuppression, tacrolimus 1 mg BD, mycophenolate 360 BD, and Vizalone 10 mg once a day. 7 to 10 days prior, we start the plasmapheresis, and we don't reuse the plasma filter. We check anti-A or anti-B antibodies depending on the ABO incompatible status, and we look at both IgG and IgM. I cannot stress the importance of the blood bank and the personnel there, because you send it in the morning and we want the report by afternoon. And we also look at the complete blood picture, PTINR, APTT on the day of plasmapheresis, including calcium. Once the session is done, we do the antibody testing against the blood group only in the next plasmapheresis and see how much reduction is there. Once we have achieved 1:8 as the titer, and I will show you what was the titer in each one of our patients. One day before to transplant surgery, we do again a plasmapheresis, completed by 12 p.m. Send fresh CBP, CRP, LFT, PTINR, APTT, serum electrolytes, calcium, phosphorus, and serum fibrinogen. In one of our patients, in fact, the second patient we did ABO, we got into some bleeding risk with the low levels, and from then on we check this in every patient and make sure that we have enough FFP and blood available. The CDC cross-match, Luminex titer, and anti-A and anti-B titer levels are done one day before surgery, and once we are satisfied, we go ahead with the transplant, and we were giving ATG as the induction agent, along with, of course, the patient is already on the triple immunosuppression. We were keeping 6 units of packed red cells, 10 units of FFP, and 10 units of cryoprecipitate ready. On the day of surgery, go ahead with the transplantation if the antibody level is 1:8 or less and the fibrinogen is more than 150 milligrams. So this is the overview of our ABO incompatible renal transplant recipients. As I have mentioned, we have done 10 so far. 11th one we could not proceed, as even after 8 plasma sessions, the cross match or the antibody titers were higher, and the patient refused to go ahead with the protocol. We had offered a column and then continue another 2 plasmapheresis. There are units in this country which have done more than 150 ABO incompatible transplants with very, very successful outcome. So you look at all these 10 people had no rejection, and sometimes I feel it's very easy to manage them, though it is quite labor intensive. And one of the team members in our team, my colleague Dr. Mahesh, was involved in most of these transplants, has to take charge of it and go into the details of each time the patient comes for a plasmapheresis. So let me conclude saying kidney transplant is possible today even in high-risk recipients. Various protocols quite similar across the world are available. Successful outcomes have been published from India also. AVO incompatible transplant, again a high-risk recipient here too, or a reality. Indian data is available. I have shared with you 10 such patients in our own experience with good outcomes, no rejections and no increase in the infections. Our experience has been if our regular transplant has costed us around 6.5 lakhs, by doing these plasmapheresis we add another 3 lakhs extra to the whole protocol. Keeping this in mind, whenever we get a recipient who is high risk, we should consider offering them a transplant without rejecting them as we have been doing so far. Thank you very much. Good evening, friends, seniors and teachers. It is my pleasure to discuss.
Can't have question answers, so if there is any comment, a short comment, that is welcome. Otherwise, we'll move to the next session, please.
We'll move. Yeah. So, for the next talk on acceptable mismatch transplants, practicality and feasibility in India, I call upon Dr. Shruti Tapiawala. She is a senior nephrologist and renal transplant physician at Institute of Renal Sciences Global Hospitals, Mumbai, and Sir H.N. Reliance Foundation Hospital and Research Center, Mumbai. She is also have Anil Clinic, Andheri, Mumbai. She has established a special laboratory for advanced transplant diagnostics in Mumbai and established sorter registry for sensitized patients, first national registry developed in India. So she has many publications in national and international journals, of course. So I would like to call upon Dr. Shruti Tapiawala for the next talk.
Good evening, everyone. So after that talk where few protocols of desensitization were shown, I would like to share my experience and a little bit of how we have been handling sensitized patients with little experience from Canada, from US, and adopting the strategies to apply to our patients in the Indian scenarios. So starting with a case, middle-year-old lady and suffering from end-stage kidney disease, was on maintenance dialysis for 3 years, presented to the outpatient department to me in Jan 2017 for inability to get renal transplantation due to positive cross-match with her family donor, was her husband. Her husband was blood group matched with her, O positive, had received donor-directed transfusion and 2 pregnancies with her husband. She further added that this was the only willing donor and medically fit donor available in her family. She has been cadaver listed, but to no avail, she has not got any transplant. So I looked at the analysis which was done and all the extra tests which were required I did. ABDR typing was done, but I added a DP and DQ to it because I wanted the complete HLA typing. The HLA mismatch was 7/10. Class 1 PRA was positive. Class 2 PRA was negative. For students, panel reactive antibody is done just to screen which class of antibodies is positive. Post that, I did a single antigen bead assay which will tell me the identification of the antibodies, which one is positive, and I got a B3501 and a B3508 which was positive. And if you see on the donor, the B35 which is in red, the pointer is not working. I have marked it in red. B35 is on the donor and that is what was giving the positive cross match, and that was the DSA which was not allowing her to go for transplantation. Now a little bit on what HLA antibodies do. We all know that they cause allograft rejection and transplant failure. There are umpteen number of papers now in the last decade showing us that whether they are class 1 or class 2 HLA antibodies, they will cause an allograft dysfunction. The allograft outcomes are inferior if you have HLA antibodies, and they will be further inferior if they are against the donor. Your outcomes are the best when you do not have any HLA antibodies. Outcomes are good if you do not have an antibody mediated rejection despite having HLA antibodies. But overall, most of the papers have emphasized that no matter what, if you have preformed donor-specific antibodies or HLA antibodies, you do have immune events down the line. Patients with 85% or more of panel reactive antibodies are generally called as highly sensitized. These are the patients who have blood transfusions, pregnancies, spontaneous HLA antibodies, previous solid organ transplants. The consequence is that they are highly sensitized and they have cross matches positive with multiple donors in the population. They keep waiting on the dialysis and they die waiting for a transplant. These patients will have an inferior outcome whatsoever. As per the analysis of our data, I have some 390 PRAs done at my lab now, and I can say that out of the 390 PRAs which I have screened, 30% of solid organ transplant recipients are positive for a antibody. So PRA more than 0 means you have HLA antibodies. Out of the 390, 30% were positive. Out of these, 5 to 6% were highly sensitized. So 6% of the 390 patients had more than 80% PRA. These patients are waiting to find a suitable match which will allow them to undergo transplantation and live a normal life. What are the approaches? We heard in the previous talk that people attempt desensitization. And what is the attempt for desensitization? That you want to remove the HLA antibodies which are going to be the culprit to cause antibody mediated rejection, like we attempt in an ABO incompatible transplant, that we want to remove the anti-blood group antibodies. But the HLA antibodies and the blood group antibodies cannot be equated in the same way, because the HLA antibodies have a memory response and you cannot say that you have desensitized the patient and you will not expect an event. Second approach, you accept that there are HLA antibodies and you bypass the antibodies. You do not attack the antibodies. You will try to give a donor to the patient against whom the recipient does not have any HLA antibodies, which is a simpler way out rather than challenging the antibodies. So desensitization protocols are not for everyone, especially in India. Suppose the titers of the HLA antibodies are very high. Now one paper says 24,300 MFI, but that is just one paper. There are multitudes of papers, like we recently had a deceased donor transplant at our unit, and the patient had a B35 antibody to the tune of 18,000. There is no graft function as of now. The cross matches were negative. The transplant was done. Retrospectively, we found out that there was a DSA. The graft is still not functioning. So it is not easy to say that, oh, the Indian literature says 24,000 MFI, go ahead with the transplant if the cross match is negative. No. These antibodies have to be differentiated with IgG 1 to 4 classes, complement binding. Then you can say whether this is pathogenic or not. We do not have the means to subclassify the antibody as of now. There are refractory specificities like DR52, 53 cannot be removed. They are very, very difficult to desensitize. Our patients are fragile. Young patients is still okay, but middle-aged and elderly patients you cannot desensitize. We are mostly restricted to living donors, and if you want to desensitize people who are higher up on the cadaver list, you are subjecting them to months and months of plasma exchange and immunosuppression. And money, you cannot count money in desensitization, because you have to keep monitoring HLA antibodies, you have to keep giving immunosuppression, adding to the burden. These are some of the studies which I have highlighted. It is a meta-analysis, and this is joining all the studies in the international literature, saying that if you have a sensitized recipient and you are doing desensitization protocols, the outcome is definitely inferior to people who have not undergone desensitization and who do not have antibodies against the donor. So no matter what, you desensitize, you remove the antibodies, but the moment you have a DSA in the system, you will have immune events later and you will have an inferior outcome. So what has been the practice in international community? So yes, desensitization did come into practice in Johns Hopkins, Mayo Clinic, Canadian societies, Australian societies, but remember these are universal healthcare systems. There also they realized that the economic burden of desensitization and post-transplant plasma exchange monitoring was adding to the economic burden of the society. And hence they decided that once you have a sensitized patient, you try to put them on a living donor paired exchange list so that you do not need to respite to desensitization and you can go ahead with a normal transplant even for sensitized people. So what are the strategic approaches? So based on the recognition that matching is not for everyone, 85% of deceased donor transplants are mismatched. Focus on appropriate mismatching rather than looking for an HLA match. Requires a detailed evaluation of HLA antibodies, so you should know what are the specificities of the HLA antibodies, you should know what are the donor HLA antigens. You shift the emphasis to antibody evaluation and away from cross-matching. So what is the difference of desensitization versus LDPV? Very important to understand. You do not accept the patient. So in desensitization, you are saying that the patient is sensitized and I want to desensitize. In the other strategy, you are accepting that the patient is sensitized. You are trying to avoid the HLA antibodies by giving them a donor against whom they do not have any HLA antibodies. It is easier said than done. Eurotransplant has a registry where they are trying to match patients while allocating the patients, which is difficult for our country, but nevertheless this concept is being followed. How does a virtual cross match or an acceptable mismatch work? Very important. If you see this patient A1, A30, B7, B8, DR11, 15, DQ6, 7, antibody list says DR7, DR9, DR53, DQ2. Potential donor A25, A33, B42, B18, DR8, 16, DQ4, DQ5. What do you have to match? You have to match the DR and the DQ because the patient has class 2 antibodies. The donor does not have those antigens. This is an acceptable mismatch. This will work. Because the patient does not have antibodies against the donor, you do not need to desensitize. You can go ahead with a low risk transplant protocol. This has been the approach for sensitized patients all over the world now because they have realized the burden of immunosuppression, infections and economic burden. What is the approximate wait period for these patients? In the registries abroad, these lists move fast because most of the patients are centralized and they are put on the same registry. Now the first case, what did we do? I had an ABO incompatible pair which came across, and luckily the donor of that pair did not have any antigens against the B35, so I could easily swap this because that patient required an ABO compatible transplant because of want of money, and the first patient required an acceptable mismatched transplant. So I made it an ABO incompatible transplant for my primary patient. It became an ABO compatible transplant for the second patient who came for an ABO compatible transplant. In the bargain, my patient who was 3 years on dialysis and could not get transplanted got transplanted. So that was in May 2018 where they could easily get a transplant, and I used basiliximab, nothing else than that, because I had used Ritux for the ABO desensitization where the titer was only 1 in 64. So that prompted me to start the sensitized organ registry, which is known as SORTER. This is the second case where Mrs. SG from South India, an employee of Reliance, they came across where again the husband has strong antibodies, had antigens against the patient's antibodies, and this patient could not get transplanted, and we had another patient waiting for 3 years on the list. And I could easily swap these patients because again both the patients had donor specific antibodies against their spouses and they could not be transplanted, and because I had the registry I could match these people. So this was the so Mrs. SG and her husband SNG, Mr. RJ and his wife UJ, they swapped. This is a third pair, AM versus Mrs. MH. So these patients again had DSAs. I have outlined, for the want of time I am not going into the details, but if you could see the HLA typing, of the donor and there is a match with the antibody profile, and you can say that the virtual match is positive, virtual cross match is positive, hence I have put them in the sensitized registry to get a donor against whom she does not have antibodies. So this is the list of pairs which we have done via the sorter registry, and if you see they are now more than 36 months of follow-up and everyone's creatinine is doing well. I have not used plasma exchange for any of these patients other than 2-3 patients who had an incompatible, ABO incompatible transplant. Why did I do an ABO incompatible transplant? Because I wanted an HLA acceptable compatible transplant over and above the ABO incompatible transplant, because ABO incompatible transplant will have a better survival advantage than an HLA incompatible transplant, which would need a lot of monetary help later on. HLA monitoring, plasma exchange, risk of rejections. So what are the requirements to be on the list? Simple. We need just the blood groups, we need the HLA typing of the patients, the antibody lists. That's all. More the donors in the family is always better, because then I have more choices. Present list has 35 patients and people from interior Maharashtra, Delhi. I have had patients coming from Nagpur, Nashik also. And what happens is that these patients have very common HLA antibodies, common antibodies against common HLA antigens. That's why those antigens are very commonly formed in our population. So that makes it difficult and their waiting time is very high. So what are the hurdles I am facing to give these patients acceptable matches? The average waiting time is anywhere between a month to 3 years, because there are some patients who have very few antibodies and they do not have antibodies against common antigens, so they quickly get a match. But there are a few patients who are very highly sensitized, 85-90%, and what happens is that they have antibodies virtually against everyone. So the more the patients and more the donors we have on the list, the faster the matches we will get is one. The next hurdle is that in our Indian system, we do not accept unrelated pairs. Say if I want to do a direct transplant, a mother-in-law to a daughter-in-law will do, an uncle to a nephew will do. But if I enter this pair into a swap, it is not allowed. So there some patients get stuck. Other thing is there is lack of awareness of this system. And people keep doing cross matches for sensitized patient, and the moment they see a cross match negative, they might think of transplanting, but it might lead to rejections later. And they end up giving more immunosuppression and more infections. Paperwork for swap transplants takes a longer time. So we always, even in our team, when we discuss that we want to put this patient for swap, we always think that arey bahut time lagega, paperwork will take a lot of time, let us just try and do something. So these 3-4 hurdles are trying to get the practicality of this thing, this system down, which works beautifully abroad. What is the way forward? We need to list transplant patients who are difficult to transplant. We need to try and work with the government, which we have been trying to work, that we should try to involve unrelated pairs also in swap, which would otherwise get permission as direct transplants. We don't want to do anything out of the law. To summarize, renal transplantation remains the best modality even for sensitized patients. Sensitization to HLA antibodies decreases the probability of a patient to undergo transplantation. Desensitization protocols are costly. They add to the burden of immunosuppression. The outcomes with the presence of DSAs is inferior. Giving these patients a low immunological risk organ transplant improves the longevity of renal allograft and hence the morbidity and mortality of these patients. We can transplant these patients without tears, but we have to make it more practical for our patients, but it is feasible. Thank you.
Thank you, Dr. Shruti. An excellent presentation and a model which can be replicated all across. If there are any questions, I invite any questions for.
Shruti, very nice talk and a good program to get the difficult patients transplanted. I have a little questions on the patients who are DSA positive but flow and CDC negative. How long do you think you should wait so that the risk on being on dialysis versus desensitization would be acceptable?
That is why I said that few patients the waiting time becomes so high. And why is that happening? Because I have limited choice of donors. Suppose all these sensitized patients come on a list. I have so much variety of donors against whom I can match. We can get a lot of matches if that can happen. So I would say that encourage them to be listed, I would say, because this list doesn't cost any money. It's just like I have made it into a system, and it works manually for me because I keep cross-checking with each and every donor, and the moment there's a pair, it can go ahead. Now these pairs which happened because there were recipients lying there for a long time and someone came along. So that balance of time I will not know, but desensitization, like few people have tried desensitization, but you don't know at what MFI you want to go ahead. Like we have tested a few sera samples where desensitization had occurred. The MFI were 25,000-30,000 before they started desensitization, and just before the transplant 2 days prior sample sent, the titer was still 15,000. Now what makes you decide that this will go ahead? Abroad, C3 binding antibodies, IgG4, these are all differentiated. Now I tried to get these reagents for my lab, but they are research purpose only for the practical purposes of using in India. So I cannot provide this service to our country as yet because they are only saying research purpose. If I can say non-complement binding, IgG1, IgG2, you can easily go ahead with desensitization that these are low risk. But that waiting time versus the dialysis has to be weighed.
Because we're doing a lot of second transplants now, and a lot of patients
Correct.
will have
Many people are coming for
DQ
that.
antibodies, and they have CDC and flow negative. A DQ has a long-term implication.
Like I said,
not
we
a
just had a
short-term
patient in our team where the CDC, it was a cadaver transplant, the CDC and flow were negative, and we went ahead with the transplant, but that antibody bit us. The kidney did not function. We are still with IVIG, plasma exchange. It has been a month almost. So, you know, CDC and flow negative does not guarantee that ABMR will not occur on table. It was not an hyperacute, but it is a primary non-function as of now.
Because I just thought at some point the
It has to be, but we have to try and work hard to make this work.
Who had a transplant DSA positive, flow CDC negative, had a better outcome than being on dialysis.
I know.
So at what point does this trade-off?
So maybe we can give it a period of some time where the dialysis can be done if it's a younger patient and 1 or 2 years on dialysis, and then we can tell the family that look, you are very highly sensitized, if you want we will take a chance. But which antibody is going to be pathogenic and which is not, presently I cannot differentiate and give. If there is a 15,000 MFI or there is a 2,000 MFI, the 2,000 MFI may be bad and 15,000 may not do anything because that antibody may not be complement binding. You and me cannot find out. That's the problem. Isliye, the more patients on this list, I feel that more people will be benefited.
So would you put them on the cadaver list or you would not put them on?
We have put them on, like this patient got a cadaver transplant, he is sensitized. And we are trying to do a virtual before the transplant happens. So we try to get the donor sample as soon as the second apnea is done. So I get 6 hours till I do the HLA typing of the donor. I do the SAB of the recipient if it was not done. I do a virtual. And then I try to go ahead explaining to the family that we will do everything to prevent a rejection. But if there is a DSA, it may still harm you. And which is what happened in this patient.
History of sensitization is also very important. So if your CDC and flow cross-match is negative, it is very important to take if there is any history of sensitization. If one has had no transfusion, no pregnancies, no prior graft, and your CDC and flow cross-match is negative, you are safe to go ahead.
No, this is if DSAs are present.
Huh?
If DSAs are present,
that's what I'm saying. Even
but
if
then
there are,
sensitization means that there are antibodies.
right, but you may have on a test a DSA in absence of sensitization history, and if then your CDC and flow cross-match is negative, then there is a low chance that this DSA can affect your graft function. It's okay.
I think, but we have to explain to the family that this is the situation and we are taking
that
this.
obviously we have to, I mean, no,
We'll
you
have
can never
to
be
because-
100% sure.
Because, you know, like I said, the only answer ahead is the IgG subclassing and the C3 binding, which is done abroad. C1q or C3 binding, but it is available only on research use as of now. So I cannot buy the kits.
Thank you, Dr. Shruti. It's a great presentation, and I declare the session closed.
I thank Madam for extensive discussion on this topic. I request chairpersons and speakers to proceed backstage for the felicitation. Now, before we end the day, a last but a very important and a special session on financial freedom for all of us. So, I call upon Dr. Narendra Dedia, sir. He is Managing Director and works at Parak Hospital and Research Center, Ghatkopar, Mumbai. He is ex-professor and HOD of Department of Nephrology, Sir JJ Group of Hospitals and Grand Medical College, Mumbai. He has received Dr. Neni Dahijia Award, University of Missouri, Columbia, Best Citizen Award from Shri Gopinath Mundeji, and Achievement Award from Gujarat Government in 2006 from none other than our Modi ji. So I call upon Narendra Dedia sir for his last talk of the day. There also. Back and next.
Slides are on. Thank you very much, Aurangabad, and especially I will thank Dr. Sachin and the team who took care and we could make this is a viable. Before coming to the talk, are you really willing to make money? This will be more little bit interactive. I have hardly 15-20 minutes. If you allow me, I will talk whole day on the financial management. So, yes. So why don't you come front? Why are you sitting in the back? Please come front if possible. I think we want to make it little more interactive. Now, Sure. I think India has a great story. I will just summarize what is happening at present today. If you know, almost 4 lakh crore rupees has been removed by financial institute during last 1 year. Still, what happened to the stock market? It is going up only. Previously, we were dependent on the FII or the financial institute, but now the days have been changed. And that financial institute also realized, and last 1.5 months, they have put almost 46,000 crore rupees into the India. So this is just, I wanted to try and give you that what is the present situation. Friends, this decade is of India, and if you people remain away from the market, you will lose this golden opportunity of making money. I know usually the doctors, they think least about the money. अरे पैसे का बात नहीं करना है. It is not good. It is a below dignity and blah blah blah. But at the inside, everybody wants to make money. If you are making money very legitimately, officially, then what is the wrong? Then why don't you talk about that more freely? And I really thankful that at least this much 15-20 minutes time has been given. You know why I am talking about that India has a great story? There are so many other things. At present, India is one of the most stable, even politically. At present, there are more than 10 lakh demat account in the 10 crore demat account in the country. Now, which is a huge number, which was previously about a decade back almost 1 crore. So almost 10 times jump, and this becomes a huge thing. So there are so many things which are happening. There are some people from the Gujarat must have heard the name Morbi.
There is a small town, I am sure Bharat must be knowing Morbi. Anybody knows about the Morbi? Yeah, I am sure you must be knowing. Now Morbi is a very small town or a small place in a Gujarat, but today it is a 5th largest tiles exporting in the world. So that kind of export, now India's export has reached almost $100 billion a year in the last 1 year. So these are the huge things which is happening in the country, and probably the people, or we are not aware of the things, and we may probably then miss the opportunity available to us. As I told you, there are so many things about the present situation in India, and I can go and talk on that only. But we have a hardly 15 minutes to 20 minutes with us. So I will talk about the one particular point only right now, which probably, कोई बोलता है ना? Pardon?
The pointer is not working.
So I will come to the point, and कोई बोलेगा ना मुझे एक मंत्र दे दो पैसे कैसे बनाने का. So I will give you one single agenda, single point of understanding that how the money can be made very, very easily. Now, what are the problems in the medical profession and other professional? I am sure all of us have been knowing about that. Any doctor who becomes a specialist and start practicing, and any other professional who start practicing, almost there is a gap of 10 years. वो 25 साल में होता है, this happens at 35 years. So this 10 years gap is a huge gap. When you are 25-year-old, you are ready, energetic, you are ready to take a risk, you are ready to run around. 35 हो गया है, marriage हो गया है, एक बच्चा हो गया है. No, now you don't want to take a risk, you want to go slowly, you want to be more safer and so on. So, and those 10 years, it becomes a huge gap. I will tell you my example. My son wanted to be a doctor. I could luckily pursue him that don't become a doctor and don't come to the medical field. And today, he is a 31-year-old, his income is more than me. Now, only this is possible because he is in a different financial world and he can do what 24 hours, I cannot do 24 hours. So this was just problem reward. Now, what are the other common financial mistakes doctor is doing? That I will elaborate one, and then we are not going into that detail at present because we don't have a time. Over concentration of in the real estate. Majority of doctor either land liya, udhar flat liya, udhar kacha zameen liya, something. And I can tell you almost 90% of people sitting here, they must have blocked their money somewhere, they must have lost their money somewhere, they must have been kidhar somebody money has been got stuck and they are not able to get back. Inadequate, improper insurance, again that topic is a huge, we are not talking. Investment without planning. Again, this is a very, very simple thing. Majority of us, again, as I told you, we don't give importance to the investment. Some patient comes, some pehchan wala comes, some known to person comes, he says something and we invest with him. Please don't do that. Again, we are not going into that detail. Very myopic view about the tax planning. March ending, our passbook, slipbook, checkbook, सब हमारा accountant को we have sent to the CA, and only message we will give to the CA, see that कि tax कैसे कम भरना पड़े. But very rarely we talk about that, how we can do tax planning, how we can increase our capital, how we can enhance our business. Those things are more important when you talk to the CA rather than doing all these things. And majority of doctors are very comfortable with the cash income. Now we should get away with the cash income. Now this is only one point. Agenda is for the today's mantra for all of you. Have you heard about the compounding effect? How many people have heard about the compounding effect? Yeah, great. There are so many people. I am very, very happy to see that. Have you really practiced how the compounding effect work? Now this chart itself will show you that if just somebody is putting, I will just say 5,000 rupees for 25 years, that figure you just remember, at the end of 25 years, if 15% return comes, it becomes 1 crore 62 lakh rupees. 5,000 for 25 years. And if you put for the 30 years, it becomes 3.5 crore rupees. Now, 5,000 per month, 60,000 rupees per year, 30 years, you are putting 18 lakh rupees. 60,000 per year, 30 years, 18 lakh rupees. Compounding effect is 3.5 crore rupees. Just keep this in the mind, so this will help you for my next slide. So normally what you have to do, probably you don't have to do anything, and that is the most important part in the getting the passive income. Many people have burned their fingers or lost the money when they act on the tips. Somebody had told, put the money into the market. Somebody had told, bought this particular shares. What I will advise all of you, just if you really have that knowledge, if you really have that kind of interest, okay, equity is one of the best way to create the wealth for yourself. But if you don't have that things, you think that you cannot analyze the share, because it's not very, very simple thing. I will tell you again here the example of my daughter. She is also an equity analyst. She will say, I cannot 100% surely say about the particular stock, more than 25 or 50 stocks, yes, I can study, not more than that. Now, why I am telling you this? You study means when you go behind one particular stock, if you are convinced that particular stock, then you don't invest 5,000 or 10,000 or 5 lakh or 10 lakh. You have to invest a huge capacity, maybe 50 lakhs, a crore, or maybe that. Then the kind of return what you can get will be similar return you get. But how you get that particular conviction, or how you will be sure if you yourself is analyst and not you are dependent on somebody. If you are dependent on somebody, you are going to lose the money. So if you are dependent on somebody, then don't invest the direct equity, you go to the mutual fund. But if you have that kind of knowledge, or you still want to do something, then you can allocate the thing. You have 100 rupees, put 70 rupees in the mutual fund, put 10 rupees in a direct equity where you can understand or you may not understand, but then 3, 4, 5 good stocks where you can do the SIP. So this is very important that, and in those mutual fund, you need to do, just sit, patience, patience and patience. And what you have to allow, time is the factor, and which will take you that compounding effect. So time is the most important factor which will be helping you to make the money. So 98% of the time you don't have to do anything, just sit. Yeah, here again one point I will tell you, that if you have a cardiac problem, you will go to a good cardiologist. If you have a kidney problem, you will go to the good nephrologist, or so on. Similarly, you should have one good financial advisor. In wealth creation, two things are very important. One, good CA. CA is not your just available for the filing the returns or things. CA becomes, your chartered accountant can become an indirectly partner, whatever the practice or whatever the company you are running. Similarly, one good financial advisor will help you a lot to make a good money because there are so many ways are available, not only equity, not only mutual fund, not only debt fund, not only liquid fund, not only unlisted share. There are so many avenues are available which probably you may not be knowing. And again, one more example of personal. Now I'll tell you this, what I have learned, not the direct way I have learned. बोलते हैं मार खा खा के सीखे हैं. So that kind of learning what I had, but then possibly if whatever the knowledge I have today, if I had this knowledge of beginning of my practice, whatever the amount of wealth I have created today, I could have created at least 3 to 4x than whatever I have today. But not, I am extremely happy what we have done for myself. So important point is that good financial advisor is very important. Now example here I wanted to give. Almost 10 years back, you must have seen that Tamil Nadu Mercantile Bank was listed, I think Thursday. Few people in the stock market must have heard about that. Now that stock, unlisted, I had bought about 10 years back. That, how I bought the stock, my financial, at that time I didn't have that kind of knowledge what I am today. So we bought because kind of explanation my financial advisor told me, equity of TMB bank was 80 lakh rupees. And profit they were generating about 300 to 400 crores per year. And kind of huge dividend they used to give. So I said, such a thing is absolutely impossible. And we bought it. Huge amount of money, we got it in the dividend also. And we regularly used to bought the share. In fact, I went sometimes to the south to collect the share certificate. Those days still DMAT was not there. So you have to go there and collect the share certificate and get the things. How much time is there? Up. Okay. So continue. Fine. Thank you. So at least good that somebody is interested to make a money. Now I will try still more simpler things. So now come to the most important part which I wanted to tell you. Two-child theory or third-child theory. I'll give an example of Bharat because Bharat was 2 years senior to me. Bharat has 2 kids, right? Bharat, you should have a third kid. Everybody is laughing. Now I'll tell you the example why Bharat should have third kids. Now that theory I had put about almost 8 to 10 years back, and now I have changed that second child because most of the today's generation, they says one child is okay, or sometimes even they don't want one child also. So now third child theory, how it came, go back to that slide, 5,000. I'll ask Shruti, your wife becomes pregnant, then child's nursery, child's education, child's college, till child becomes 25 to 30, he is not going to make any money for himself, herself, or for the family. Right? Agreed, Bharat? So, how much money you will averagely spend for the child per month? Education भी आ गया, शादी भी आ गया उसका, pregnancy भी आ गया, उसके बाद holidays जाते, बारगांव जाते, सब everything you count and then average it out. Huh? Pardon? No. What, per month how much are we? 15,000, 20,000, 40,000, 50,000. I agree that everybody will have a different class, but average, at least we will say 25,000 per month. Where education and abroad education or whatever you say, everything is covered. 50,000. Huh? Okay, so he says 50,000, somebody will say 20,000, poor person. Go back to that slide. 5,000, 30 years, it becomes 3.5 half crore. 25,000, we will consider 25,000. तुम उसका फिर 50 कर लेना, so you will be more happy. So 25,000 per month for 30 years, sir कितना होंगे? 3.5 into 5 कर दो. Pardon? 17.5 crore, right? So if Bharat, you would have had third virtual child, where you put every month 25,000 for that child, virtual child, that child will have a 17.5 crore rupees, right? No, still beauty is there. You wait for that. If you have that third child with 17.5 crore rupees, your first two child will not leave you. अरे उसको लगेगा बाप के पास ये तीसरा भी चाइल्ड है जिसका वैल्यू इज 17.5 करोड़, हाउ कैन आई लीव बाप? Now that's the today's generation. That's what I told you. So that's the today's generation. People will think that they will have all three kids as a virtual kid. So that's a different story. So important is the compounding effect. So I wanted to tell you that compounding effect is beautiful, so simple, but majority of people don't want to follow because they don't get a kick in sitting and just not doing anything. Now, couple of simple things I will add. There are so many things here to probably we could have gone. Now, he will just give you the example of few slides that one particular stock, first few years, 3.5 years, no return, then gone up and then again dipped, and then no return for 3.5 years and then 200 times. So, stock market, you don't know when the things are going to move, but yes, you should have a patience and you should wait. There are so many mutual funds also where people have made the money. Here I will give you example of one of the few of mine also. Can you move the slide? Now this is again one simple example. You must have heard the story, the king had asked somebody, he was happy with the person who gave some good answers and what do you want? तो उसने बोला कि मुझे सर put a chest का चौपाई and start putting one rice granules in the first square and then in second ka double, then unka double, then double and then double. So how much it becomes at the end? He thought, oh, it was so simple, but probably he didn't had that kind of things that came at the end. So if you have a 1 million, somebody will tell you, I can give you 1 million. Or 1 penny which doubles every day. What you will prefer for 1 month? I'm sure since it's written, people will say 1 penny. Both are possible in the end, you get only one. So 1 penny at the end of 27th day crosses 1 million, on 28th day it becomes more. At the end you will have 4 million, and so you will be much having more than the 1 million. So this is just to explain the power of compounding. We are not going into this. So start making the investment as early as possible. These are the few things, funds which have grown almost 200 times. So, and I always say that though in my family also people, both son and daughter, they are in a financial world, but still I invest in mutual fund. And this Nippon India growth, previously it was a Reliant growth, it has given more than 20% return. Now more than 20% return, you show me the net return, that's which business will give you. People put the money, it's very rarely that you get the 20% net return. So still, and plus tax point of view also, till now it was a long-term capital gain was totally tax-free, now only 10%. So again, tax point of view also, it is one of the best thing to make money. But this is the important message for everybody, that if somebody thinks that investment is entertaining, then if you are having fun, probably you are not making money. So good investment is very, very boring because you don't have to do anything. So you have to have that kind of mental thought process that you have to just sit and don't do anything. So here there was one actual story that Amazon chairman once asked the Warren Buffett, and he had only said this, that money making is so simple, then why everybody is not making money? And his answer was very right, because nobody wants to get rich slow. Everybody wants to make money fast. And here I will tell you what happens, na? People who have invested in the real estate, they don't look at कि अभी कल उसका rate क्या हो गया. But people who have put the money into the stock or the mutual fund, next day only they will start looking at what is the rate. Or third day they will start calling their financial advisor. अरे वो तो चलता नहीं है. So because there is no day-to-day kick, people lose the money. And they try to change from one to another. Yeah, you might have to change, but if there is some enough valid reason, otherwise please don't change. Now here also important point again, that if your advisor explain you and you put the money right way, there is a huge way you can make a money. And then financial freedom will be very important, because if you have the financial freedom, you will have so many other things in the life. I think here somebody was talking to me on the way when I was coming from the airport, that majority of doctors, apart from doing their practice, they don't have any other hobby or any other speciality they have developed, though they have a talent, but they have not developed. So yes, this is things. Once you have a financial freedom, probably you will start developing that hobbies and start investing at the early age. If you invest at the early age, probably you will be making good money. I think I could just had conveyed one simple talk and simple message today: compounding effect. If you probably understood the compounding effect, you don't require to do anything. Just find out one good financial advisor and put your money, let your money grow by itself, and time factor will be the most important thing, and it will give you a great return. Thank you very much. And thank you, Sachin, that at least giving this opportunity for me to talk.
So I am no one to give permission. I took permission from our central body, and they were very happy to have you. And the enthusiasm of people suggested they allowed extra time for you. So thank you. This concludes all our scientific presentations. I am very happy to see the same number of people which were there 8 o'clock in the morning. Same number of people are there. There may be floating population, but so good attendance throughout makes us happy. Yesterday we requested all faculty to stick to time. I am also very happy. Apart from, I think, this last lecture which everyone wanted, we have been primarily on time. Everything was on time. So some more announcements. We immediately have a general body meeting that is in Vihara Hall, which is at the lobby. And after general body meeting, we have DJ night, banquet and dinner in this particular hall only. And along with delegate kit, most of you, or if you have collected, you must have received t-shirts. It is our request, if you can come to DJ night or the banquet dinner with that t-shirt. It's not compulsion. There may be some restrictions. Some people want to wear, or they want to wear something more fancy. It is your choice. But even if 20-30% people wear, it will create a good selfie moment for ISN West Zone Aurangabad. And anything else you want to add? Yeah.
So thank you everyone for this wonderful academic feast, and let's conclude this session.
Hello.